Good morning, everyone. I, Dr. Kavita Agarwal, along with my colleague Dr. Riju, welcome you all to the AOGD post-conference workshop organized in association with Foxy Family Welfare Committee with convener Dr. Mirnalini Mani and coordinator Dr. Shobha Gudi, who is the chairperson Foxy Family Welfare Committee. As we all know that the consequences of COVID-19 is not just limited to the infection, but sexual and reproductive health services are being affected, and these are particularly for the adolescents and the youth group which do need to have the access to the contraceptives. Foxy GCPR on COVID-19 has considered contraception and abortion services as the essential health services, and therefore they should be available 24/7 even in the COVID times. So I welcome you all to this post-conference workshop on tackling this unmet need for the services in times of COVID-19. Now I invite all the dignitaries, our guests of honor, Dr. Alpesh Gandhi, Dr. Ragini Agarwal, Dr. Mala Shirvasta, Dr. Shobha Gudi, Dr. Mirnalini Mani, and all the esteemed faculty to join us for the invocation song.
स्मरामि महागणपतिं मनसा स्मरामि महागणपतिं मनसा स्मरामि महागणपतिं मनसा स्मरामि वसिष्ठवामदेवादिवन्दितमहागणपतिं मनसा स्मरामि वसिष्ठवामदेवादिवन्दितमहागणपतिं.
I welcome you all to this workshop, and now I would like to invite Dr. Shobha Gudi ma'am and Dr. Mirnalini ma'am, who have worked for this workshop tirelessly. And I would now request Dr. Shobha ma'am to introduce the organizer, AOGD President, Dr. Mala Shirvastav ma'am. Ma'am, you are muted.
Thank you, Kavita and Riju. And that was a fantastic opening to a very, very interactive platform where we shall indeed discuss issues about unmet need in this complex area of service provision, that is family planning services. At the outset, I place on record my immense thanks to Dr. Mala Srivastav and her team, Dr. Khanika Jain, Dr. Mamta Dagar, of course, and my convener, Dr. Mrinalini Mani, for this fantastic opportunity. I thank Dr. Alpesh Gandhi, Dr. Meera Agnihotri, and other seniors in Foxy who have joined today, Dr. Ragini, Dr. Atul Ganatra, the vice presidents. Well, Dr. Mala Srivastav has become a very well-known figure now. And of course, in the AOGT, she does not require an introduction, but then it is my duty to place on record that she is a senior consultant professor at GRIP-MER, gynec endoscopic and robotic surgeon at Sri Gangaram Hospital, New Delhi. Of course, she has a very keen interest in oncology, endoscopic surgery, and robotic surgery, as her work profile is already showing. She is specially trained in these services at France. This year, she has been the president, and a very wonderful, successful year she has conducted. And I'm very proud to say that I was part of the first conference she conducted, and I was very honored that Dr. Alpesh gave me the opportunity to be the scientific chair for Surakshit Naritva, also based on a similar theme as today's workshop. And Dr. Mala supported us to the hilt in this conference. Thank you, Mala. Well, you have several accolades to your credit, but I can say that you are the ICOG Governing Council Member 2020, Zonal Chairperson for ISOPAR, also in ISCCP, several other platforms. good editorial experience also there. I can see several bodies. You have been the ex-president and secretary. Well, I now welcome you to say a few words to open this conference, and along with Dr. Alpesh and Dr. Ragini, the guests of honor, please do declare this workshop open. Please take the dais, Dr. Mala Srivastava. Thank you.
Thank you, Dr. Shobha, for your kind words. Good morning, everyone. On behalf of the organizing committee of the 42nd Annual Conference of AOGD and first e-conference, it's my privilege to be a part of this workshop on tackling unmet need for the family planning services in times of COVID-19. Nicely organized by Dr. Milanini Mani, a very active AOGD member, and Dr. Shobha Gudi, chairperson of the Family Welfare Committee of FOXI. It's my privilege and pleasure to welcome Dr. Alpesh Gandhi, who is the president of FOXI, a very active, innovative personality who had converted adversity into opportunity.
Kavita, can I ask to change the slide, please?
Yeah.
Yeah, thank you. Yes, Dr. Mala. Hello, is there any problem in connectivity? Yeah.
There's an issue with her net
Our Vice
connection
President
within the
Foxy,
hospital.
Yeah. Yeah. Yeah, we can hear you in between, Mala. Okay.
Her mic is muted.
Huh. Please unmute.
Okay.
Yeah.
Since when it is muted, I do not know.
Another 1 minute or so. Yeah.
So I take great honor to welcome Dr. Ragini Agarwal, our Vice President Foxy. Madam is a charming and very helping personality, always eager to help us in all the academic activities. I welcome Dr. Atul Ganatra, our Vice President Foxy, Dr. Ramani Devi, our Vice President Foxy, Dr. Basav Mukherjee, who is our Vice President elect of Foxy. We have galaxy of stars in this workshop. It's my honor to welcome Madam Dr. Meera Agnihotri, Dr. Chandravati, Dr. Usha Sharma, who are the teacher of teachers. I welcome Dr. Bharti Maheshwari, Chairperson MTP Committee of Foxy, Dr. Ben Bellows, who is our international faculty. And I also welcome Dr. MC Patel, who has lots of work done in medical legal aspects. I welcome Dr. Chandan Kachru, Dr. Charmila Ayaru, Dr. A.G. Radhika, and the star of the day, Dr. S.K. Sikdar from the ministry. I also welcome our own team, Dr. Kavita Agarwal, who is the young dynamic chairperson of the Infertility Committee of AOGD, Dr. Riju, who is joined all over the place from Pune. I welcome Dr. Neelam, Dr. Poonam, Dr. Alka Kuthe, Dr. Shushma Sinha, Dr. Kalpana Apte, Dr. Shaurabh, and Dr. Anita Rajoria. I welcome all the young PG students, residents, and young delegates for this workshop. And I wish this workshop a great success. Over to you, Dr. Shobha, Madam, for the day's proceedings.
Thank you, Mala. That is wonderful. Kavita, your turn.
Yeah. I would request Mala ma'am to kindly introduce a guest of honor, invite a guest of honor.
Yeah, she has done that. She has done that.
Then, okay.
Hmm.
Okay. I would request.
Yeah, we request all the guests of honor to stand by to
I would
actually
request a
conduct
guest.
Yeah.
Okay, ma'am, you say. I would request a guest of honor, Dr. Alpesh sir, Dr. Ragini Agarwal, and Dr. Mala Srivastava ma'am, and all the esteemed faculty to join us for the virtual lamp lightning.
Yes, thank you.
Sankurutvam kalyanam arogyam dhanasampadah Shubham kurutvam kalyanam arogyam dhanasampadah Shatrubuddhi vinashaya Deepajyotir namostute Deepajyotir namostute Shubham kurutvam kalyanam arogyam dhanasampadah Shubham kurutvam kalyanam arogyam dhanasampadah सम्पदः
Now, I would like to invite Dr. Riju, who is the fertility specialist and consultant gynecologist, Vasundhara Fertility Center, fellow in reproductive medicine, Bloom IVF, and had advanced training in embryology, Embryology Academy of Research and Training, to carry on with the academic session. Over to you, Dr. Riju.
Thank you so much, Dr.
Yeah.
Kavita, for the kind introduction, and a very good morning to all the esteemed faculties and delegates present in this virtual August gathering.
Yeah.
So with the permission
Riju,
of our...
yeah,
Yes,
Riju, just a minute. I would like the president, Dr. Alpesh Gandhi, and Dr. Ragini, who have also been the guests of honor, to formally declare the workshop open by saying a few words. Then you open the first session. That will go beautifully. Yes.
sure, ma'am.
Dr. Alpesh, please. Yeah.
Thank you, Dr. Mala, for the kind words, kind introduction. Today's guest of honor, Dr. Ragini Agrawal, Vice President Foxy, Mala Srivatsav, Dr. Atul Ganatra, Dr. Ramni Devi, Dr. Sobha Gudi, Dr. Basab, respected Madam Mira Agnihotri ji, teachers of teachers, all the esteemed faculties, dear friends, a very good morning to all of you. At the outset, I would like to thank Dr. Mala and team AOGD for inviting me for this workshop. I must congratulate AOGD for this annual conference and these important workshops. Foxy believes that reproduction is a woman's fundamental right. However, in our patriarchal society, we have taken this right away from her and put it in the hands of her husband, her family, and even the lawmakers. We believe that when a woman chooses to have a child, it should be her explicit choice. It is her right, it is her choice, and it is her decision. As a gynecologist, we wish to offer her this choice in a safe, risk-free manner, so she has control on her own life choices without having to resort to unsafe and dangerous practices. We all know as the pandemic spread, many countries implemented tough lockdowns, including India. And because of this, because of travel restrictions, and because of many other problems like unavailability of staff, less number of patients, lack of PP kits, so many reasons, many private clinics had shut down their services. There was disruption in supply chain for drugs, for medical abortions. So many things had happened. Now it is now restrictions are not so tough. Everything is now eased out. But at the same time, there will be some implications of this period, 3 to 4 months or 5 months at some places. And because of this, now we have to be more cautious, we have to be more active to provide safe services, remedial services to these women. Foxy is aware of its responsibility. I must congratulate AOGD and Safe Mother and Dr. Sobha Gudi for this workshop and continuously updating all our members. Dr. Sobha Gudi is very actively working. Her team of family planning, family welfare committee of Foxy is doing a lot of good work. I congratulate Dr. Sobha and her team for this good work in this difficult time of COVID-19. And what I want to say, I will discuss in my talk on
Yes.
Foxy's vision. So with
Yeah.
this, I wish grand success to this workshop. And once again, thank you very much for patient hearing. Thank you.
Thank you, sir. Dr. Ragini, please. You're muted, Dr. Ragini. You're muted. Yeah.
Ma'am, please unmute yourself. Yes.
Ma'am, you're not audible.
She has to chair the first session also. So, any technical help?
Dr. Ragini ma'am, kindly check your audio settings.
Yes, ma'am. Just the audio setting is required. Have you connected with any earphones or something like that, madam?
She is not plugged in the earphones, maybe. She's connected, but she is not plugged in.
I think your computer audio is muted.
Mhm. Yeah. Now you can unmute. Yeah. No,
Yes.
still muted. And now you're unmute. Yes.
Unmuted, yes.
Yeah.
Dr. Ragini, would you like to connect from your phone, ma'am, as you did the test with your phone? Will that
Yeah.
do?
No, she is unmuted now. No?
Not
No,
connected.
but
with
there's
your-
some problem with the speaker actually. I mean, the select a speaker, you just select the first option, speakers,
But
audio.
when she spoke in the morning, it was quite good actually. She spoke just as she joined, she spoke.
Precisely.
Mhm. Okay. Okay. So I think with I think
Hello.
yes,
Yes.
yes,
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 ma'am.
yes, Ragini.
So I'm so sorry. I don't know. I was talking to all of you and suddenly it has gone.
Yes.
Very good morning to all of you. And let me congratulate Dr. Mala and AOGT for a successful e-conference. Thanks Mrinalini, Shushma and Kavita for this invitation. Respected Meera Madam, Foxy President Dr. Alpesh, Dr. Shobha Gudi, all my co-VP, seniors, teachers and friends, and all delegates. We are here to discuss a very, very important topic of the contraception, which is, I consider, the best gift of the modern medicine to women for making her hold on possible when she has reproduced a child. Contraception awareness is still needed because there is a huge unmet need. And dear Shobha Gudi, Chairperson Foxy Contraception and Family Planning Committee is doing a wonderful job for that. And I hope and I know that convener Dr. Mrinalini Mani and co-convener Dr. Kavita and Dr. Shushma is going to present a wonderful academics to all of us. I will not stand between academics and you. Over to you all moderators. Thank you very much for this invitation. Please start your academic session. Thank you so much.
Thank you so much, Dr. Ragini ma'am, Dr. Alpesh Gandhi sir, Dr. Mala Srivastava ma'am for blessing and honoring us with your presence. And with your kind permission, I would like to start the first session. So to begin the first session, which is expanding the basket of choice, I would like to invite the chairpersons, Dr. Meera Agnihotri and Dr. Poonam Shivkumar. Dr. Meera Agnihotri is the Chairman, Ethics and Research, State Medical College and President of WWW Foundation. She is the advisor of Women Health Cell Ministry of Government of India and the recipient of prestigious Burrage, Stott and Chancellor's Gold Medals. She has innumerable awards and national and international contributions to her laurels. Very good morning and welcome to you, ma'am. Our next chairperson, Dr. Poonam Verma Shivkumar, is Professor. Can I have the next slide, please? is Professor and Head of Department of OBGY at MGIMS Sevagram, and she has received advanced training in SHRH from Sweden. She has clinical skills trainers training for EMOC. She's the principal investigator for PPH Bundle, a great academician with vital contribution in research and in national and international health guidelines. I welcome you, ma'am. So to begin the session, I request our chairperson, Dr. Poonam ma'am, to kindly introduce our first speaker, Dr. A.G. Radhika.
So a very good morning to all the Foxy officials, all my seniors, my colleagues and dear friends. It's my proud privilege to introduce Dr. Radhika. Dr. Radhika is consultant OBGY, University College of Medical Sciences, NGTB Hospital, Delhi. Dr. Radhika has held several positions, like she was member Cochrane Collaboration, she was member Campbell Collaboration, she was member South Asian Cochrane Network. So the whole Cochrane setup has been done by her. She has received several awards, ICOG Visiting Professor Award in 2019, Foxy Korean Award 2019, Foxy Best Paper Award, WHO Fellow Advanced Course on Monitoring and Evaluation in Health System. And she's been an expert reviewer, as we said, for Cochrane Collaboration for several organizations. She has n number of publications. So over to you, Dr. Radhika, for your presentation.
Thank you so much, Dr. Poonam, for the kind words. So a very good morning to all. It's a great pleasure to be here amongst all of you, and special thanks to Dr. Shobha, Dr. Mrinalini, and the entire team AOGD for having me here. So I'm going to address something extremely important. We as gynecologists keep talking about the contraceptives, but the public health aspect is extremely important, which I find Dr. Shobha ensures gets addressed at each podium. So I think it is extremely important today. We are all very familiar with the medical eligibility criteria. Now, the point is having the MEC is a great idea, but what is the implementation aspect? How many people are actually using it, and to what benefit it has been to our country specifically is what I'm going to address in the next few minutes. Now, a few words about the family planning services in India. Now, the India is one of the very big countries. We know diverse services are available, but then our family planning services started very early in 1952, and today we have free of cost public health services being provided by about nearly 2 lakh primary health centers, 6,000 secondary and 750 tertiary level centers. And the services are supported by a large pool of accredited private healthcare centers, and also the community health care workers, especially the ASHAs, who are nearly about 1 lakh today. They are the depot holders for contraceptives, and they are going very strong. Other than that, the nurses and certified ANMs in the peripheral health centers are allowed to prescribe spacing methods like IUCDs and injectables, including the OCPs and the condoms, as well as the emergency contraception. And the doctors are specifically trained to prescribe contraceptives as well as to undertake the surgical procedure, that is the sterilization procedures. Currently, the family planning has also been integrated into the RMNCH plus A strategy of the National Health Mission. Now, what is the reason for poor utilization? See, the country's statistics over the past so many years has not changed to the extent that we would like it to be. So what are the reasons? So I thought this was a good chart to basically project. So there could be, method related problems. There could be personal problems where there could be, lack of contraceptive knowledge, anxiety, misconceptions. Then there could be interpersonal problems that are important. Then partner related problem. And today we are basically going to also address the service related problem, that is the unavailability and the provider based problems that could be the reasons for the poor utilization of contraceptives. Now, what are the reasons, statistics for the unmet need in our country? So as you can well see, this has been taken from the Family Planning 2020 site. And this shows that from 2012 to 2020 today, the unmet need, between 2019 was 18.9. Today in 2020 is 18.6 for the married women for the modern contraceptives. And the satisfied women amongst the married women is 74.2 and 70, nearly the same. So what I'm trying to bring home is this figure 18.6, nearly 20%, has not changed between 2012 to 2020. So that is an important point to be noted. Even if you take 20% as a small figure, when you come to the numbers in our country, we all know how huge that number is. So a lot of work needs to be done. And another important point is majority of the contraceptives that are getting used today continue to be the sterilization. Now, this has also been reiterated by the NFHS 4 data, which says that the unmet need could be as high as 22.3 in Nagaland, or it could be as low as 4.6 at Andhra. That means there is a variation and the type of services that are being provided across the length and breadth of our country. Female sterilization continues to be the commonest contraceptive method, and nearly 56.5% of the current users reported that they were never told about the side effects of the current method. There is also evidence to state that the cafeteria approach of providing family planning services is not being implemented effectively, and this has been given out by none other than the Government of India in the Vision FP 2020 statement. Now, the medical eligibility criteria were published as early as 1996 by WHO, and it provides an up-to-date evidence-based recommendation for contraceptive use amongst the women with various medical conditions as well as the medically relevant characteristics. And it provides a guidance to the national guidelines to be adapted in the region-specific context as well as to the population. Now, this was the importance of MEC was brought out in this publication in 2017 in the current opinion Obs and Gynae, which says that over the past 20 years, MEC has become remarkably an influential document for the practitioners and policymakers in family planning. And it provides an up-to-date evidence-based recommendation for contraceptive for women with various medical conditions. So the fact that MEC is very important is well understood. The point is how much of it is actually getting implemented and utilized. So this was one study that I came across in the PLOS 1, and this was published as recently in 2019. This was the competency assessment of medical interns and nurses and documenting prevailing practices to provide FP services in teaching hospitals in 3 states. The point is that teaching medical colleges are treated as elite colleges, elite places for healthcare. We all know that. And they are placed at a much higher podium and a much higher level than rest of the services that are available for the country. So I kind of feel that probably they reflect the services and the knowledge being provided in rest of the country. But the results were astounding. So as you can find here, about 60% of the interns and 48% of the nurses knew more than 5 contraceptives that could be offered. Mind you, it is only 60% and 48% here. About 22% of the interns and 33.3% of the nurses respondents believed that contraceptives should not be given to married women coming alone. And almost equal number, 32% of the interns as well as the nurses, the interns, they felt that it was illegal to provide contraceptives to unmarried women. And nearly 43% of the interns and 70% of the nurses could not demonstrate the insertion of IUCD during the OSCE session in the of the study. And sorry about that. So majority were unaware of the new family planning methods like DMPA. Up to 86% of these children didn't know that DMPA has been introduced in the basket of choices in India. And equal number, 32% of each, could not they felt that FP services should not be offered to unmarried females coming alone, and it is illegal to provide, FP services to unmarried people. Only 1 out of 6 medical colleges had the MEC wheel. And as these were not used in the routine family planning practices in most of the medical colleges, students had not observed these during their training period, and this was attributed as one of the major reasons for their inability to demonstrate the MEC wheel during the OSCE session. Now, how is it in other countries? What was the impact of the UK MEC criteria in their country? So this was a publication that was there in 2013. And what they found was there was a definite reduction in the percentage of higher risk combined hormonal contraceptive users. It was reduced by 0.8%. However, many women with category 3 or 4 continue to be prescribed this medication. Apparently, it looks that the implementation is, a challenge in major part of the world. As per the Ministry of Health guidelines report that was published again in 2015-16, cafeteria approach of providing FP services is not being implemented effectively. Uninformed choices lead to unintended pregnancies over lower contraceptive acceptance and sterilization rates, and improved quality of care has a positive correlation with sustained contraceptive use. It is not a one-time prescription. Compliance and continuity of usage is extremely important. We all appreciate and understand that. And the same facts have been reiterated by the MOHFW report. And the family planning training is mainly implemented in the public healthcare delivery systems, and medical colleges are generally left out. And I myself feel that many times, because there are so many training programs that are available for the primary and the secondary healthcare system. When it comes to the medical colleges, there is always shortage of hands. Majority of the times, the residents, we try to send them, but so many times the focus shifts to the emergency care, and it is so difficult to get the hands out for undergoing training in the various aspects, including family planning. So this aspect continues to remain the same. And there is also the provider bias due to incentivization and misinformed decision. Now, just to give a brief idea of what I mean out of this, see, we are currently having, I am the principal investigator for an ICMR funded study regarding the use of PPIUCD and centchromin, which has been recently added to the basket of choices by the family welfare. Now, what is happening is, because of the COVID situation, the number of women who are reporting to our hospital, primarily because ours has become a COVID only hospital, the family planning program has actually shut down. So what we are trying to do is, we are trying to reach to the women, to the peripheries through the ASHA workers. So today, when I tell the ASHA worker to, consider giving centchromin to the women, she says, I don't get paid for it. What is my payment? What is my advantage if I do that? Because I get paid for IUCD and the postpartum IUCD, as well as sterilization. So that was something that really woke me up to this fact that incentivization, while it has its benefits, also has its other problems. So there are people who don't want IUCD. So combined contraceptives, yes, Malayan, they do have, but then we do have non-hormonal methods, and application of the MEC criteria to such circumstances is extremely important. And I think incentivization has to be, again thought about. And of course, misinformed decisions, we are aware of this. Personal biases are important. Like I have already highlighted how people feel about the unmarried women who are coming alone. Today, times have changed. We no longer live in a society where marriage is the norm. Live-in relationships have become more common than it used to be earlier. So, people become judgmental. Even such a lady asking questions is frowned upon. And we have a highly varied group of people who form the part of our network. They come from various as part of our society, the ASHA, ANM, and going on to the specialists. So there are huge personal biases at every level. Training, district level uptake is good. Medical colleges generally tend to keep aloof. Other than this, non-availability, sometimes we have faced this. There could be some place there is a break in the supply chain. There could be non-availability of contraceptives from the basket of choices. And incentivization, I just now said how sometimes it can be a challenge. So what could be the solution? Of course, we start with training. Training with equal emphasis to everybody at all levels. Probably it has to be, made mandatory. When we give the extension to the residents, family planning should also be, part of that. The signatures that this person has undergone family planning training at least for 15 days or whatever. It has to be inculcated into the curriculum of the medical student as well as the nursing students. The MEC criteria has to be adequately emphasized upon. It is already there, but further emphasis, further focus, because the teachers have to be themselves convinced. Core competency curriculum, by that I mean actually dealing with the cases. It has to be role playing, and they have to have hands-on experience on the practical aspects of it. And of course, retraining is extremely important through innovative teaching techniques. Other measures, instituting changes in the aesthetics and format of the guidance. The MEC wheel and the MEC app are already there, but it is also important to translate to the local languages, tailoring guidance to the level of service provider. I am really not sure how many of the ASHA workers are happy to use a small wheel. I find some of them are middle-aged, some of them are quite old, and they could be finding it difficult to read the wheel. Most of them are not comfortable with the app. Addition of specific counseling messages and clarification, and changes or additions to medical counseling recommendation should also be provided. See, it is extremely extensive. We know MEC criteria over the years have changed, but there are still some conditions where there are certain gray areas. So probably the local specialist, the local consultant could, do hand holding. There has to be some sort of reachability, and the people have to feel free to be able to provide that kind of advice to the workers. So dissemination, the same thing was also reiterated in this paper, which said that the providers may benefit from additional guidance on how to counsel women with characteristics medical condition where medical eligibility criteria do not clearly rule out a rule in a method. So probably a little change, addition, or probably mentoring is what is required for better implementation of the program. So understanding this, the WHO Family Planning Accelerator project was started. It was started in the umbrella project, followed by the preparatory phase, and today we are into the accelerator project. So the beginnings came in 2015. So the aim is to accelerate uptake and implementation of the evidence-based guidelines, improve the quality of contraceptive information, service provision and uptake by the adolescents. Special emphasis on the adolescents is today the focus. Increase the uptake in the postpartum and post-abortal contraceptives, increase the availability of the range of contraceptives, and of course, improve the quality of care in the FP services. So WHO, they are very good at this, and they have very clearly, given out the implementation drivers. So this could be at the provider level, organizational level, or the leadership level. Majority, I have already spoken in the language that we are used to speaking, but this is basically the administrative language to the same. So provider layer, qualified providers who are providing technically competent and evidence-based care. Organizational level, basically accessibility of the availability of the contraceptives, organization and efficiency of care, appropriate facilities, and good supply chain. Leadership, supportive and proactive policymakers and program manager. So I would like to conclude to say that MEC is an important evidence-based tool that which needs to be mastered by healthcare workers for appropriate implementation. Optimization of its use may be best achieved by additional strategies to the existing ones. So increase the availability of the wheel as well as the app, translation to local languages, additional information on gray areas of clinical and contextual relevance, training and retraining at all levels of the healthcare staff. So thank you very much for a patient listening. So this is the wheel and this is the app that could be downloaded by us in the mobile. So thank you so much.
Thank you, Dr. Radhika. This was really indeed a very good presentation, very informative. And now over to Dr. Meera, please.
Ragini, it was a wonderful presentation. I just wanted to tell the audience and the person who has presented that there are a lot big changes. I believe Alpesh will agree with me. Since after this MCI dissolves and the next meeting is being held, lot big changes have occurred. One of the most important changes I can tell you, ASHA workers are working till the periphery, I agree. Regarding the medical colleges, I just want to tell and add to the existing knowledge of ours that DGO or MS, whatever examination is being held, you see a specific number of the marks are being fed for so-called social welfare and family planning matter. And if you fail in that, you have to get marks for that. You are working for ICMR, I agree with you. In our also, we are conducting lot many things as a research project in the ICMR. So few things I want to add. Dr. Goody will agree with me. Totally ban on sterilization technique in camps. Chaddar bichha ke you are doing the operations in the health center. They are totally banned. Dr. Goody and myself have presented a big panel discussion on it, condemning that Supreme Court has banned it. It should be done in an institution or a place where everything is available. So that part is gone. Second change is that, as you are telling, in medical college teaching, whether it is DGO or it is MS, it has become a part and parcel of the education and treatment. You cannot pass unless you show that how do you insert the copper T, how do you take it out, then the new things which are, what is synchroman, how is it working. In our table, whether it is any of the examination, including you see research and papers, we keep a separate table for family planning. And they have to answer it. If they are not able to answer, out. So that is one change. Third change which is occurring, Dr. Ragini, that we are changing the pattern of education. पहले बुला करके सबको ट्रेनिंग करा करते थे, कैंप्स करते, नो दैट इज नॉट देयर. अब हम लोग डायनेमिक लेक्चर फॉलोड बाय ट्रेनिंग, जैसे हम लोग फॉरसेप लगाना सिखा रहे हैं, सिजेरियन करना सिखा रहे हैं, ऐसे ही दे विल बी कॉल्ड बैच वाइज. Suppose few doctors are placed before me, my resident, junior resident, senior resident. So they will be trained separately and they are examined, re-examined. And before they get a SR, they are asked questions. Goody, you remember that we have conducted a very good panel discussion and we have informed to the audience that family planning in masses is not conducted now. Camp लगा दिया और उसमें सब कोई कर रहे हैं, it is not being done. So my submission is that lot of changes are going on. MCI is dissolved and the next setup which has come very recently, they are changing, revolutionary changes are there and they are working according to the guidelines of WHO. So it was a wonderful presentation and I assure you that medical colleges are not deprived of it. Rather their standard of education as regards the family planning services are escalating day by day and it is becoming more tough for our students. So it's not that they are. ASHA workers are working very nicely. We go to the camps and ASHA workers are learning. I agree that 20% are still not knowing very many things. ये जो आपने क्वेश्चन बताया मनी वाला, ये हटाया जा रहा है कि हमने इतना स्टरलाइजेशन कराया तो इतना पैसा मिला, ये करा तो ये करा, अगर हमने सेंट्रोमन नहीं लगाया तो पैसा नहीं मिला. This part is being deleted very soon. Thank you very much for an excellent presentation. It will go a long way for all the audience. Thank you very much.
Thank you, ma'am.
Thank you so much, ma'am. There has been a slight change in the sequence of the speakers. So I request our chairperson, Dr. Poonam ma'am, to kindly introduce our next speaker, Dr. Basab Mukherjee.
So it's my privilege actually to introduce Dr. Basab Mukherjee. He's a known figure in Foxy and he's actually known for his politeness and his behavior. He did his medical schooling from CMC Vellore. He's FIGO Coordinator South Asia for Safe Abortion Committee, Clinical Examiner for RCOG examinations in India, Member Governing Council ICOG 2015 to 20, Honorary Secretary, Bengal Ops and Gynae Society in 19. Young Gynecologist Award was received by him in 2011 at Taipei. Past chair Family Welfare Committee, and so he's here because he's really good in it. For Foxy, Vice President elect Foxy 21-22 and Organizing Secretary ICOG 22. Welcome, Dr. Basab Mukherjee. The stage is all yours.
Thank you very much, Dr. Poonam, for the kind introduction. My greetings, my respect to our chairpersons, and thank you, AOGD, for this opportunity. I'm sorry for barging in because I have a surgery waiting, and that's the reason why this slight change in schedule. So from a wonderful talk of Dr. Radhika on public health, I'm going to move a little bit towards the clinical aspects of contraception in this talk on updates in contraception. So over the next 10 to 12 minutes, I'll be taking you through some updates, not everything, but some updates in the oral pills, combined oral contraceptive pills, EC, vaginal rings, implants, injectables, IUDs, barriers, and others. And of course, a lot of these updates have not yet come in India. They're in a global perspective, but it's good to hear them because at some time, possibly they may come to India and possibly we may have some variants of the ones which we are discussing today. So the newer estrogens is one of the new things which we talk about in updates. From time immemorial, we have been using ethinyl estradiol as the estrogen component in the combined oral contraceptive pills. But it is recently, over the last decade, that people have understood that we can move towards other estrogens which are more lipid friendly and have less effect on the liver. And that is where comes in estradiol valerate and estratol. The estradiol valerate now is available in India over the last 4 to 5 years. It comes with a combination of Dienogest, and there is a quadriphasic pill which was initially marketed for AUB, but also we use it for other purposes too, and that is the combination which is there. Estratol is not yet available in India. It is native estrogen with selective action in tissues. So it's called E4. It's come in combination with drospirenone 3 mg or levonorgestrel 150 micrograms, and we need to watch the space to see how estratol comes in. It is the estrogen which is synthesized in the fetal liver, and it is supposed to be much more friendlier metabolically than the ethinyl estradiol, and is making ways into combined oral contraceptive. Then we also have the extended cycle oral contraceptives, the LNG and ethinyl estradiol combination. We know that there are women who do not want periods every month, either for social reasons or for medical reasons, where there is either endometriosis could be one of the problems, or they just do not want to have the hassle of a monthly bleed. And so for them, there is options of an extended cycle oral pills, which could come as seasonal, seasonic, low seasonic, and liberal. So depending on the brand, there are 84 tablets of continuous hormone administration, and then could be 7 placebo pills or low dose estrogen pills, as in seasonic. And liberal, you have a continuous thing for 365 days. So these are some of the extended cycle pills. Again, some of it, one brand has come to India, to my knowledge, but there are other things which are still on the way. But this is something, again, a lot of people may argue that you may not need something like this. You can just use the normal pills which you have and use them continuously for a long time. But yes, this has a little less of medication, and this is one option which women can use. Then the new thing in the block would be the Ulipristal. We last 1 year from the time one of the companies, or 2 companies, I think, in India have launched it. Then there is the buzz about Ulipristal as a new emergency contraceptive pill and its advantages over levonorgestrel. So there's a 5-day advantage, a 120-hour window here, which is over the 72-hour window, which we get for the levonorgestrel pill. There is fair amount of evidence to suggest that Ulipristal works better in overweight and obese women. There is a unique effect on the dominant follicle where it can delay the rupturing or it can replace the dominant follicle by another follicle, hence preventing pregnancy when used in the mid-cycle phase, where it works much better than levonorgestrel. So ulipristal has definite advantages. Yes, it is costlier, but at the same time, for one medicine pill, possibly it is definitely a good alternative to levonorgestrel, which is there. Coming to the vaginal rings, the ring which we are more familiar with, which we have been using over the last few years, has been NuvaRing. And NuvaRing has etonorgestrel and ethinyl estradiol, is replaced monthly. But there's another ring which has been approved by the FDA in 2018, which is called Anovera, which is not there in India, of course, which has a combination of segesterone and acetate and ethinyl estradiol. And the same ring can be used for 13 cycles. It needs to be removed each time after 3 weeks, washed, kept, and then again replaced after a week. So the FDA approval came in 2018. This is the picture which you're seeing is of the Anovera, which obviously is more thicker than the NuvaRing, which is more thinner in size. Coming a little to the implants, I think most of us have been exposed over the last couple of decades to the ICMR almost never-ending study of the implants, which has come out. I think some of it has come out of the Implanon, and by the time the study results came up, the Implanon NXT also has come up. So Implanon, or the single rod implant, is now the one which is in vogue, or one which is still in India. It's still catching up with in the contraceptive basket as a useful member or an alternative to other implants, other contraceptive choices. It's got etonorgestrel and ethylene vinyl acetate. The half-life is 25 hours and a bioavailability of 94 to 99%, which releases 65, 40, and 35 micrograms per year for 3 years. What is the NXT about? The NXT is radioic. It's got a preloaded single-use applicator, which makes it different, and you can adjust the depth of under the skin at which you are placing it. What's new in injectables? What is relatively new in injectables? Again, it's been there for nearly 2 decades, but it's come to India now. Is DMPS subcute. So that is 104 mg, and the biggest. It is very similar to the DMPA IM injections, which we use 150 mg. Efficacy wise, mechanism of action wise, and the interval at which it needs to be administered. So the FDA approval came in 2004. The biggest thing about subcute injection, it is self-administration, which has been shown to be one of, again, a big jump in women's choices for contraception, where after the first dose, possibly after an initial evaluation, a woman does not need to come to the medical practitioner, the healthcare provider at every instance. So that is one big thing about the DMPS subcute. Coming to the LNG IUS variants, there are a lot of LNG IUS available all over the globe. In India, we still have alternatives to the initial brand of Mirena, which had come forward. We have at least 5 to 6 other different companies which have brought LNG IUS, but they're essentially the same thing. But at the same time, there are other brands which are available in USA, especially where you have thinner Mirenas, where there are thinner and especially slim Mirenas, you could say, or having a lower dose of the hormones, which are some used in nulliparous women and some for cost benefit. So here there is a Mirena, Liletta or Levocert, and Skyla or Jadis, as it is named on both sides of the Atlantic. So there's 13.5 mg LNG there and 52 LNG in the others. And the Mirena is for 5 years, but the other ones we see is for 3 years. And this is how they look. Paragard, of course, is the copper T380A, which we use here. That's again one of the most effective forms of contraception, one of the most underutilized, of course. Dr. Radhika highlighted in her talk some of the reasons why IUCD is not that popular in India, and now postpartum IUCD seems to give that thrust which was missing in the last 5-6 years. And here you see some pictures of Mirena with Skyla and the other ones. Coming to condoms or barriers, what's new here? Well, there are a few fancy condoms which have come in the market over the last decade. So Galactic Cap is one, which you can see on the top right corner. where there is an adhesive base and there is a cap which only covers the glans and not the entire shaft of the penis. There's a hydrogel, which you see in the top, in the lower left corner, right corner, where it's a hydrogel where the two gentlemen are stretching it. You can see that. It's funded by the Gates Foundation and it's supposed to feel very natural, and that's what it's about. Origami is the one which you can see as a sort of a spiral, the one on the middle lower part. Actually, so that's folded instead of rolled. And the F2C condom is the one which you see on the top, and then is the Kaya diaphragm, which is something new, which is easy to use diaphragm, FDA approved in 2015. These are some of the new barrier methods which are there, just trying to make it more natural and trying to get more things. So technology is playing a very important part in contraception, not just for the awareness of contraception, not just for the FAQs, not just to having follow-ups and clarification, but also as a method. So for all the fertility awareness-based methods nowadays have been worked into technology. So there was some time ago when we used to have the ring, which was by Georgetown University for fertility awareness, where you used to, the cycle beats, which you used to take the ring and adjust it. But now a lot of this can be done on the apps, and now smartphones being available all over the country and all over the globe. It is very important, like apps are used enormously to track fertility. A lot has been promoted by the infertility business, where you want to know when to try for a pregnancy, and you just have to turn it around and say when not to try if you don't want to become pregnant. So there are apps like Fertility Friend, Glow, Clue, Kindara, and there's a Natural Cycles, which is an app which has been approved by FDA as a digital form of contraception. So if you follow that app on a day-to-day basis, you know when roughly the ovulation takes place, when you're having menstruation, when intercourse is permissible or has least risk, and when it is needed, you have to have protection. So there's a DOT app also, which is much more than a period tracker. And again, same way, you can find out which are the days which you're most fertile in a cycle and which are the days where intercourse ideally should be avoided or something has to be used. What's lying in the future? The fertility chip, the microchip. Again, this is all in experimental stage, but you do not know. We love to see science fiction movies, and this may not be far away, where a chip can be implanted under your skin and to release drugs inside the body. There could be any drugs, and then if it's a hormone drug, it could be acting as a contraception too. So and these chips could be remotely controlled, so you don't need to, so you can control them outside your body, and it's inserted inside your body. And this is, so it may seem a little bit like Star Wars now, but it may not be that far. Then the Risug is something which is relatively new. It hasn't caught up, as most of the male contraception hasn't caught up beyond the condoms. So here is how it works. It is an injectable, temporary, reversible vasectomy is the word which is used. It has been discovered in India, and that is how. And here you have injections at the vas deferens which coat to the wall, and the sperms, when they come in contact, are rendered immotile. And this is something which has been tried, but more research has to be done. What about contraceptive jewelry? Could this be the next method of birth control? Who knows? Women love to wear jewelry, especially Indian women. And so if you have jewelry with some hormone patches attached to it, maybe they could have some effect on your contraception in days to come. We don't know. So the pearls from this talk, making it simple, is mankind will never be satisfied, and innovations will continue to take place in all sectors, including healthcare. The field of contraception is no different, and we will see as time goes, there's nothing ideal, and various variants and new changes will keep on happening. It is important for us as members of the healthcare providers to adopt change, embrace new technology, and integrate it in our clinical practice. We need to stay updated, know what's happening in our country, in the world, to offer our women the best choices. I thank AOGD again, congratulate Dr. Mala Srivastav and the president and her team for the excellent work that AOGD is doing in the FOXY circuits. And thank you very much for this opportunity.
Thank you, Dr. Basab. Indeed, it was a very updated presentation. Thank you so much. And with now, as you must be knowing, that there are a lot of non-surgical permanent foams also coming up, which will reduce significantly the tubal ligation complications. We have a number of things to discuss with you, but we'll do that in our expert comment. And now I give it the dais should be for Dr. Meera to introduce the other speakers, please. Thank you.
Thank you, Ragini. Thank you very much. I am really very grateful to Mrilagini Mani Shubha Gudi, Chairperson of the Family Welfare Committee. The unmet need of the family planning, everybody knows. I'm very happy that on this occasion I have to introduce one very dynamic girl, Kavita Agarwal, who has got lot of interest in any field apart from this, and she is ready to participate in any of the meetings. Kavita is a young, dynamic Foxian, Assistant Professor, Safdarjung Hospital, Vice President, IMA, South Delhi branch. She is Chairperson of the Infertility Subcommittee of AOGD. She is National Corresponding Editor of none other than the Foxy Journal. She has organizing Joint Secretary of Foxy BUH 2017 conference, which we all have attended. She has got more than 50 publications in various national and international journals. And the most important thing about it, she is winner of the Foxy Kamini Rao Oration Award and Foxy NTP Award. And she is a Foxy Corion Award, which is a very prestigious award. She has got 17 papers, posters, and a lovely profile before me. But one thing I can tell you that she has got keen interest in all the fields of obstetrics and gynecology, and the one which she is going to present is one which is concerned, which is a concern of the national interest and the interest of WHO also. So the mic is yours, Kavita. I adore her, I like her, and she's a very hardworking personality. I always find whatever work is given to her, she will present it very nicely. Basab, your presentation was very good. Okay.
Thank you, ma'am, for the kind introduction. Are my slides visible?
Yes. Yes,
Okay.
Kavita, visible.
Okay, thank you, ma'am. So I'll be talking on ensuring reach to the unreached in the public sector. So for that, first we should know what are the unreached populations with us. So if we see here in the public health indicators, they show clearly that the rural population is there, which has total unmet need more than the urban. And if we see the current use of any modern method, it is lower in the rural population. So this is one population which is unreached. It is still an unrealized dream of the healthcare system to be able to reach the last mile, especially women in the rural areas, distant and remote parts of the country. But other than the rural areas, we also have some other groups which are unreached. So coming to this group, that is early marriage. It continues to be the norm in India, and the National Family Health Survey 4, it showed that more than half of the currently married women were in the age group of 15 to 19 years. And this is the largest group with unmet contraceptive need, as only 15% of them, they used a contraceptive method. So this is, we have as another group which has to be reached. Coming to the next is the childbearing. In continuous surveys from NFHS 1, if you see to NFHS 4, the fertility rate peaks at the age of 20 to 24. So again, this is another unreached group. So starting from the rural area, then 15 to 19 years, then 20 to 24 years. These are all the unreached groups. So today we will try to ensure reaching to these unreached groups. Now, if I see the NFHS 4, it shows that these age groups, the unmet need for contraception is very high. In fact, the highest in these groups, that is more than 20%. And the unmet need for spacing methods is 19% in 15 to 19 years and 15% in 20 to 24 years. So now we reach to another aspect, that is there is an unmet need for the spacing methods compared to the limiting methods. If we see the NFHS 4, it showed that the total unmet need, it has remained constant from NFHS 3 to NFHS 4. That is around 13%, out of which 6% was the unmet need for spacing method. So it means there has been no change. So there is an existing gap between a woman's desired fertility and her ability to access the family planning methods and services. So as we see here, female sterilization, a terminal method, has remained the mainstay at the national program since many, many years. And in the recent survey, it was also found that again, it was 36% who were having the female sterilization, but rest of the methods, if we see, are lagging behind. And the majority of the women, 77% who underwent sterilization, has not used any method before they were sterilized. So this is the point we have to note, that although we have identified the unreached groups, but we have to also identify the methods which we are going to promote more. Where are we lacking? That is the spacing methods. Sterilization has been similar since many years, but we are not able to pick up in the spacing methods. And as a result, you can see here that 11% of the births that took place within 18 months, 27% within 24 months, and more than 50% of the births occurred within 3 years of the previous birth. So this data ensures us the need for enhancing access to the reversible contraceptive methods to improve the birth spacing. So between 1998 to 1999 and 2015-16, there was a minimal increase in the proportion of couples using oral contraceptives, IUCDs, and condoms. These data indicate that program has not so far succeeded in providing these contraceptives to delay the first birth, to space the subsequent births, and nor has it been able to reach the men. Now, after identifying one thing, that is, we need to introduce the spacing methods more, we also have another group of contraception which is gaining importance, that is the emergency contraception. So if we see in the recent survey, 4% had mistimed, that it wanted the pregnancy later, and 5% did not want pregnancy when it occurred. So what was the result? That is 9%, around 30,000 women had unwanted or unplanned pregnancy, leading to abortions. And as we all know that around 8% of maternal deaths are attributed to these unsafe abortions. So we have to keep in mind about the emergency contraception, which is a low cost, simple, effective technology and can provide a backup method for the women to use within the first few days of unprotected intercourse to prevent unwanted pregnancies. Emergency contraception, if we see, has gained quite good in the private health sector. That is, it is more than 75% of the women. But if we see in the public health sector, it is lagging behind. So it is the time for the public sector to institute a program for providing emergency contraception. Its strategy should be to reach the poor, rural women who do not have access to the private sector. Now, as we know that we have to more concentrate on emergency contraception, on the spacing practices, and we also have seen that it is the youth to which we have to more focus on. But again, we have certain challenges coming to us when we try to reach these unreached things. So the main challenges what we have seen are access is a barrier to use, especially in the rural areas. 85% of the women were found to be aware of OCPs, but use was only 14%. The second is correct information about the product, which plays a very big role. So now what can be the strategies so that we can overcome these challenges and also decrease the unmet need of these focused groups. The first is operationalizing the concept of informed contraceptive choice. Although this is the program which has been running from a long time, but yes, it again needs to be emphasized to provide a cafeteria approach with a basket of choices. Improving quality of services to provide contraceptive choice, need to strengthen infrastructure, human resource management, accountability, and governance of the public health system, as these are the major impediments to the effective delivery of the health and family health services. The other strategy can be focusing on India's poorly performing states. So if we see in the currently married women aged 15 to 49 years, the unmet need in Manipur is very high. And if we come to Andhra Pradesh, it is very less. So focus on India's poorly performing states. So this can also be used, that is mass media publicity, which we have used in WPD 2020. The other strategy is expanding the basket of contraceptive choices. And we have seen that when we expanded the basket of contraceptive choices by adding Chaya and Antra to our basket, and we have seen a real increase, we have seen a very good response to it. So if you see here, NFHS 4 has reported that by the increase of 1 addition in the basket of choices, see how the prevalence rate, the contraceptive acceptance has increased. The other strategy can be educate the users and service providers. So as I told in the challenge, that the patient needs to be given the correct information. Patient has to be removed from the myths. These myths have to be cleared. But what is the strategy for that? The strategy is, first we need to educate the service providers. Whatever new introduced method is there, in every aspect, it has to be told to the service providers so that the users will be benefited. They will have better, more accurate access to the information surrounding various contraceptive options, enabling them to make more informed choices. Then empowering community health workers. We have availability of 0.9 million ASHA workers. We have community health workers. We have counselors. We should make use of them. This is a critical contribution of the ASHA as the frontline warrior. So empowering community health care workers to ensure better quality of care, that is capacity building, training of these frontline workers, and there needs to be greater emphasis on the trainings around the community mobilization. Now, after this, when they have gained the knowledge about the product, the new contraceptive options, they should also know how to counsel the woman. So in counseling, listening is more important. Then only you can understand what are the queries, what are the myths in the woman who is sitting in front of you, and you will be able to give a proper information. To listen and listen more to what the women want. And then starts your counseling for contraceptive technologies, address the myths and the misconceptions prevailing in the communities regarding the modern methods of contraception. What we discuss becomes the priority. So don't leave any moment to discuss. If the patient is waiting outside in the antenatal OPD, please go and discuss. This was the result seen when it was seen that family planning, you see, is discussed very minimal with the patients. This was the survey and seen that family planning discussion was very less with the patients. So we get various opportunities to discuss with the couples and provide them the basic information about all the benefits of the family planning, all the contraceptive choices we have. Maybe it is a postnatal ward, waiting list in the ANC OPD, immunization clinic, dietitian, we can do health talks, we can do group discussions. So these are all very important opportunities for us where we can help the patient. Postpartum contraception should be provided prior to discharge from the maternity service. Every delivered patient should be counseled. Enhancing the male engagement in the family planning. As when I started the talk and also by the earlier speakers, they have very well highlighted the sterilization, the female sterilization is forming the major chunk. But the other modern contraceptive methods and also the male contribution is very less. So if we see vasectomy and condoms, the two methods of contraception which are available to men, they account for only about 12% in the overall modern contraceptive prevalence rate. So family planning initiatives should address the beliefs, myths, and misconceptions surrounding contraceptive services as well as other barriers that refrain the active male participation. Now coming to the one more challenge with us these days, that is the COVID-19 pandemic. In this situation, how to ensure the reach to the unreached? UNFPA has conclusively proved that if the lockdown continues for more than 6 months, it can severely disrupt the health services. And 47 million women in the low and middle income countries may not be able to access modern contraceptives, resulting in 7 million unintended pregnancies. And as you all know, unintended pregnancies lead to unsafe abortion and adding to the maternal morbidity. So it's under the FOXY GCPR that contraception and safe abortion should be made an essential health services and should be given 24/7. So what can we do in this situation now? How to reach to the unreached? Ensure uninterrupted adequate supply. Supply is also very important. You should have that thing, otherwise the patients, they stop using it. So ensure uninterrupted adequate supply. Postpartum and post-abortal IUCD insertions to continue via the telehealth consults and limited face-to-face consultations wherever possible. So there are some services which can be managed remotely by the telemedicine. That is the contraceptive options counseling. If the patient has just now delivered, so by telemedicine, you can teach her about the lactational amenorrhea method, the simplest method. She does not, no need for any prescription, no need to go to any doctor, just a remote contraceptive options counseling. Remote initiation of progesterone only pills, DMPA, CHC, remote quick start of contraception following emergency contraception use, refill contraception prescriptions without in-person assessment, delay blood pressure assessment in women less than age 35, initiating CHC if no contraindications to use, extended IUD use, and defer the routine long-acting reversible contraception removal or exchanges. These self-care interventions, we can help the patients by the telemedicine to introduce these self-care interventions, and lactational amenorrhea method also holds quite good importance. So to conclude, access to family planning and other reproductive health services to the rural population, public sector, there is an urgent need to address the problem of high unmet contraceptive need among our youth, the youth couples, especially among the married adolescents. Provide quality of care consisting of its crucial components such as access to the contraceptive choices, quality counseling services, information and follow-ups. Expand the basket of family planning choices, greater male participation as active partners and responsibility bearers can certainly ensure increased use of contraception. It's a time to focus serious attention on strengthening the health system's capacity to reach the unreached and to improve the service quality. Improving the quality and reach of family planning services will not only address the issue of unmet contraceptive need, but thereby accelerate the fertility reduction. It will also have a definitely impact on our Millennium Developmental Goals on mortalities. Thank you.
Thank you very much. It was a wonderful presentation, Kavita. In a very short time, you have covered almost everything. As Ragini has asked, we will keep the questions in the end, I believe. Ragini, questions are to be kept in the end, I believe.
Yes, ma'am.
Okay. So If anything is to be asked, it should be kept in the chat box. Or it was a wonderful presentation. Once again, I congratulate Kavita. Very nicely presented. Everybody has understood everything. And the unmet need, age of marriage, is in the governing council of the government of India. Age of marriage, Dr. Our Alpesh Gandhi must be aware. The age of marriage is to be decided by the Prime Minister very soon. And that may be one of the important landmarks in our decision. Should I present the second presenter?
Yes, ma'am. Please.
Okay. Dr. Mrinalini, everybody knows her. She's a very soft-spoken head of the Department of the Obstetrics and Gynecology, Government Hospital, GNCT of Delhi. She is President, Delhi Gynecological Forum, Southwest. She is member of the FOXY Breast Committee, FOXY Family Welfare Committee. She is a committee member of the Reproductive Endocrinology of AOGD and multidisciplinary. She is a national assessor of the quality and mentor Lakshya program, providing key teaching and management support to the various maternal public health organized programs and capacity building health related activities of the state. She is on the editorial panel of PPMPL, Journal of Obstetrics Research and Practice. She is faculty of the e-learning family medicine. She is guest speaker to many of the CMEs, workshop, conferences, and conducted lot many. She has got many credits to her credit. She was awarded as a Wonder Foxian Award in 2019. I congratulate her. A State of the District Award for contribution towards promoting quality and maternity health promotion, contraceptive services, and women's reproductive health. Foxy Arogya Ambassador Certificate of Appreciation was given to her. With these words, we have got a wonderful speaker today. I invite her for her presentation. The dais is yours, madam.
Thank you very much, ma'am, for those kind words. I'll be sharing my slides. I think my slides are visible now.
Yeah.
So now much has been said about contraception and by the speakers before me. And here I would be my job has been made easier. There's a lot of overlapping. And we are running behind schedule. So I would be cutting short my talk and will be focusing on the counseling. So my task today is to make counseling easier, the fine tuning of counseling, the critical factor in our family welfare services. We know that we have a lot of expanded basket, but still there are a lot of unmet need is there, and somehow it is not trickling down to the actual use by the consumer, the client, what we have. She's not a patient, she's a client. So we have a lot of high-risk births, and as highlighted by Dr. Kavita earlier, we have too many early births, they are too close, and there are still too many births, more than 22.8 were there, more than 3 still in our country. Thus, the need is to have effective counseling, and the stepping stone to a pre-pregnancy care is the need of the hour. Contraceptive basket, as has been mentioned earlier, it has expanded, and Government of India has recently introduced in the last 2-3 years, the MPA injection and Centroman were added to the basket. The basket was made more attractive, and the wrappings were changed so that the clients are more attracted towards it, and they feel that the quality of the product coming to the government hospital is no less. Now, a word about what happens in the counseling. The client is confused. She has so many methods available. And in the present scenario of internet technology available, people take the information themselves and they think they are as good as doctors. And when they come, there are a lot of questions and queries to ask us. And they really don't know what to choose, which one to choose. So it's our job to make her aware about her reproductive rights and counsel her properly, explain her about the basket available, the journal methods, and we do a method-specific counseling, and then help her make the right choice, and more importantly, informed choice. She should be freely choose among the options available with correct and accurate information and to maintain the privacy of our client. The key to success is counseling. And this is very dear to my heart. I tell my residents, I tell my nursing staff, my paramedical staff everywhere, please counsel whenever you get the opportunity. And recently, the government of Delhi has done a lot regarding this counseling. The DFW had taken initiative and they had counseled and trained all our ICTC, PPTC counselors, and also our dietitians, RTI, STI counselors, all the male staff were trained, and we were urged to make male windows everywhere, wherever possible in our hospitals. And this has gone a long way in increasing the rate of acceptance in the hospitals. Counseling in a family planning setting. So it has to be client-centered counseling, and then we need to have a shared decision making. A counselor basically, they arrive at a mutually acceptable decision as per the client's needs. Mind you, as per the client's need, we don't have to impose our decisions on her. We have to engage the client in non-judgmental manner. And as mentioned by Dr. Kavita, listen to her. Listening is the main technique. And if you listen properly by using this approach, you hit the bullseye. The components of effective family planning counseling are communication skills, ability to generate trust in the client, and give a proper information about the methods available. So we all know the qualities of good counselor. One should have a good sound technical knowledge and objectively answer all the questions. One has to be empathic and a good listener and a patient listener. So we have to establish trust. Very important is our communication. How do we communicate with the client? The verbal communication and the non-verbal communication which we have. And the client should feel that we are paying attention. Most of the time, what happens in our clinics, mostly in the public sector, what we see is a patient comes to us, a client comes to us, she's asking something. Doctors sometimes are busy on the phone, they're doing some file works, and they're not giving her undivided attention. And we don't listen to her, we don't talk to her. Unless we talk to her, motivate her, know her problems, what do? This is not about solving the problem of a client or pressurizing her, imposing our beliefs, or is neither an interrogation on the client. This is a big no. We should be following what is the gather approach as been advocated by the government of India also. We have to greet, ask, tell, help, and explain her. I needn't go into details. Everyone knows what we have to do. More importantly is asking her, what is her problem? This is where we lack. We just don't ask her beliefs and her preferences. We are busy telling her about the choices. But first comes the asking part. And then we have to assist her to make a choice and provide the supplies the very same day. If you're not able to prevent the supplies, what happens is we have lost an opportunity. She goes back home, never to return back again. And not the least important, not the last, the most important part is we have to explain, review, and reiterate the methods, whether she's understood, when to come back, follow up. We have to review her. And more importantly, is she satisfied with the services we have done and about our counseling? If any doubt, we ask her to return back to us. So first and foremost, what we do is we have to identify her pregnancy intentions. What exactly does she want? Does she want to become pregnant, or she's not sure or no? If she wants a pregnancy, yes, fine. Then she wants it now or when, how many, is she planning a spacing or not? All these questions have to be asked. If she says yes, she's not sure, or she wants contraception, 4 important questions are to be asked. Is she breastfeeding an infant under 6 months of age? Does she have a cooperative partner? What method she has in mind? And whether any method which she used, she could not tolerate. So communication is the key skill here. Questions have to be open-ended questions. They cannot be answered by yes or no responses. They should not be closed. We have to be open, listening. Please spend some time here. This will go a long way in continuation of the method. If we are in a hurry and we do not wait and pause for 2 minutes, we are losing a precious opportunity. And we will be losing this patient only for her not to come back again or follow up and continue the method. We have to affirm. We have to ask her for her specific decision and thank her for whatever information she has given us, and reflect upon that information and repeat back to the client so that she understands, yes, I am interested and somebody is listening to her. And believe me, most of these ladies who come to us, particularly in a government sector, they are just waiting to somebody to listen to them, hear to them, and listen to their problems and take out a solution. You just give one ear and they will come pouring out with their grievances and their problems, and they will be very happy with you. And then you summarize, repeat back the client key pieces of the conversation so that she registers. And then after that, we come to the introduction of the basket, which has been told by my previous speakers. And more importantly is, if she has any problems, we should not hurry up. We should stop there, clarify her doubts. And these charts, all of us must have under our tables in the hospitals so that we can explain them about the efficacy of the methods, the different methods available, how long they are, how effective they are. This is a WHO chart which has compares efficacy. This chart is displayed in most of the hospitals in the government, and this should be there in the private sector as well. And this can be used by our peripheral workers also to reiterate the method, and preferably be made in the local languages. And these are some of the charts again, which tell us about the efficacy, effect options available, and the side effects, and when to return to fertility. But despite all that, there may be many obstacles. We have to ask her, she may not believe that she needs a contraception today, or she may be scared of the potential side effects, or her partner may not be interested. Because most of the time we see the decision about the family is made not by the women, nor by the husband, but the mother-in-law, elders in the family. So we have to take them into confidence. But at the same time, there are rewards of counseling the patient properly, and we can tell them about the safety of the methods. The non-contraceptive benefits can be told to them, benefits to the lady herself, to the baby, and to the family, it can be told. And we have to weigh them. If we want to accomplish our goals have to be smart. They have to be very specific and timely. We have to, and they should be attainable goals. And we have to fit into her criteria about and take care of her beliefs and her preferences. So we have to motivate the client for the contraception. With perfect use of contraception, we can give her all these options. Best case scenario is she chooses the method. And the worst case scenario, she chooses nothing. No need to get disheartened. Call her again. Again, reiterate her, it's fine. She can go back, discuss with her partner, discuss with the elders in the family, and she can come back with them. We can even invite them. And ideally is to do a couple-based counseling. Couple counseling goes a long way in using the methods, and we can reduce the male also to be an active partner in here. So we review the methods, whatever she has, we summarize the conversation and see her pregnancy goals and develop a follow-up plan. Then we provide her at the same day. That is very important. Again, I'm saying provide the same day, reinforce understanding, remind her about the side effects, reasons to return, and the side effects, arrange for a follow-up, resupply referrals, and also give dual protection for STI, HIV prevention. And if she desires EC, do offer that. And no, we have different groups which come to us, and they all have different needs, like adolescent. We have to reach out to all these, and adolescent have different reasons, and people coming after childbirth, post-abortal, like Dr. Kavita mentioned, they all have differently to be counseled. And the technical working group from WHO has stated that after a live birth, it is recommended that next pregnancy should be at least 24 months apart. And we see our babies are coming out too soon. And after a miscarriage or an MTP, at least 6 months gap should be there. But alas, we see people don't opt for contraception. They come back next month or 2 months later. And young women, we should wait till she's 18 years of age. And as ma'am was mentioning, we are soon going to increase the age of marriage of our young girls. And adolescents, they are at a different class apart. They have their poor perception and skills to develop about evaluate the consequences, and they have difficulty in discussing contraception with their partners, and they delay in accessing the services because of the taboos associated. So they need holistic care, these group of people. And not only about contraception, we have to go beyond sexual reproduction and should include basic anatomy and physiology to them, tell them about the menstrual cycles, physiology of pregnancy, effectiveness of the contraception, and prevention of STIs. So young people deserve non-judgmental and respectful care. So we have to use the language which they understand, and we have to address their fears and misinformation. And more importantly, we can use social media and smartphone use because they are very apt at that. We have to be smart, become smart ourselves. So counseling for the men also needs a greater role here. And if the men is not there, we can give the pamphlets or information to our female clients so that they can take it home and discuss with their spouses and maybe call them next month with them. So family planning counseling needs for postpartum women, as been told, they need effective contraception for adequate birth and spacing. We can tell them the benefits of LAM and EBF, and also integrate this with the maternal, newborn, and child health services. And this is one window of opportunity which we should never miss. And fortunately, in our government sector, this has been a backbone, and most of the hospitals in Delhi are now very effectively providing postpartum IUCD and Centroman, that is Chaya, which is there in the supply. And some have reached up to the rate of 70 to 80% coverage is there. And the average of Delhi is about 37% coverage in postpartum, which is steadily increasing. And we have to also to balance the harms caused by certain contraceptives, and we have to see whether we support breastfeeding, and also have to see whether to have to explain to her the rapid return to the fertility. And postpartum contraception timing, as I told, should be immediate initiation should be there, and delayed initiation could be there. But we have seen that 35% of women do not return for follow-up visits. So it is the immediate initiation postpartum which is the most effective, and the lady should be got hold there only. Now, post-abortal women, there are no complications, give it immediately, and she can use all the methods. Any method can be used to her. If there are complications, so we have to ensure her, trust her, respect her judgment, and counsel her for delaying sterilization or IUCD insertion or whatever method she uses. So integrating emergency treatment and family planning is a must in our family welfare departments, as has been told by earlier speakers. This is woefully, sadly lacking in our public sector, and we need to ramp this up. And also, cultural and gender roles and family planning go hand in hand. So the provider, the counselor has to be aware what should we do and how to go about it. And who can provide these counseling services? Whole plethora of our workers, right from our field workers late to the specialists, can be providing these services. So regarding the ethical principles involved in family planning services, there should be full participation, right of accountability is there, non-discrimination, empowerment, and it has to be linked to the standards. It's a legal obligation of the government to uphold human rights consistent with standards set by international human rights bodies and mechanisms. And India is a signatory to that. So what happens in COVID times now? And a lot has been talked about it. In COVID times, we have seen that a lot of information came out, and patient people were denied their rights because of the lockdown. So we had a lot of studies, and MCH services were the worst hit, and the reproductive rights were denied to this female. And because of lockdown, we had a lot of problems. Lockdowns were there, access were denied, and a lot of studies came out that how many million women, 49 million women with unmet needs would be there, and it is impacting the protecting and impacting the health of a women. Not only contraception, even the pregnant ladies had a lot of difficulties. A lot of guidelines came around from FIGO, RCOG, and the American College, and even FOXY. We were one of the first federations to come out with a contraception and safe abortion guidelines as an invention should be available 24/7. And during these challenging times, our field workers were our backbone. Right, as it is, we had a very strong backup in the government sector for all of our field workers who were delivering our MCH services and other geriatric services. We took help of these, and they were involved in the surveillance of COVID from door-to-door surveys. So we took this opportunity to deliver the contraceptives as well and follow up these women. And if they were using some methods, to reiterate to them and explain to them and take this window of opportunity to help them. And this really proved a big help to our ladies. And new communication strategies were thought of, the media was taken help of, and out-of-the-box ideas were taken for this out-of-the-box problem which has hit us, and we never thought that we would see a pandemic in our lifetime. Telehealth for counseling and screening, Dr. Kavita has dealt with it, so I will not go into details of that. And additional information and counseling was to be provided regarding consistent condom use, effectiveness of extended use, emergency contraception, optimizing the access was there, and multi-month prescriptions can be given. We can use DMPA-SC subcutaneous, which is available. Sign-up-press in some of the places can be used. Long-carb to be preferred. And we want, of course, we want to safeguard our healthcare personnel as well. So we want a limited direct contact An advanced prescription can be given, especially emergency contraceptives. And consideration for postpartum women, we must not miss this window of opportunity. We have to counsel her, counsel regarding LARC, sterilization. Well, she's going on a section. We can provide her sterilization along with that, or if you want a PPS, we can do that. I'm about to finish, just two slides more. And then we have to reiterate about the lactational amenorrhea method. And additionally, the barriers have to be taken care of, supply chains need to be maintained, and proper PP to our staff has to be given. Every cloud has a silver lining. So this is an opportunity where we can counsel about the grace period for different methods. If she is using a LARC, we can tell her, fine, you needn't get it removed. You can continue for some more time. And if she is missed on her MPA injection, fine, you have a 4 weeks window period. So we can counsel her that regarding that. And this is how we have went about counseling in our hospital. In the labor rooms, we took the opportunity, OPDs, and these are the guards were counseled to counsel the further other, and all these different methodologies were used. A lot of slogans and everything. We had WPD, so there was a lot of activity in the hospital. Everyone was involved in counseling of this. Success isn't number and type of contraception. It is ensuring knowledge, opportunity, and a positive experience. It's all about making the right choice at the right time and being responsible for a bright future. Mind you, effective counseling is just hand-holding. We have to hand-hold and then let the client walk freely with her own free mind. At the end, a counselor can take comfort in knowing that they have cared for the lady during a very significant time of her life, and then can remind themselves, as JFK said, one person can make a difference and everyone should try. And I can be that person, you can be that person. Thank you very much.
Hello.
Thank you very much.
Thank you very much for a wonderful presentation. Everybody has understood the importance of counseling. Add one word to it, it should be a counseling of the family. It's a counseling of the family more important, because if you suggest a copper tea and the mother-in-law says that no, this copper tea is going to your brain, then it may just cancel out whatever you have taught. So it is the counseling of the family also. Yeah. Whenever you get opportunity, you carry it out. Thank you very much. We are very short of time. So just put the questions into the chat box and it will be dealt in the end, as I am advised by Goody and all other persons. Is that right? Okay. Thank you very much. Thank you very much for making me a part of this wonderful program. I really enjoyed every bit of it. It has added a lot of knowledge and perseverance for Dr. Alpesh Gandhi. Thank you very much for just being head of such a big thing. Thank you very much once again.
Dr. Poonam's conclusions, please. Dr. Poonam, unmute yourself.
Few key comments. All these speakers have spoken very well. Number one is that Dr. Sikdar has been in family planning since long. We have worked together and there are several guidelines he has taken out. I suggest that those guidelines should be propagated, circulated and converted into local language so that it can reach to the Ashas so that they can follow that. Dr. Alpesh has written very beautiful, his team has done very beautiful duties here. We must ensure that it goes to every society. It is converted into local languages again. That's one suggestion. Second is that we have to have a family planning counseling booklet, which I think Dr. Shobha, you're working on it. And please send it to every society. Let us all follow that. Also, we have to request government, as Dr. Sikdar is there today, that we must have a counselor in the medical colleges and district hospitals, because counselors are not there and it's very difficult in a medical college where 220 patients are waiting outside. The residents and the senior consultants talk to the patient about family planning. Correct. It's very, very important that we have counselors. So it's a high recommendation from all the medical colleges and district hospitals that they should be provided with the counselors. Eye care clinic has to be promoted, and the difference what we have seen in Sevagram is remarkable. Because this clinic has changed the scenario here. The condoms which were not being taken up almost 70% condoms have been taken up in these 3 months. So I think it's very important. Last but not the least is DMPA subcutaneous. See, we have to expand our basket. It's very limited thing what government is providing. And you can't have two choices, one for rural and one for urban. The rural women are also equally, they have right to get all the choices. So this is my high recommendation that these things, eye care clinic, the circulation of guidelines, looking into it that one has counselor. These are my strong recommendations.
Thank you very much. Yes. We thank you, Meera ma'am, your blessings. And we have always wanted you to be a part of our program with your volume of work in this sector. And thank you, Dr. Poonam. Your words are like really pearls, and we shall kind of make full use. Now, Riju, quickly take us to the session next, because the president and the international speaker are waiting. Thank you.
Speakers and chairpersons for the wonderful session. I now request Dr. Kavita to take forward the workshop, please.
Thank you, Dr. Raju. I would like to thank all the chairpersons of the first session for their valuable inputs. So now we move on to the most awaited session of today, that is the keynote addresses. So moving forward, leveraging partnerships for better implementation of family planning services. To start this session, I would request Dr. Shobha Gudi to introduce the chairperson, Dr. Chandravati ma'am.
Yeah, thank you, Kavita. Dr. Chandravati doesn't need any introduction to the August gathering and the faculty lineup today, but then we have to pay our respects to this senior selfless Foxian, this crusader for women's health, and a person who has stood by what is right for decades together. She is the living example of quality care for women, and also very high ethical standards. From what I have heard of Madam, words cannot describe what a beautiful professional life she has led and how exemplary she is. Well, at present, Madam is Emeritus OB-GYN at KG Medical College, Lucknow, proprietor of Krishna Medical Center, her own setup, trustee of the Educational Foundation Krishna, secretary of WHEEL, patron Indian College of Maternity and Child Health, Nachi, Logs, and several others. In the past, she has had a very illustrious career as a teacher, also featured strongly in the ICOG and in the Journal Committee. And of course, Madam has been awarded several, glories. Amongst them is Lifetime Achievement and Indian Fertility Society Management Award from them. And then, of course, Padma Shri, Dr. Raj Baveja Lifetime Achievement Award, and IOG Dr. Satyapal Lifetime Achievement Award. Well, Madam, I now invite you to be the chair for the keynote addresses. Who else to be introduced? Dr. Kavita?
Ma'am, Dr. Atul.
Yeah, so Dr. Atul Ganatra, the Vice President Foxy, I think he has not been able to join because of her clinical commitment. And I do sincerely apologize for the delay today. Probably that has what has made him unavailable for our session. We regret your absence. Dr. Atul has been highly instrumental and he has worked shoulder to shoulder with Dr. Alpesh Gandhi, as have the other vice presidents. Can I have the next chairperson, or yes?
Dr. Ragini.
Who has to introduce her? Me only?
Okay.
Mrinalini, can you do the honor, and then we can request Dr. Chandravati to introduce Dr. Alpesh Gandhi. Mrinalini, can you please welcome Dr. Ragini?
Well, Dr. Ragini, madam. She's a dear friend and
okay, your voice is not coming out well.
It's okay now, ma'am. Now you hear me?
No, it's not clear, ma'am.
I think
yeah, Mrinalini, I will take it forward. No problem. Ragini is the dynamic vice president of Foxy 2020, and do as I might, I always end up in addressing her in her first name, because though she is senior to me, I feel she's so youthful, and she has kind of revolutionized how to appear energetic at all times. She is the founder of the Gurgaon Society, which has got a very intense work profile today, a very highly performing society, founder, president of her OB-GYN, president-elect of Aesthetic and Regenerative Society India, and the president of Indian Academy of Cosmetic Dermatology and Gynecology. I welcome you, Dr. Ragini, also to chair the session for this keynote addresses. Without further delay, Chandravati ma'am, I request you to introduce the illustrious president, Dr. Alpesh Gandhi.
Thank you, Dr. Goody, for your kind words and wonderful going session and very informative. I'm really glued to the session. It's my proud privilege to introduce none other than the
Ragini,
dynamic.
Chandravati ma'am is there, Ragini.
Okay. I thought you told me.
No, Chandravati ma'am.
Okay.
You will be
Okay.
introducing Dr.
So
Ben Bellows, the international speaker. Chandravati ma'am, we are waiting to hear from you, ma'am. Dr. Chandravati?
No, my net is giving some trouble, but I'll just introduce Alpesh. I hope I'm audible.
You're audible very well. You're audible very well. Very
It is
well.
a pleasure to introduce Alpesh. Okay, so
Can you see the slide, madam? Madam, can you see the slide?
I think it's gone offline.
Hello? You're mute.
चंद्रा जी म्यूट, आप अनम्यूट करो. Chandra ji, are you there?
Ma'am, I think she is logged out. Ma'am will be logging in again. She's trying to log in again, I suppose.
Can I have support from the technical team?
She's logged in. Ma'am, please unmute yourself. Chandravati ma'am, please unmute yourself.
I think there's some network problem.
So Ragini can introduce, no problem.
Yes, Dr. Ragini, please go ahead because there is a delay now.
Hello.
Yeah.
Hello. Am I audible?
Yes, you're audible. Yeah.
So to introduce Dr. Alpesh, I don't need any slide to introduce him because really he doesn't need any introduction. But two things are very clear, which is coming up. His vision is something to be really followed, appreciated, and to be replicated. And what he has given in this difficult time of COVID, it is literally marvelous, and he has reached to each and every society and joined by so many people. That is really remarkable. We all know he is the person behind SDU and ICU for the obstetrics purpose in India, and he's honored with the honorary FRCOG and many other accolades. And the most prominent is the first organization to come with the COVID GCPR and the registry. Over to Dr. Alpesh for his deliberation.
Thank you, Dr. Ragini, for the kind words, generous introduction. Respected Chairperson, Dr. Chandravati ji, a great inspiration to all of us. Chairperson, Dr. Ragini, and Dr. Atul, our dynamic vice presidents.
Alpesh, sorry I could not introduce you. My net was giving me trouble, but I know you have been introduced properly. So I'm here to listen to you. Thank you.
Thank you, madam.
Thank you, madam.
My net is giving some.
No problem, madam. You are here. That is great. Yeah.
Madam, your presence is a lot to us. Thank you, madam. So I am going to speak on Fox's vision. I will not go in detail of scientific detail because we have eminent faculties and a very good scientific program prepared by Dr. Sobha and AOGD. So it is really interesting to attend all the talks. I will not go in detail of scientific details. I would like to speak about what Foxy has done, and I would like to speak about Foxy's vision. I would like to, as we all know that Foxy is one of the largest federation of any medical specialty across the world with 38,000 practicing obstetricians and gynecologists all over India. So we have a very good strength. And with this great strength, if we decide something, I think we are able to do it. Our primary mission is to reduce maternal mortality and neonatal mortality and morbidity in India. And we all know that unsafe abortion and unintended pregnancy is one of the cause of a very important cause of maternal mortality. Foxy endorses, advocates, supports sexual and reproductive health and rights of girls and women of our country. As you know, the theme for this year is safety first, safety for Indian women and Foxians. And again, for the safety of Indian women, unintended pregnancy, early marriages, unsafe abortions, all are very responsible. So for their safety, we require to manage all these problems. On 28th February, Foxy has called a meeting at Delhi of all the policy stakeholders of Foxy, authorities of Ministry of Health and Family Welfare, Government of India, and NGOs working for women's health care. And we have a very brainstorming sessions. We came out with certain conclusions, certain policies. Here, Dr. Ajay Khira has inaugurated the conference and the session, and we have a wonderful roundtable discussions on very important 5 issues: sexuality education for the teens, Foxy Eye Care, integrated contraceptive approach across reproductive age through contraception clinic, postpartum contraception, when to begin the counseling and how to improve uptake, different acts governing SRH practices in India, and ensuring universal access to high impact comprehensive abortion care services. We have invited experts of respective fields for their opinions, and at the end we came out with consensus statements which are prepared and which we are going to upload on our website for the reference of all of you. It is nicely prepared by Dr. Sobha Gudi. And for the public awareness also, we had walkathon and public forum on youth talk during the conference. We have many policy statements regarding contraceptives and regarding safe abortions. I will not go in detail of all this, but I would like to bring 2-3 policy statements here. Regarding the long-acting injectable progestins, Foxy recognizes the scientific evidence supporting the use of long-acting injectable progestogens as a safe, effective, reversible long-acting method of contraception. The advantages of long-acting injectable progestogens are that they are highly effective, safe, long-acting, and easy to administer and easy to use method of contraception. A feasible option when estrogen-containing contraceptives are not favored or medically contraindicated, with no adverse effects on lactation. For women, they provide autonomy and choice with privacy about their use, easily maintained, and it's a reversible method. And Foxy believes that long-acting Injectable progestogens are an important component of the contraceptive choices, which should be available to the women of our country through both private and public sector. We have our policy statement on contraceptive implants. Foxy endorses contraceptive implants as an effective, reliable, long-term method of contraception. It is an alternative for women who prefer not to think about birth control every day, every week, or every month, and has an effectiveness independent of user behavior. As there are subdermal implants, the training of the provider is very essential, and technique of insertion, all the simple needs to be learned by providers before they attempt for the first time. The training also enables the provider to counsel women on the benefits and side effects associated with implant use to select appropriate users and correct time of insertion. Foxy believes that implants are a promising, effective method of contraception, and that should be available as an option for contraception. Foxy recognizes the right of a woman to determine the pregnancy beyond, to terminate the pregnancy beyond 20 weeks when there exist abnormalities that are either incompatible with life or would require major medical or surgical intervention to survive. These terminations should be done for specific medical reasons. And Foxy is happy to see that government has also accepted Foxy's recommendation for the MTP beyond 22 weeks. This year, Foxy has conducted interesting survey on age of marriage and pregnancy, because as Madam Miraji has just mentioned, discussed, that government is also, and our PM, Honorable PM, is also going to declare policy very soon. Foxy has also conducted interesting study, and for the first time we have a very big study. 2,911 gynecologists gave their opinion. Usually when we are conducting such studies, we are getting opinion from 1,000 gynecologists, but this time we have nearly reached to nearly 3,000 gynecologists opinion. So it is a very, very important recommendation for the government of India. What according to you should be the minimum age of marriage for females in India, and 65.9% are of opinion for 21 years. But the significant thing is 86%, total 86% of our members are of opinion that it should be above the age of 20 years of minimum, or minimum 20 years. What according to you should be the minimum age of marriage for males in India? This was the second question in the survey. And again, we can say 75% of our members opine that it should be equal to or minimum 23 years or more than 23 years for males. What according to you is the ideal age of Indian female for the first pregnancy? We all are very much concerned for the early teenage pregnancy, early marriages. The purpose of this study is to address all these issues. And according to our members, the ideal age of Indian female for the first pregnancy, we can see here that 95%, 96% members are of opinion that it should be about 20 years. There are two groups, 32% of opinion of 20 to 23, and 62.7 are of opinion that it should be 23 to 27, and some are of opinion of 27 to 30 years. But we can say only 1 or 2% of the members were of opinion that it can be below 20 years. So this is a very, very significant. 99% of the members were of opinion that it should be, first pregnancy should be above 20 years. Do you think in India certain minimum investigations like blood group, thalassemia, HIV of a couple should be made mandatory before marriage? And this question is also of very, very significant. This also provide premarital counseling, premarital investigations, and of course This will also lead to pre-conceptional counseling, and this will give us an important opportunity for counseling with the couple before their marriage and immediately after their marriage. And here we can counsel with the about the pregnancy and the role of contraception. So look, according to our members, again here we can see 85.5% of our members are of opinion that in India, certain minimum investigation of a couple should be made mandatory before marriage. So this is a very, very important suggestion, recommendation to Government of India. Foxy is very prompt and proactively working for COVID-19, taking comprehensive measures. We have started to work from the second week of March. Before lockdown was introduced on 24th of March, and we published our first advisory on 17th of the March and second advisory on 28th March. And in our advisory, we foresee the problems quite well in time. Within 4 days, when we published the second advisory, in both the advisory we advise our members to continue essential maternity services, and we also advise them to continue time-sensitive services like 18 to 20 week scan, MTP, and contraceptive services. And in second advisory, we also advise them for the use of telemedicine. Actually, Foxy and Physician Association are the two associations who have recommended you to make telemedicine official, legal in our country during the meeting, video conference meeting with our Honorable Prime Minister, which was called on 24th of the March. We also advise our members to train medical, paramedical staff members in infection prevention, including correct hand hygiene, usage of mask, and social distancing. And we also, as discussed, we came out with the Foxy's GCPR on pregnancy with COVID-19 on 29th March, and Foxy was one of the first organization of India, not only in India, in the Southern Eastern Asian countries, to come out with the guidelines, and which has helped so many practicing gynecologists across Suffolk region. And in this guidelines, we recommended to continue the important health services, maternity services, contraceptive and family planning services, and abortion services. And not only that, we also guide them how we can provide these services and how we can take safety measures for safety of our members and healthcare providers. And we describe different levels of the care and different level of the different types of PPE required for the different levels of the care, and how to donning and how to do doffing. Everything was beautifully explained in this GCPR. And we also came out with a GCPR on perinatal and neonatal management with Neonatology Forum of India and Indian Pediatric Association. So we came out with 3 guidelines during this period. Foxy's vision, of course, is reproduction. We believe that reproduction is a woman's fundamental right. When a woman chooses to have a child, should be her explicit choice. Every woman has the recognized human right to decide freely and responsibly without coercion and violence the number, the spacing, and the timing of their children, and to have the information and means to do so, and the right to attain the highest standards of sexual and reproductive health. It is her right, it is her choice, it is her decision. And as gynecologists, it is our duty, and we wish to offer her this choice in a safe, risk-free manner, so she has control on her own life choices without having to resort to unsafe and dangerous practices. Foxy has many more policy statements also, like use of female condoms and vasectomy and so many other things. But because of the limit time problem, I am not going in detail of all this vision. We believe that there is a great improvement in our country regarding the family planning services, but still there is a big unmet need existing in India. As the pandemic spread, many private clinics had shut down because of tough lockdown. transport restrictions, provider unavailability of staff, a smaller number of patients were not ready to reach to the open healthcare facilities because of fear, pandemic, and a lack of PPE kits and lack of quality of PPE kits. And there was also a disruption in supply chain for drugs for medical abortions. The West Africa Ebola virus disease outbreak had shown that the biggest threat to women's and girls' lives was not the virus itself, but the shutdown of routine health services and fear of infection that prevented them from going to open health facilities. During the pandemic in South Africa, 3,600 mothers, neonates, and there were stillbirths, which are reported, which are nearly equal to the deaths because of the Ebola virus. Several NGOs has predicted. The Foundation for Reproductive Health Services India estimates that lockdown could lead to an additional 2.3 million unintended pregnancies and over 8 lakh unsafe abortions. And we all know that unsafe abortion is the third leading cause of maternal deaths in India. IPAS Develop Foundation has estimated that in India, 1.85 million women will be unable to access abortion services as a near-term impact of COVID-19. And let me inform you that in this estimation and in this study, Foxy plays a very important role, and Foxy's leaderships have played a very important role in coming out with this study and in making the design and coming out with the result. And of course, this will lead to a different implications. Now we will have more more surgical abortions. The medical abortions now cross the limit and may need a surgical abortion. So there will be increase in surgical abortion. There will be increase in second trimester abortions. There will be increase in illegal abortion. There will be increase in unsafe abortions, and there will be increase in continuation of unintended, unwanted pregnancy. And here, our role is very, very important. This situation adds additional responsibility on healthcare system, on all of us, and we have to offer safe options, remedial options to these women. In India, the government has issued telemedicine guidelines that do not rule out medical abortion. Foxy promotes use of telemedicine for contraception and for the prescribing drugs for the medical abortion if after counseling and proper care and if patient is suitable for it. Foxy also supports for the use of LARC as it decreases the visit to healthcare facilities. And this is an opportunity we can say for PPIUCD and so many other things. Foxy also supports use of emergency contraception, which may be more useful during particularly this COVID-19 pandemic. Foxy supports newer contraceptives like implants. Foxy advocates expanding of basket of contraceptives under the social marketing scheme, and Foxy recommends for at least one gynecologist in the body of NMC, newly formed National Medical Council, to look after all this important agenda of women's sexual and reproductive health and rights in public hospitals and colleges and private sector. Because there are so many schemes, so many projects, so many targets for SRH services. At the same time, we also wish it should be taken proper care through the NMC. So we also demands, or we can say it's our humble request or recommendation to Government of India, to NMC, to at least have one gynecologist in the body of NMC who can take care of all these things or who can help them. Yes, Foxy advocates healthcare is becoming a part of information technology. We advocate telemedicine, and we can do health education, we can do counseling, we can prescribe drugs for medical abortion, and so many things. We can do follow-up after delivery, abortion, surgery, so many things can be done. Foxy with its academic partners doing lots of activity. Foxy DKT CME Gnan Varsa for abortion and contraception. Foxy Pfizer for CMEs for feminine health and life cycle approach. TOT sessions with MSD on Implanon. Foxy Eye Care, Foxy Pfizer for integrated contraceptive approach across reproductive age. and Foxy's academic activity with Zydus on emergency contraception and contraception in pandemic times. So Foxy is doing a lot of activities, lot of workshops, even in this difficult time of COVID-19 on digital platform, trying to reach to all our members and trying to also to reach to each and every corner of India through its popular community connect programs during this year, which are scientific based. And Foxy also advocates and doing collaborative work with so many NGOs. Foxy is one of the important partner for the ARC for advocating reproductive choices. Foxy with PSI has started Parivartan, and Rajasthan is the main state for it. With FPAI, we are doing programs for adolescent, sexuality education, advocacy for doctors from indigenous disciplines and strategies for enhancing male participations. With Ministry of Health and Family Welfare, Foxy supports by conducting ASA mentorship sessions and for adolescent SRH conferences. And various Foxy is also conducting various studies and surveys on post-abortal contraception, and mainly particularly with IPAS we have started this study. And we recently started some new programs or talks, particularly with Foxy CIPLA workshop on safe abortion and contraception cafe, Foxy Sankalp traveling workshops on family planning, Jagriti project for increasing demand generation, Foxy Buyer Ask Tanu project, the chatbot for contraception counseling, paramedical training of A&M talks on with UNFPA, surveys for uptake of contraception by young married couples with Pathfinder International, and developing a telemedicine module for contraception services. I congratulate Foxy's Family Planning Family Welfare Committee and Dr. Subha Gudi for working actively in all these projects. And Foxy believes in respectful, trusted, strong, long partnerships with all the NGOs and Government of India who are active for the healthcare, women's healthcare in India. And we have signed a historical MOU with the first time with USAID in India on 28 February, again regarding the unmet need of contraception, promoting adolescent and youth-friendly services, adolescent helpline number, effects of steroid in premature delivery, and we have selected 5 societies for the pilot project. Delhi, Gurgaon, Raipur, Noida are among those societies. And this is a memory for this very, very historical MOU. Foxy has done first time in the history of Foxy done MOU with the UNICEF, and this is Foxy UNICEF partnership aims to leverage to support advocacy, access to information, healthcare provider capacity building, data and knowledge management, and client tracking to ensure essential life-saving service continuity for mothers and newborn as country implements COVID-19 response. So again, here there's a continuity of for mothers services, and this also include family planning and abortion services. It will be coordinated between UNICEF and implementing partner Foxy, working together with the Ministry of Health and Family Welfare, state NHMs, district chief medical officers, and health facility management and staff. And state and district level project implementation will be coordinated between UNICEF state offices. UNICEF has state offices in 23 states of India, and we have 260 Foxy chapters. So we will have a great collaborative work with UNICEF. And particularly, we are also aiming to work at Luxia, at obstetric HDU, ICU, and quality care, and adolescent health and neonatal care with this in this UNICEF project. Foxy has also done MOU with FIGO, and Dr. Poonam is here with her support. And we are going to, this MOU is done for the Uttar Pradesh for PPH bundle. Again, we have done one MOU with the American College of Obstetrics and Gynecology for telementoring of our postgraduate students. And Foxy has also done MOU with the Government of India for National TB Elimination Program to address TB among pregnancy and infertility. So we have done several MOU. I can say the maximum number of MOU in the history of Foxy during this difficult time of COVID-19. And we believe that we are safe when our supporting staff is safe, and paramedic staff will be safe when they are updated and trained for the care during COVID-19, which also include care for the abortion, contraception, and all the issues. And with Safe Motherhood Committee, Foxy had organized a focus free of charges useful training course on 17, 18, 19 August with the help of AIMS Delhi and WHO, where more than 11,000 paramedics has participated and more than 150 societies have participated. And I am thankful to Dr. Priti Kumar for this very, very useful initiative, working for this very, very useful initiative, and Dr. Aparna Sharma and Dr. Sunesh Kumar from AIMS. And we distributed this certificate with the sign of Foxy President and Dr. Rodrigo Offrin, WHO representative, and Dr. Sunesh Kumar, HOD of AIMS. Foxy also has done lots of collaborative. Foxy have high regards and respect for medical colleges, and this year Foxy, yes, as a gesture of appreciation, Foxy has distributed 195 masks and 20 face shields to resident doctors and professors, teachers of medical colleges all over India, and they all are working tirelessly to provide obstetric services to COVID-19 mothers. We understand this, that this offer is not a solution to the shortage of PPE kits, but this is, we can say, is a step in the right direction. So thank you very much for serving COVID-19 mothers, and we appreciate your efforts, and we also are thankful for accepting our this small gesture. And we have received so many messages, appreciation, and phone calls and photos from different medical colleges for thanking Foxy for this initiation. Yes, this is just the list with whom we have done partnership: USAID, UNICEF, Government of India, with ICMR for testing criteria during pregnancy, for making registry for ICMR, and for studies in pregnancy, for developing studies in pregnancy with COVID-19. I am one of the advisor for ICMR for all these projects, with WHO, with NACO to prevent vertical transmission of HIV, with PSI for Parivartan, with ARC for advocating reproductive choices, FIGO for PPH bundle and COVID registry, ACOG telementorship, SAFOG for international webinars, IPAS for different studies, IAP and NNF for making GPR. We have also done lots of international programs with Anesthetists Association, also International Anesthetists Association, Justosis, and so many other associations, and with different colleges. So Foxy is trying to reach to so many national, international association, organizations, colleges who are working tirelessly for the women's healthcare upliftment. And Foxy is also doing lots of community connect program. Foxy's vision is to reach to each and every corner of India, and Foxy's vision is to make Foxy a home brand across India. And Foxy understands its responsibility, its role in providing family planning services across India. Foxy believes that leveraging partnership is important for better and effective implementation of family planning services and other important projects. Foxy extends its full support and strength of 38,000 gynecologists to Government of India for all its schemes, projects, and targets for family planning services, and as well other services for the women's health care upliftment. And Foxy has set up, this year Foxy has set up, we have so many mission and vision, but at the same time, we believe that we need certain fixed targets also and timeline also. SDG is to be achieved by 2030 for our country, but we believe that I foresee for Foxy 2020 is to plan and to start work to achieve SDG for our country by 2025. And these are the targets Foxy 2020 have laid down for Foxy for next 5 years. Let us work together to achieve these targets for our for Foxy and for our country and for the women of our country. And one of the important target in this is maternal mortality 67 by 2025 instead of 2030, and safe abortion 0% mortality because of abortion by 2025. A big section of our country is still unreached, underprivileged, deprived of benefits of healthcare facilities. So it is our moral duty as an organization, as a private practitioner, as a colleges to reach to them to provide this services, healthcare facilities to them. Thank you very much for the patient hearing and giving me this opportunity. Thank you.
Thank you, Alpesh. I think it was a wonderful vision. I know from the beginning, since you took over charge as president at Lucknow, your vision had been great and you wanted to make the women of India safe and at the same time Foxian safe. With your leadership, I think most of the Foxian have worked throughout this COVID period, and some of them have lost their lives because of serving their community. But we bow to them, but we will not be afraid of working. We will be having different ways of working, helping our community and women. And Foxy has done tremendous work for doing partnership with national and international agencies. And I assure you that each Foxian is going to support each president who comes to take over as a leader of Foxy. Thank you, Prof. Alpesh, for bringing out all the points you have taken on. Thank you.
Thank you very much.
Thank you.
Thank you, Dr. Alpesh, for giving us that precious time out of your schedule. We all know how blocked your schedule will always be and how many matters multitasking that you are faced with today. Chandravati ma'am, thank you very much for blessing us today and for being the chair now. And please take this forward, Kavita, please.
Yeah, and I will request the chairpersons to introduce Dr. Ben Bellows. Dr. Ragini ma'am, will you please?
Thank you, Kavita. It's my privilege to introduce Ben Bellows, who is the co-founder and business officer, consumer.
Dr. Ragini, your audio has to improve. Yes.
Information, charities, for-profits, and public agencies.
Dr. Ragini,
Yeah.
could you repeat the previous one sentence? You were not audible then. From consumer-facing digital, yeah. Sorry about that.
Ragini ma'am, you are not audible. Some connection problem.
Somehow.
Am I audible or not?
Now you are audible. Now you are audible. Yeah.
Okay. So what I was saying that Dr. Ben Bellows is co-founder and CEO of at MIDI, a consumer-facing digital health company empowering individuals with actionable information. Ben previously was a health researcher at the Population Council, conducting studies of performance-based financing, reproductive health vouchers, and health policy with government and non-state partners in Sub-Saharan Africa and Southeast Asia. His lifelong work covers information technologies, human rights, and reproductive health. Yes.
Yeah.
There's a problem with ma'am's.
Yeah.
So over Dr. Ben Bellows, I think it's playing some havoc today.
All right.
Ben Bellows. I think we will
Thank you very
listen
much for
him
the kind
and
introduction.
learn more from that.
That's quite all right. Thank you, Dr. Agarwal. Thank you very much for the warm introduction. And distinguished ladies and gentlemen, colleagues, thank you very much for the opportunity to speak today. It's a pleasure to be here, to join you online, and to share a perspective, if you will, a slightly different framing on partnership, and thinking about partnership from the perspective of private sector and from the perspective of demand side. So we've heard a lot today in previous presentations on challenges around or reasons for non-contraceptive use or discontinuation, that there are a number of factors on the supply side and constraints around training, for instance. Dr. Radhika and Dr. Mukherjee spoke to consumer preferences to some extent, or client discontent or challenges, but also a lot of the supply side training constraints. And Dr. Kavita Agarwal spoke as well about some of the challenges around health education as a supply side constraint and characteristics of the high quality counseling that are required. I want to speak today a bit about NIVI as an example for the demand side and the opportunity that exists as we look to the future to leverage digital to expand this marketplace and provide the architecture for organizations to transact or interact, build partnership, and strengthen the overall ecosystem so that ultimately we're able to help consumers realize their own health objectives. So with that extended introduction, I'll get into the slide here. We recognize there are a number of low quality and high inequity outcomes that we're observing with family welfare services and with contraceptive uptake. A lot of those have already been explained or highlighted from previous panelists and speakers, but I want to emphasize the critical role of information. This is something that Dr. Mani was also talking about with her characteristics of high quality counseling, and extending or generalizing on that challenge of information, the challenge of absent information. There can be a lack of quality, there can be a lack of trusted information that's needed to make personal health decisions. There can be missing or incomplete data at a population level to help inform or manage programs that could boost knowledge, could improve attitudes, and it could ultimately positively affect behaviors, but we're missing that data as managers. And ultimately, there's a poor means or limited engagement. There's a challenge with the inability to re-engage patients or to re-engage households and draw them back, if you will, that demand creation component back to the health system for these critical preventive health services around contraception, around family welfare. Of course, all of those challenges pre-COVID have only been exacerbated in 2020. COVID-19 has fundamentally altered reproductive and maternal health outcomes. And as we've seen and already heard a number of times today and seen published in the literature, there were forecasts early in the pandemic that we would see coverage reductions, the loss of uptake in family planning or family welfare, a coverage reduction in prenatal or antenatal service coverage, and ultimately coverage reductions in postnatal. And these have been borne out in the data in the months more recently. So these are certainly the challenges that our generation that we are called to respond to call to address as we now face the end of 2020 and going into the next year. Part of this opportunity then, if you will, to address the challenge before us is to think about the consumer, to think about the client, the households, the individual, the community level side role, and the power for digital to create the ecosystem to accelerate partnership in this ecosystem. And so NIVI, we created NIVI to precisely do that, to enable self-care. We're already doing this for millions of users. We've reached 2.3 million users in aggregate in the last 20 months, reaching individuals through messaging channels. So these are we leverage, say, WhatsApp, Facebook Messenger, existing communications channels that individuals have on their smartphones. And through conversation, mediated through something as natural as a messaging format, helping these individuals, helping consumers find the information they need to be able to take action on their health journey. So we leverage that conversation, those digital moments, to derive in aggregate insights for our partners around the dynamics at play in this contraceptive space. So what does it mean when an individual is asking about a particular contraceptive method? What does it mean when they're seeking a referral? Or where do they go? And from that dynamic interaction in this messaging medium, we can help our partners, not just NIVI, but we help our partners, nonprofits, for-profits, and the public sector to understand dynamics in aggregate in the marketplace to address those information challenges that I previously mentioned on the earlier slide. So if I could think of it or help present this as an iterative cycle, we begin with the Ask NIVI experience in the pink portion of this circle, where we focus on consumers, raising awareness through demand generation activities. These could be digital campaigns conducted through social media or other online platforms, or they could be offline, working with ASHAs, working with the mass media channels that we heard in previous presentations to deliver that initial call to action. And from that, directing them to Ask NIVI, where questions can be answered, where that initial intent and understanding their pregnancy intention, but also understanding what other intents may they have in reaching out. Understanding that intent, identifying it, and helping them act on it is a critical part of the Ask NIVI experience. So we go from engage to chat to act. But from those from those initial contact points with the consumer, we then derive insights for our partners for smart re-engagement. So you can see an iterative cycle informed by data, informed by evidence to drive uptake. So what can partners see from using or engaging with NIVI? They can see demographics and outreach. They can see topics of interest. They can see user knowledge levels, and ultimately what actions users are taking. When we think of demographics, what kinds of demographics are we capturing? We're able to see in aggregate users' age, their gender, even their location, which is a critical component if you're thinking of service delivery referrals. So ultimately, who's engaging with the platform? We can help our partners understand outreach and the effectiveness of those outreach campaigns, both offline with the ASHAs or other medium, other mass media events, or online through digital campaigns. Understand which ads or which calls to action ultimately caught the user's attention. We can understand their topics of interest. We can understand their levels of knowledge. What do they know and what is not known? And ultimately, what actions are users taking? Are they able to take up that follow through on their desired contraceptive intent? Or are they finding that there are barriers, COVID related or others, that are keeping them from taking action? And ultimately sustaining that action, because it's not just a matter of obviously taking up the method, but sustaining that contraceptive method, which is such a critical part of what we're doing collectively, as a community of practice here, and what Foxy's been doing. So in terms of topics of interest, we can help our partners see that users are engaging on those calls to action. They're responding on a particular topic. It might be something as broad as family planning, but we're finding that helping our partners also understand what other questions and interests users may have. So they may have come to the platform to learn about family planning, but then find that they're actually exploring in-depth particular methods, learning about OCPs or natural methods or fertility awareness, or finding out more about medication abortion. So we can help users explore additional topics beyond that one topic that brought them to the platform. And again, helping them to take action. So if you think about it from a demand awareness or demand generation process, there's a funnel going from a broad top level, reaching thousands of users on any particular campaign, and seeing some conversion as users' interests begin filtering or stepping down into specific pathways through the platform, ultimately to receiving some action and being able to instigate some sort of action, be able to lead to culminating in either a behavior change endpoint or a pharmacy visit or a clinic referral. During COVID, however, we've also begun to explore more of this digital space beyond the brick and mortar referral as an endpoint. We began asking when we launched our first COVID conversations, April 7th, just about a week 10 days after the first lockdowns in late March, we launched these conversations and began asking users, well, what's your experience been during COVID in trying to seek, say, pharmaceutical products or find your contraceptive method? And of the sample we asked, and of those that responded, it's a convenience sample. These are individuals that are reaching us through an opt-in rights-based approach. We found that nearly half, in fact, did get the method they were seeking, but a good quarter were learning that they needed a prescription for a method they didn't know required a prescription, or one where they didn't have the prescription in hand. They also found about 10% were finding that their method was out of stock at the pharmacy they had intended to procure it from. And there were other barriers that consumers were identifying. So then we began wondering to ourselves and working with our partners at the time, PSI and others, what online services and what degree would our users be interested in online services in the event that we could refer them to, say, an e-pharmacy or a telemedicine online consultation. And we found significant demand. Ask consumers, they tell you a lot. So we found about 65% in this particular sample were curious and wanted to know more about online services. And so we began to develop very quickly the ability to refer users to doctors or doctors.com, to NetMeds, and to other platforms for e-pharmacy referral. So this is something we've been doing rather quickly just within the last few months. The idea is that ultimately we're developing and deploying a platform that's now served 1.8 million Indians with the means to engage large scale. So we've built this platform to reach users, consumers, individuals on the one hand, but help our partners, those nonprofits, for-profits, and public agencies, government agencies that want to use data to drive positive behavior change. We can think about it in terms of three related products we like to call NIVI Impact, NIVI Direct, and NIVI Reach. I'll focus on NIVI Impact on this slide to keep it brief, but the idea is that we're facilitating or providing tools to our partners to unlock that actionable component around behavior change, from the initial awareness raising to deepening that interest, to developing a desire to act, and ultimately helping individuals take action for those that want it through a rights-based, informed choice process, one that essentially is empowering consumers to take the agency in their own hands to now go forward and find those services they're looking for. So essentially this platform works because of these partnerships where, say, Jhpiego or PSI now are able to take the tools that we've built, deploy them into their populations, their target audience of interest, and ultimately optimize that consumer engagement that they've been seeking, that they've been developing and deploying over the years. So early partners in terms of this reach, direct, and impact, we've had a range of partners, not only in India, but we're operating in Kenya, South Africa, and Nigeria now. So we're in 4 markets, for 4 very large markets, and India being the largest, of course, with this ability to offer solutions that can be as simple as putting out information about specific methods available at, say, pharmacies, like we're doing with Mari Stopes in Kenya, or something a bit more complicated with conversations around COVID, like we're doing with MSD Merck in South Africa, or working at an in-depth behavior change approach with PSI, Jhpiego, and Sergo Foundation in India. So you begin to see that there's a range of possibilities that digital is allowing a greater dynamic, more flexible approach to unlocking consumer demand and achieving that desired outcome around better health through higher quality and greater equity. So with that, I hope I've given you a sense of how digital can be a collaborative, partnership-driven approach to unlocking demand and deepening engagement with consumers, not just for initial contraceptive uptake, but for the long haul, for contraceptive continuation. If you're curious to know more about what NIVI is doing, I'm glad to answer questions over email, or check out what we're doing with WhatsApp. You can see the chat bot yourself at that number below on this slide. And I'm glad to take any questions or follow up after the conference. So thank you very much for your time today. Now, if I can figure out how to just stop.
Ragini ma'am, you're not audible.
I think Ragini is finding some problem with her net, like I had some problem.
Yeah.
But I think Ben, it was a wonderful discussion and talk what you did it, and I think we need to really explore this system and go in detail about it, how we really can work out and what benefit we can have from the community and public. And if there are any comments from Shobha, and I think Ragini cannot, in fact, get her connections because of the net problem today. I think net is giving lots of problem everywhere.
Yeah, somehow today that is not in our favor, it looks like.
Yeah.
But what is definitely what Dr. Ben Bellows has spoken is in the favor of this country. You have put in a lot of work already, directly syncing with the Indian clientele and the target couples and the women, eligible women. So how did you manage to channelize your information to India? How did you get the first opening is what I was interested in knowing. How did it all begin? Because sometimes we feel that the beginning is the most difficult task.
The first step is always the hardest part of any journey. Thankfully, the barriers to entry in India in many ways are quite low. From a digital perspective, not only is the scale impressive, but the rate of change is also quickly reducing barriers to entry, in the sense that the cost of data is probably the cheapest in the world at this point, with Reliance, Jio, and others, allowing that level of access to consumers at a price point that makes engaging users digitally a compelling offering for not simply commercial purposes, but for public health benefit.
Yes.
And I think it's important as public health researchers, as public health practitioners. My background, I'm trained in epidemiology. I've been working in the region, South Asia, and more in East Africa, but for the last 10, 12 years. And it's such a phenomenal opportunity now to be able to offer health information through these scaled platforms that why not at this point? It just seems like it's one that's really opportune. And I think it's incredibly.
Yeah, Dr. Bellows, I just wanted your perspective on, you heard our dynamic president speak. You heard what kind of volume of work he has generated and how many partnerships he and his team have leveraged along with all of us. So do you foresee leveraging partnerships directly with Foxy also, and with the technical force that we have of so many service outlets across the country? You know, about 40 to 45,000 service outlets may be there. At least 60% of them, or at least 50% to say the least, will be private settings. So do you see some kind of buildup of market for contraception service? Because I think it does work in some way if we channelize that kind of, energy, the marketing strategy into the service provision.
No, I think it's a conversation we should be having. It's certainly a natural fit, a natural partnership. Being able to offer a service, a subscription-based service that allows 45,000 endpoints. I mean, you could imagine the opportunity here to connect consumers on the one hand who are looking for that information, the actionable information to drive their behavior to help achieve desired endpoints around contraceptive uptake, contraceptive continuation, or other SRH, sexual and reproductive health issues. This is an excellent opportunity to explore partnerships. Yes, I think that's something we need to do.
I think we must leverage that from this conference, and we must thank the organizers for that. On that note, Madam, can we go ahead? And Chandravati ma'am and Usha Sharma also, I can see Madam Usha Sharma also. Could we go on to the next session?
need to go, Shobha, to the next. I think we are already half an hour late.
Thank
We are
you very
already
much.
late.
Thank you, Dr. Ben Bellows and Kavita
Thank
and
you very
Riju.
much.
Yeah, Kavita and
Over
Riju,
to
it's
you,
all
Dr.
yours.
Riju, to please continue the session.
Thank you so much, Dr. Chandravati ma'am, Dr. Ragini ma'am, Dr. Ben Bellows, and Dr. Alpesh Gandhi. So to chair the third session, the vital areas of practice, it is my honor to invite our chairpersons, Padma Shri Dr. Usha Sharma ma'am and Dr. Ramani Devi ma'am. Padma Shri Dr. Usha Sharma ma'am is the principal and professor OBGY of LLRM Medical College, Meerut. She is the recipient of Dr. B.C. Roy National Award, Jewel of India Award, Hari Om Ashram Alembic Research Award by President. She's a Golden Educationist of India Award and endless prestigious awards like late R.B. Dr. S.N. Malhotra Award, late Professor Dr. D. Kuti Lifetime Achievement Award, and she has made our country proud by creating world record in lab ligation. A very warm welcome, ma'am. Our next chairperson, Dr. T. Ramani Devi, is the Vice President, Foxy, and Managing Director of Ramakrishna Medical Center LLP and Janani Fertility Center. She is recipient of Dr. APJ Abdul Kalam Award and has received prestigious awards in Foxy as well as IMA. She is International Advisory Board member of Fertility Society of Bangladesh. I welcome you both, ma'am. Now I request Dr. Usha Sharma ma'am to introduce our first speaker for the third session, Dr. Bharti Maheshwari.
Okay, am I audible?
Yes, ma'am.
Okay, okay. All of us know that Bharti is a very dynamic, dedicated, and hardworking person. And she is at present professor and head of the Department of Obstetric Gynecology at Muzaffarnagar Medical College. She is chairperson Foxy MTP committee. She has fellowship in medical education by MCI, and she is member elect for governing council, joint secretary UPCOG, vice president Meerut Obstetric Gynec Society, author of many textbooks and the chapters, and has delivered Kamini Rao oration and other talks in national and international conferences. Organized North Zone and UPCOG conference as organizing secretary. And she has been national coordinator, MTP committee 2015 to 18, and executive member endocrinology committee. So today Bharti will be telling us about safe abortion practices and the ideal method. We all know that about 15 to 16 million of induced abortion occur every year, out of which 3 to 4 million are unsafe abortions. And our aim is to prevent unsafe abortions and to promote safe, legal abortion practices with minimal morbidity and mortality. And for this, we have to create awareness regarding the various complications we can have due to unsafe abortion practices. And sometimes even the future of the female can be ruined, that she can become infertile. And this subject will be taken care none other than our Dr. Bharti Maheshwari. And may I request you, Bharti, to please give your talk on safe abortion services, the ideal method.
Welcome, Bharati, chairperson of MTP committee of Foxy. We would have seen the wonderful work what she has been doing during this COVID scenario, and even at the lockdown period, you can almost every other day he does some webinar. Welcome, Dr. Bharati, for this important topic on safe abortion, about what Dr. Usha Sharma has already mentioned. Thank you.
Sorry. Good afternoon and namaskar to everyone. I think I am audible. First of all, thank you and pranam to my mentor and my guide, Professor Padam Shri Dr. Usha Sharma Madam. And I am really blessed and honored and really grateful to organizer and Dr. Shobha Gudi Madam and Dr. Alpesh Kandis and all AOGD team that Dr. Padam Shri Usha Sharma Madam is chairing this session. It is really very honored because she has achieved the Padam Shri for this all family welfare services, and I am one of her students who is motivated to work in this field. So thank you, and I'm really blessed, Padam Shri Usha Sharma Madam and Dr. Ramani Devi, my chairperson. Thank you, Madam, for your kind word. I'm really the Foxian who is motivated by all of you, and really appreciate the efforts of Dr. Shobha Gudi, what she is doing excellent job in all parts of family welfare to by organizing such type of academic CMEs. So today she has given me a topic to cover in the 15 minutes, and that is what is the ideal way of safe abortion practices. So as you all know that still we have unsafe abortion, and I always share this WHO's latest message that how to prevent unsafe abortion through comprehensive sexuality education, access to affordable contraception, and safe abortion care. So when we talk about the ideal way of safe abortion services, so I would like to share this slide of the WHO. What they have, they depicting that emergency treatment of abortion complication is essential to reduce death and injuries from unsafe abortion, but it cannot replace the protection of women's health and their human right afforded by safe and legal induced abortion. And this is very also important statement by WHO in 2012 at Geneva that access to safe abortion depends not only on the availability of services, but also on the manner they are delivered and their clinical context, as well as services should be delivered in a way that respect a woman's dignity, guaranteed her right to privacy, and is sensitive to her need and perspective, as well as a special attention for the needs of the poor, adolescent, and other vulnerable and marginalized women. Believe only then we will be able to remove the unsafe abortion. And as we all know, already know that in our country we already have a legalization of services in 1971 just to prevent the unsafe abortion as well as for the safety of doctors and women both. And currently we have National Policy 2000 as well as RCS2 and MTP Act together working for providing the safe abortion services. But where are we? What is the current status in India? Still we have 15 to 16 million abortion in every year, but significant proportion of these are still unsafe. And as Dr. Alpesh has told that still we have a third largest cause of maternal mortality by unsafe abortion. So of course we all know that the clinical, beside the clinical part, we have other part related to abortion, social, economical, physical access as well as policy matters, and we all have to handle that together. So as a we provider, we obstetrician, we have to know about the ethical and social part of the abortions, and we are fortunate that in India we have very properly written guidelines, guidance that you can say that we have. This is the picture of the on-site, and you can see that all steps, all forms, they are available on the site, and there are the comprehensive abortion care manuals where you have the proper guidelines how to say ideal abortion services. So here is the need is to strengthen the comprehensive abortion care services. We all have to know for ideal way to provide abortion services, we have to adopt a comprehensive abortion care system, which includes not only the uterine evacuation, but it starts from the counseling and obtaining voluntary informed consent. Dr. Nali has given very beautiful lecture in the morning on the counseling, and then followed by the clinical assessment, which includes detailed assessment, clinically history and examination, pain management and infection prevention, uterine evacuation, managing complication if any, post-abortion counseling and follow-up, and post-abortion contraception. When all these factors and these aspects will be handled together, only then we will be able to achieve our target. And this is also, we should be aware about the national statement that safe abortion should not be jeopardized in preventing sex selection, because still about 9% of abortion are sex selective and 90% not. So we must not jeopardize the safe abortion services just to preventing sex selection. That's why the whole Foxy's efforts to prevent the unsafe abortion, but simultaneously to prevent the female feticide, but continue the safe abortion services. So Surakshit Garbhapat Beti Bachao ke saath. Same is with the WHO's and Foxy efforts for the value clarifications and attitude transformation to strengthen the comprehensive abortion care services. So how we can get the safe abortion services, how we we should adopt the proper method. So here things first we have to know about the laws related to MTP as well as how to maintain the proper documentation. Only then we would be able to provide safe abortion services, prevention of litigation simultaneously to make the system proper by achieving the proper data. Then we have to improve our clinical skills, what I am covering today is in main part, and then communication skill, it is equally important, and then follow up. The MTP Acts will be discussed in the next lectures. We all must be aware about the MTP, POXO, PCP, and DT Act. And all we know already that we have clear-cut acts, MTP Acts, where it is very clearly told that who can do MTP, where it should be done, and how you can get approval of your site for the MTP, and as well as how you have to maintain the documentation and reporting. So MTP site approval, all private center has to take in this approval. This is the Form A, universal from all our countries. You can say very clearly that if you need the termination approval up to 12 weeks, then what you have need the facilities, it is in category A, and if need up to 20 weeks, what you need facility in the category B, and in category B you need the operation theaters facilities all, and then you will be get the certificate approval. So all of you, those who are listening this talk, please all must you ensure that whether you have this Form B or it is displayed at the site where you are providing their services. And then, of course, you all must also know that the government side, where when you are providing the services, what up to what gestational age these government sites are approved for termination. Like PSC, you can terminate up to 8 weeks, in CSC up to 12 weeks, 20 weeks gestation at district hospital and tertiary center, except in the certain emergency condition. And CMO or his team is totally authorized to inspect your sites, as well as to they are authorized to discontinue your approval certificates also. And here the terms about the medical methods of abortion. Many of us have lots of confusion that whether we have to get approval to provide the medical methods also. So here I want to tell you that all medical methods of abortion provider eligibility is same as in the further surgical method, but except you can provide the medical methods up to 7 to 9 weeks from your OPD, but your certificate for affiliation with the sites where you can provide the surgical method or you can provide the evacuation, that should be displayed at your OPD. Besides that, all the records of pregnancy termination has to be maintained for medical methods of abortion also. It's the same, that consent form, RMP opinion form, admission register, and monthly reporting form. Consent would be told in detail by Dr. MC Patel in next lecture, but you all should know that spousal consent is not mandatory according to law, and in cases of minor, the consent of guardian is required. This is the Form C consent form for all MTP. When you are doing the MTP, your consent has to be taken in Form C. This is the typical format you have to be kept in your OPDs, and you have to take consent in this. And please remember that the incomplete abortion, missed abortion, blighted ovum, and the medical pills, if some person has taken some outside, then they are not comes under the MTP purview. This is the second form which all of you have to be kept in your OPDs, and this form, RMP or opinion form, once the patient comes to you and you can see that very clearly that all 5 indications, they are written in this RMP opinion form. Once you find out the proper indications for MTP, you have to fill this form at the same time, and signature of 2 RMPs here also plays that if it is more than 20 weeks, you have to take the signatures for the 2 RMPs, and this form should be filled in the 3 hours of the termination of pregnancy. And once you do the termination, then all entries, this entries has to be entered in this admission register form. This have the 14 columns and have the details of the termination of pregnancy. This is the admission register where you have to keep all details of that termination. Beside that should not be written. No entry of an MTP then shall be made in any case sheet, operation theatre register, follow-up card, or any document or register other than the admission register maintained at the facility. And this admission register is a confidential document and kept to be maintained for the 5 years. Besides that, this is the Form 2 monthly reporting form. This at the end of every month, owner of the hospital has to send to the CMO office. Now comes to the, we all know that this is the important slide where is a summary of the mandatory documentations under the MTP Act. Form C, Form 1, I have told you opinion form, Form 2, monthly reporting form, and Form 3 admission registers where you are maintaining the for 5 years the details of the patients. And this is the finally essential protocol of safe and legal abortion. We all must remember that it should be performed by the RMP as defined under the MTP Act, that it is not only MBBS but should be properly trained for the MTP and should be performed only at approved site under the MTP Act and recorded in Form 3. Other requirement of the Act such as consent form, opinion form, monthly reporting form has to be fulfilled. Pregnancy should be within gestational limit approved by law. Till date it is 20 weeks of gestation limit. Only then you will get the cover of the MTP Act. And if it is now not done, then violation for 2 to 7 years imprisonment can be there and other punishment. And we must know that PCPNDT and its implementation, it is designed for prohibition of sex determination or sex selection before or after conception. It does not restrict access to safe abortion or require monitoring of abortion services. At times, once PCPNDT appears, then it is assumed that most abortion are for sex selection. But this perception found untrue and not supported by any study of that. So PCPNDT and MTP both have different objectives, and PCPNDT doesn't regulate abortion services delivery documentation or its reporting, and abortion services is only monitored by the MTP Act. Same way, you must know one thing about the POCSO Act, because POCSO Act, it is a protection of children against sexual offences, requires anyone who knows that a sexual offence has been committed to report the case to the appropriate authority, either the local police or special juvenile police. And this, you are not supposed to file an FIR or conduct the investigation. You have to only inform the authorities when providing services to a minor, including abortion services under the existing provision of MTP Act. And legal proceedings, if any, can continue simultaneously and should not be hindrance in the treatment process. Now comes to the clinical part. What is the ideal clinical methods you should adopt for doing the termination? So we all know that this is a clinical part, history examination, and proper knowing the exact period of gestation. This is a very important thing. And then history, we must not forget to take the detailed medical history, contraception histories, as well as tetanus immunization, psychological assessment, and only if there is no associated any complication, then only hemoglobin, urate, blood group, RH. It is important to note. And then ultrasound, we all know that it may be helpful for accurate dating as well as detecting ectopic pregnancies, but it is not a mandatory. If you are clinically satisfied, then you can do under your clinical information. This is very important slide. I always emphasize is the pre-procedure counseling. Most of us, we ignore this part, but we please remember this. Please give 2 to 3 minutes for this pre-procedure counseling. It helps a woman to decide about the termination of pregnancy. It helps a woman to choose the method of termination. It ensures that the consent for the procedure is given after receiving complete information about the procedure and understanding its implications. And it helps a woman to adopt contraceptive methods. So please make a checklist, make materials for your centers for the pre-procedure counseling. And in this counseling, first you have to clear the woman very clearly that she can get pregnancy. It's so early as 10 days after the first trimester abortion and within 4 weeks after the second trimester abortion. So she should choose some contraceptive method. And here, this is also important statement by the government of India that if a woman is not willing to accept a contraceptive method, please do not refuse MTP, as she is likely to go elsewhere, probably to an illegal abortion and suffer complications. So assure the woman that she will not be refused MTP even she doesn't adopt any contraceptive method, and continue to counsel again and again and record for everything. Then comes to the methods of termination. In first trimester, we all know till 12 weeks we have options for medical methods, 7 weeks according to MTP Act, until 9 weeks according to our drugs council. And vacuum aspiration, manual vacuum aspiration is a gold standard for the till 12 weeks of gestation. Then second trimester you can do either by the medical methods according to WHO protocol or by the surgical methods, dilatation and evacuation. Documentation for medical methods, all forms has to be filled, I have told already you, but missed abortion, blighted ovum, already incomplete abortion, patient has taken medical method somewhere else, doesn't come under the MTP purview, there you are not supposed to fill all forms. Then protocol for medical methods, we all know on the first day we give tablet mifepristone, and 400 to 800 microgram misoprostol can be given on the day 3 and day 15, we follow the patient. This is the proper checklist, it is given for the day 1, day 3rd and day 15. It is by the government of India and you have to follow by this follow-up card. This is very important follow-up card. You can see that is a complete follow-up card. You can download it. You can ask from the Foxy committees by going to the Foxy website. So it can be mailed to you. And here you can see that it has the complete address of the contact facilities where patient can approach in the emergencies. Here she has common problems related to misoprostol. Here the whole 15 columns and the 15 days patient has to fill the details. And nowadays in the COVID, she can share this for digitally by the WhatsApp to you also. And here you can say that this is a warning sign where the patient has to report you immediately. So this is a very important thing. Every medical method should be followed by this. And this is the first step where the important highlights is that you have to give contact address and phone number to the woman. If you cannot give, then you should not offer the patient the medical method. Second thing here, you have to counsel for the contraceptive as well as you have to do the injection anti-D negative and mifepristone. And here the second visit, third day when you call the patient, here the message is that you have to observe for 4 to 6 hours in the clinics and then prescribe drugs for the pain relief. And same in the 15th day, ultrasound is not mandatory and ask a woman to report weak if she is not responding in reporting with it. And if no period, then she has to report in the next week. So this was about the effectiveness of medical methods. You all know 95 to 99%, and simultaneously MVA, we all must know that it is effective up to 12 weeks and accurate clinical assessment should be done before doing a vacuum aspiration procedures. We have to revise the manual vacuum aspirations and keep in our practice. All 10 steps of MVA, they should be learned. Paracervical block, it is a very easy method, 1.5 to 2 centimeters at the depth at 4 to 8 o'clock position. Have to give 10 ml 1% lignocaine, and then again the counseling post-abortion contraception. All IUCD immediately after the first or second trimester abortion is not associated with a higher risk of expulsion. So it should be offered to the woman. And second trimester abortion, because it contains the maximum complication. So you have to do it only at the tertiary centers, proper counseling and clinical examination. Patient should be admitted. You can adopt any surgical methods and dilatation and evacuation. Preparation of the cervix is very important. Misoprostol 2 to 3 hours before. It reduces the chances of complications as well as reduce, because if misoprostol leads to the contraction of uterus even before actual procedure, so reduce the blood loss as well as reduce the chances of perforation. And beside that medical method, you all know that mifepristone followed by 400 to 800 gram misoprostol every 3 hours you can give, and if placenta is not delivered, then you can give additional 400 milligram microgram misoprostol or oxytocin. And in scarred uterus, it is said that misoprostol was used to induce abortion with 400 milligram vaginally every 6 hours, and presence of prior uterine scar did not impact on the abortion duration. Besides that, you can some trials have used the 200 milligram vaginally with 6-hour interval on the first day and then double the dose 400 milligram with same interval on the second day. So this has also the good success rate. So no evidence that previous encephaly affects the incidence of complications. So you can use judiciously misoprostol with increased interval with reducing the dose, proper utilization of ultrasonography in the scarred uterus. And all complications related to abortion procedure, we have to identify earliest and we have to manage, like shock, infections, continuation of pregnancies, and the long complications. And we all should know that if perforation and have to identify, and we should refer it timely. So this was about the ideal methods of abortion, and in the coronas, abortion services should be continuous with all following the MTP acts and proper MTP act and documentation. So this is the last slides where we say that where legal services are readily accessible and available, abortions are generally safe. So the abortion law and services should protect the health and human rights of women, including adolescents. They should not create situations that lead women and adolescents to seek unsafe abortion. So respect for women's informed and voluntary decision making, autonomy, confidentiality, and privacy with attention to adolescent and women with special needs. So thank you very much for this opportunity to speak on the safe abortion service. Ma'am, unmute yourself.
Thank you very much, Bharti. It was a wonderful deliberation, and you have very, very rightly detailed the information regarding the counseling, technical skill, communication skill, as well as, which is very important, is documentation, the various forms and the methods of safe abortion. I'm sure that every participant will be greatly benefited by your views. And it was so nicely told that I don't think much of the comments are required. And I really congratulate you for a very nice talk.
Thank
Thank
you.
you.
Thank you so much, ma'am. Moving forward, I request Dr. Ramani Devi, ma'am, to introduce the next speaker, Dr. MC Patel, sir.
I am very glad to introduce Dr. MC Patel, who is a senior consultant and obstetrician and medical legal advisor, and past vice president of 2018 and a good friend. And he has been a organizing secretary of AACOG 2017, chairperson of the Ethics and Medical Legal Committee of FOXY, joint secretary of State Organization of Gynecology and Obstetricians of Gujarat, organizing chairperson of HMCO Conference 2018, and he has so many accolades. The moment we think about Dr. MC Patel, we all know that how much help, how much of light he has thrown towards the development and our own fraternity, understanding the medical legal problems which we commonly face. And I welcome you, sir, for this very important topic of pitfalls in
Thank you, Dr. Ramani Devi, for kind words. Greetings from Statue of Unity, tallest statue of world, and we all are proud of that. MTP Act and pitfalls is the subject for today's discussion. Warm welcome all the delegates and wishing you litigation-free practice. At the outset, I would like to thank Family Planning Committee FOXY and Dr. Shobha Gudi in particular, and AOGD for inviting me to share my view about the subject. Is it worth discussing? Yes. Why? Worldwide, 22 million unsafe abortions are performed each year. In India, 7 million abortions conducted annually, and out of those, 50% of these estimated to be illegal, and rate of maternal death due to complication from unsafe abortion goes to almost 8%. So that is why it is very much needed. And see, this is a statistic from Professional Protection Scheme from Gujarat IMA branch. On 2017, out of 11,979 enrolled members, 2,359 friends were facing litigation in one way or other. In 2018, 2,472. In 2019, 2,567. So, see the increasing number of litigations our friends are facing, and we gynecologist friend rank first as far as medical legal consequences are concerned. And as far as MTB practices are concerned, many a times some funny decisions are taken in certain of the cases. In this particular case, hospital and doctor to pay woman rupees 3 lakhs for incomplete abortion, and content was taken in the court was sonography was not done before termination of pregnancy. But questions come, can prior sonography give guarantee of not to have incomplete abortion or any complication? So many times this type of judgments we have to know practice. See, one more judgment where thing has gone wrong. This is real case happened in city of Ahmedabad only. Couple visits gynecologist for MTP. Following consent, MTP was done in 2003. Patient there had a quarrel in family, and patient filed complaint against in-laws for forceful abortion in 2004, and doctor was called as a witness in the court, and doctor was arrested in the court under IPC section 312. Doctor was put behind the bar. After 3 days, there was a compromise between the party, case was withdrawn, and doctor was free from a court. free from the bar. So question comes, can one be prosecuted under IPC 312 to 316? So with MTP Act 1971 enacted in 1971 and in force, notwithstanding anything contained in Indian Penal Code, a registered medical practitioner shall not be guilty of any offense under that code or any other law in force time being, if any pregnancy is terminated by him in accordance with the provision of this act. So if pregnancy is terminated in accordance with the provisions of MTP Act 1971, then no other code, no other law, no other ordinance will be affected as far as MTP services are concerned. But it is very much needed that pregnancy should be terminated in accordance with provisions of MTP Act 1971, because objective of this MTP Act 1971 was to liberalize provision of termination of pregnancy, to protect registered medical practitioner who perform abortion as per provisions under this act, because before this act, irrespective of anything, if pregnancy is terminated, both were considered guilty, patient as well as registered medical practitioner, and both were sued for some punishment. One more objective of MTP Act is to keep record of women under MTP secret. So to liberalize provisions, to protect RMP, and to keep all the record secret is the motto of this MTP Act 1971. So there are certain provisions we know as far as place is concerned. So any hospital established or maintained by government, any place approved by government or district level committee, pregnancy can be terminated. Who can conduct MTP? Any recognized allopathic degree holder who is registered with State Medical Council with prescribed experience, and experience varies with the length of pregnancy. If pregnancy is within 12 weeks of pregnancy, then experience of assisting at least 25 MTPs, and he must have performed at least 5 MTPs in government hospital under guidance of some expert person, and he should have license. If MTP is more than 12 weeks and less than 20 weeks, completion of 6 months of house surgery in OBGYN and experience of at least 1 year in OBGYN practice at any hospital would be enough. So as far as our gynecologist friends are concerned, postgraduate degree, diploma or DNB in OBGYN, because experience during training is considered and no separate training is required if person is having postgraduate degree, diploma or DNB in OBGYN subject. There are certain indications formed in this MTP Act 1971, or we can say grounds on which we can terminate pregnancy. Risk to life of pregnant woman, of grave injury to her physical or mental health, risk to child where born physical or mental abnormalities as to be seriously handicapped, pregnancy caused by rape, that is grave injury to mental health of a woman, and pregnancy due to failure of contraception method by male or female. So unwanted child presumed or grave injury to mental health was the ground considered. But in this ground, it was available, or rather it is available nowadays to married women only in a case of failure of contraception. In deciding the risk of injury to the health, when we are deciding the ground to go for termination of pregnancy, pregnant woman's actual or reasonable foreseeable environment is taken into consideration to decide the risk factor. There is a provision of consent in MTP Act 1971, and it is very much required that consent should be given by patients only if patient is major or patient is mentally sound. But if patient is minor or mentally ill, then consent from guardian should be taken. This is prescribed form under MTP Act 1971, and consent should be taken in this form only. You can take consent in other form also, but it cannot replace consent to be taken in Form C also. So it is very much mandatory to take consent in Form C. Instead of Form C, can one take consent in usual manner as it is taken in other surgery? No, because it is very much mandatory to take consent in Form C only. One more question. Is MTP a right of patient? Can a woman ask for MTP on demand? If doesn't fit in indication, then can she take advantage of Article 21 of Constitution, that is right to life and personal liberty? So is MTP right of patient? In this particular case, V. Krishnan versus G. Rajan, court has very specifically said that MTP Act doesn't confer or recognize any right on any person to perform an abortion or termination of pregnancy. Even pregnant woman cannot terminate pregnancy except under circumstances mentioned in the Act. That means if indication is fit as per given in list of indication of MTP Act, then only she can demand for MTP in any given situation. Even during the first trimester, the woman cannot abort at her will and pleasure. There is a question of no question of abortion on demand. And further, court had very categorically specified under Section 3, subsection 18 of this Act is only an enabling provision to RMP for purview of IPC. Court further added that termination of pregnancy under provision of this Act is not the rule and it is only an exception. So pregnancy cannot be terminated on demand only, and doctor is at liberty to decide whether any indication given in list is fitted in this particular case, and then only he or she can terminate pregnancy. There is one more provision, and that is provision of opinion. Who can opine that pregnancy should be terminated? So opinion of registered medical practitioner is to be put on record, and number of opinion will vary according to the gestational age. And this is prescribed form, that is Form 1. In this form only one should form opinion in writing. So opinion is very much needed. This is about RU 486. If you are going to terminate pregnancy medically with RU 486, then prescribing RU 486 is one of the procedure or method for medical termination of pregnancy. So all the rules and regulation of this Act, that is MTP Act, will apply in this situation also. Who can prescribe RU 486? Any qualified RMP at registered place can prescribe RU 486. Can RMP running only consulting room prescribe RU 486? Say for example, he or she is running only consulting room and no facility of indoor, then also can she prescribe RU 486? Yes, but he or she should have access at any registered center under MTP Act, because in any given situation, if any complication related to MTP services, patient should have access to get services of that complication to be dealt with at registered center, and this particular consulting room should have access to that particular hospital, and a board should be placed in conspicuous place that this consulting room has access in that particular hospital for any of the complication to be dealt with. So certificate of approval for access should be displayed at conspicuous place at the clinic. Pregnancy more than 20 weeks. As on today, we cannot terminate pregnancy more than 20 weeks unless there is permission from court. Records. As far as records are concerned, it is very much mandatory. Form C and Form 1. Form C, that is form of consent. Form 1, that is form of opinion. They should be kept in envelope, and envelope should be sealed and make with secret to be written on envelope secret, and should contain serial number which is assigned to the woman in MTP registered, and name of registered medical practitioner who has terminated pregnancy with his or her signature. And within 3 hours of doing MTP, envelope should be sent to head of the institution or head of the approval place on the same day. And that head of the institution will keep this all envelope in safe custody. And every head of the hospital or owner of approved place is under obligation under MTP rules to send the record to CDMO as a monthly statement of MTP cases performed in that particular hospital in prescribed form, that is form 2. It is very much mandatory form to be taken. When this record should be sent, as such, there is no prescribed period in this act as it is prescribed in PCPNDT Act that all the records should be sent within 5 days of the completion of month. But in MTP Act, there is no specification, but it should be sent within reasonable period. And if we send it within 10 days of completion of particular month, then it will do. One more record we have to maintain, that is MTP register, or we can say it admission register, and that is form 3 under MTP Act 1971. This is very confidential record, and admission register is a secret document. Information therein to be strictly confidential, to be kept in custody of head of the hospital or owner of the approved place, cannot be open to inspection except in some special circumstances. Say for example, if patient is working woman and if she asks for certificate to grant her leave, then you can give certificate, but at the same time, one letter is to be written to the person whom you have given this certificate, that record of this patient should be kept confidential, and this letter is to be sent to the head of the institution where patient is working and she is going to ask for a leave certificate. And one more condition is that can be opened before any authority of a person who has authority to inspect this register. In both these conditions are such that this admission register can be opened. Otherwise, it is secret document and it cannot be open to anybody. And entry should be as per calendar year. So from January to December, this register is to be maintained. Fresh serial number shall be started at commencement of each calendar year. This is very much important, that confidentiality of admission register is very much needed, and no entry of name of pregnant woman can be made in case sheet, operation theatre register, follow-up card, or any other document. References to the pregnant woman in such place other than admission register is to be made by serial number which is assigned to that woman in admission register. So in all other places, say for in case sheet, in indoor, in discharge card, only number which is assigned in MTP register should be mentioned, and no detail of patient can be mentioned there to which can reveal her identity. This is one more interesting thing under section 5. If pregnancy is terminated to save life of patient, one can terminate pregnancy even at unapproved place also, and no much formality about this forms and record. Only envelope should be marked secret, name and address of registered medical practitioner who has terminated the pregnancy. Form 1 is to be kept blank, and on same day or very next day of working day, this report is to be sent to directly to the CDMO or appropriate authority. One more interesting thing, whether cases as incomplete abortion, inevitable abortion, missed abortion, blighted ovum come under MTP Act. There was RTI, and in this RTI in 2012, it was specifically clarified that all these conditions, incomplete abortion, inevitable abortion, missed abortion, blighted ovum, are obstetric complication and these do not come under purview of MTP Act. So no formality related to MTP Act is to be observed when you are dealing with such kind of condition. Should gynecologists terminate pregnancy in cases of incomplete abortion, inevitable abortion, missed abortion, blighted womb? Fill up specified Form 1, Form C and make entry of such cases in MTP register? No. We have specified, and it was very clearly mentioned during this RTI. So nothing is to be mentioned in MTP record. Whether medication abortion done by tablet, mifepristone or misoprostol come under MTP Act? Yes, because medical abortion done by tablet, mifepristone and misoprostol is approved up to 7 weeks of amenorrhea under MTP Rule 2003. And should gynecologists prescribe medication abortion done by this tablet have to fill up Form 1, Form C and make entry in MTP register? Yes, because it is very much needed, because it is a method only, and we should observe all the rules and regulation of MTP Act 1971. Offenses and penalty. If we do not observe all this provision, then there is a provision of offenses and penalty. And if termination of pregnancy by any person in any other place which is not approved place, or by person who is not registered medical practitioner, then there is a provision of imprisonment not less than 2 years and which may extend up to 7 years. And any contravention as far as record keeping is concerned, only provision of fine of rupees 1000 only. So as far as MTP services are concerned, we are under liability and we have to face litigation if center is not registered under MTP Act, person is not qualified, if patient is RS negative and entity service is not given, valid consent not taken, if patient is of vesicular mole and not properly managed, if patient is of ectopic pregnancy and if she is not managed properly. So all these are the conditions under which we may have to face litigation. There is a proposed amendment which is passed in Lok Sabha but yet to be passed in Rajya Sabha. So let us quickly see which are these amendments. Indication, that is failure of any device or method used by
Sir,
any woman or her
sir,
partner.
can I interrupt you, sir? Patel, sir.
Yes, sir.
Shobha here. Sir, और कितना time लगेगा, sir?
2 minutes.
अच्छा, okay.
Yes, sir.
So previously it was available to married woman only and to her husband if there is a failure of contraception. But with this amendment, it is open for any woman or her partner if she is major. One more proposed amendment is, it is recommended extending gestational period from 20 weeks to 24 weeks. So up to 24 weeks of pregnancy, registered medical practitioner will be allowed to go for termination. Law would allow abortion any time during pregnancy for selective fetal abnormality which cannot be detected during 20 weeks of gestation. So if there are certain abnormality which cannot be detected at 20 weeks of gestational, then at any given gestational period, it will be given permission to terminate pregnancy. But of course, there should be opinion from medical board, and medical board will be constituted by gynecologist, pediatrician, radiologist or sonologist and 2 other persons which will be approved by government. So this kind of board will be formed in each state, in each district, and that board will be entitled to give opinion to terminate pregnancy even at any gestational period if it fits to go for termination in betterment of patient. So if this amendment passes in government gazette, really indicated patient will be at great relief. One more thing, we cannot reveal identity of a patient as on today also, but with this amendment, there is a provision that whoever contravene the provision of section 1, so reveal the identity of patient, shall be punishable with imprisonment which may extend to 1 year or with fine or with both. Because as on today, there is no provision of imprisonment. There is a provision of only rupees 1,000 fine. But with this amendment, there is a provision of 1 year imprisonment also. So we should be careful. As far as opinion is concerned, as on today, opinion up to 12 weeks for one, and for more than 12 weeks and up to 20 weeks, two opinion. But with this amendment, up to 20 weeks, only one RMP, and more than 20 weeks and less than 24 weeks, two RMP opinion will be required. Ministry has recommended allowing homeopaths, nurses and midwives to conduct non-invasive abortion with training. And this is a matter of so many controversy. Foxy has also given its own stand. So be vigilant in your practice related to medical termination of pregnancy. Center must be registered, person must be qualified, opinion should be formed. Up to 12 weeks, one qualified person, more than 12 and less than 20 weeks, two qualified person, more than 20 weeks, illegal unless it is permitted by court. Valid consent is very much mandatory in Form C, and necessary records to be sent in prescribed form to CDMO in stipulated time. So comply with the provisions of law of land, and enjoy litigation-free practice, because a small slip can make a big trouble. So an ounce of prevention is worth more than ton of cure, which is rightly said in Panchtantra. And it is very obvious. It doesn't matter how many resources you have. If you do not know how to use them, they will never be enough. And so have some basic legal knowledge, and always obtain medical legal advice whenever you are in doubt. And Foxy website, there is names of all medical legal experts with their mobile number, and my number is also there. You are free to contact any one of us in any given situation as far as medical legal advices are concerned. So go hand in hand in practice, and nobody should end up into any kind of litigation. But if at all, I will be always at your assistance to help you out from a difficult situation, because this is law of leopard behind innocent gynecologist, and this is role of medical legal counselor. So enjoy litigation free practice with regard, and salute to all the organizers, and thanking you again, Dr. Sobha Gudi and AOGD team for giving me opportunity to express my views. Thank you very much. If time and organizer permits, I will be happy to answer if any query, any question. Thank you very much.
Thank you, sir. Thank you, Patel, sir. Yeah, chairpersons, please. Yeah.
I request.
Yes. I'm there.
Yes, ma'am.
Thank you very much. I am going to introduce Dr. Chandan Kachru. She is very close to my heart. She is consultant obstetric gynec and adolescent health specialist. W. Pratiksha Hospital, Gurgaon, master course in adolescent health from Imperial College, London, trained in adolescent health from WHO European Training in Adolescent Health from Lausanne University, Switzerland, executive member, Adolescent Committee, Foxy, chairperson, Project Udan of Haryana Obstetric Gynec Society, presidential nominee, executive board of National Neonatal Forum. She is member of Adolescent Health Committee, ex-joint secretary, National Master Trainer Helping Babies Survive Program, Master Trainer EMTCD Program, and many other awards to her credit. And because we are running short of time, I will not take much of time, and I will request Dr. Chandan to speak on adolescent contraceptive. We all know that today adolescent contraceptives are really very much needed to avoid unwanted pregnancy. in many places we know that there are restricted laws and policy which really inhibit adolescents to obtain and use adolescent contraceptives. And in places where we have got even no legal inhibitions, even then the attitude of our health workers and the community leaders is not very much to promote, to give the services to any adolescent before marriage. But we have to create this awareness that adolescent contraception is very, very much important. But if we want to create such awareness, we have to update our knowledge well about the adolescent contraception so that we can always clarify the various misconceptions in the minds of the society. So with these words, may I request Dr. Chandan to please give her views about adolescent contraception. Dr. Chandan Kad.
Namaskar, ma'am. Thank you so much. Coming from you, Dr. Usha, ma'am, it's an honor for me. And thank you so much for the kind introduction. I thank AOGD team, and shall I share the screen? Dr. Mala, Dr. Mani, ma'am. Is my screen, see?
Yes, Dr. Chandan, we can see your screen.
You can see? Okay.
Yes. Just go full screen.
Are my slides visible?
Yeah, you need to close this tab.
You need to close this tab and then open
Yeah,
your slides.
okay.
Yeah,
Now it's okay?
Yeah,
Yeah,
now it's
perfect.
fine.
Yeah.
Slideshow.
Yeah. Yeah. So thank you, Dr. Mala, Dr. Shobha Gudi ma'am, Dr. Mani ma'am for giving me this opportunity. So we'll be talking about adolescent contraception today. And we know that over the past 25 years, based on data from 1995 to 2000 and from 2015 to 2020, the adolescent birth rate has declined from 60 to 43% births per 1,000 girls aged 15 to 19 years. So we shall start on a positive note that South Asia has made the most progress. The rate in South Asia in 2015 to 2020 is 26 per 1,000 girls aged 15 to 19 years, whereas the corresponding rate in sub-Saharan Africa is 104 per 1,000 girls aged 15 to 19 years. 38 million adolescent girls need contraceptives to avoid an unintended pregnancy, but more than half are not using an effective method. Meeting the unmet need for modern contraception of women aged 15 to 19 would reduce unintended pregnancies amongst this group by 6 million annually. That would mean averting 2.1 million unplanned births, 3.2 million abortions, and 5,600 maternal deaths. The pandemic has increased the problem of accessibility to the SRH needs of the adolescents. So this is a diagrammatic representation of a little bit improvement in the adolescent birth rate per 1,000. Now, the Indian data over the past decade, India has successfully reduced the proportion of pregnancy between 15 to 19 years to half. Still, the estimation by UNFPA runs to 11.8 million teenage pregnancy for the country. 1 in 4 Indian women is married before 18, and 7.8% of women aged 15 to 19 are pregnant or mothers. Of adolescents aged 15 to 19, 23 million have an unmet need for modern contraception or at risk of unintended pregnancies. This was very much discussed by Dr. Kavita and other faculty before me. Now, this is the diagrammatic representation of the states. So states like West Bengal, like Bihar and UP are doing the worst in the marriage and pregnancy on adolescents. Now, why are many adolescents still unable to obtain and use contraceptives? There are many barriers, and this is the restrictive laws like POXO here, which is still not well debatable and not well understood. Poorly implemented policies, reluctant providers, deeply held social beliefs, lack of access or unaffordability, stigma around non-marital sexual activity, pressures to demonstrate fertility, etc., and refusal by choice. Now, what should be the approach towards adolescent contraception? Confidentiality is the most important thing. Like Dr. Usha ma'am said, that we have to change our approach towards it. confidentiality is an essential component of healthcare of all the patients, but it becomes very much crucial for adolescents because the lack of confidentiality can be a barrier to the delivery of reproductive healthcare systems. Then what do we do about the counseling? Regardless of a patient's age or previous sexual activity, we have to address her contraceptive needs, expectations, and concerns. We have to be aware of the state laws. We begin with information on the most effective methods, address the most common misperceptions about the contraceptive methods in a way that is age appropriate and compatible with the patient's health literacy. This has been given by the ACOG Committee 2017. Now, visits should also include continual reassessment of sexual concerns, behavior, and relationships, prevention strategies, testing and treatment for sexually transmitted infections as per the CDC and Government of India guidelines. Now, healthcare provider bias is a form of coercion. Very much patients can't be forced to use a method chosen by someone other than herself, including a parent, guardian, partner, or healthcare provider. Adolescent rights to refuse initiation or discontinuation of a method should be well addressed. Adolescents limited in their ability to verbalize or give consent should not be seen as asexual. They are equally predisposed to getting assaulted. Now, the sexual history. Best practice guidelines require that the sexual history be taken with the adolescent alone. Key to history taking is an honest, caring, non-judgmental attitude and a comfortable matter-of-fact approach to asking questions. We can take this help of 5 P's tool of CDC. We should be knowing about the partners, tell them about prevention of pregnancy, protection from STI, which is very much commonly seen in adolescents, their sexual practices, their past history of STIs, and pregnancy. Now, factors which influence the contraception choice is used by their friends or relatives, as peer pressure is a big factor in adolescents. Accessibility of the contraception, their personal knowledge, media. Media has a lot of social effect in the contraception choices, and wrong informations as well. Fear of side effects and physician recommendation. Now, what are the methods? Dr. Basab has elaborated the methods. I'll just go to it very, very fast as the time is less. So long-acting reversible contraception, as per the ACOG and the CDC, this is the first which is recommended in adolescents. Forgettable contraception, not dependent on compliance, should be considered first line of contraception in adolescents as recommended by ACOG. Now, we can offer them levonorgestrel IUD. It is an intrauterine device, very safe for adolescents. Expulsion is uncommon in adolescents and reduces dysmenorrhea and menstrual blood loss, effective for 3 to 5 years. Copper IUD, we know about it. It approved for maybe 5, 3, 10 years, and most effective emergency contraception, does not protect against STIs, which we have to tell the adolescents. Contraceptive implants, these days very much in use. Even in India, we are using it. Effective for at least 3 years, side effects irregular bleeding, and does not prevent STIs. Now, barriers to the long-acting methods are patient preference, concerns about safety, not trained in IUD insertion, the cost factor. And during this choice project, which was held in the US, the women were educated about the long-acting reversible contraception, and they were provided free of cost. And they found that 62% accepted it between 15 and 19 age group. There are 2 methods are injectable DMPA, pill, patch, ring. And we know about the injections every 3 months we have to give. Side effects are irregular bleeding and amenorrhea. It does not protect against STI. Then the combined oral contraceptive pills, the internal pelvic examination is not needed, and routine screening for STIs is recommended in all sexually active patients. Although smoking should be discouraged, it is not a contraindication to use the combined oral contraceptive pill in teenagers and young adults. And see, many regimes are there, many types of phasic pills are there, but among low dose pills which are recommended, there is no clear data suggesting one formulation is superior to the another for adolescent use. Now, about the contraceptive vaginal ring, it is available. It is inserted in vagina, stays in place for 3 weeks, and the ring has comparable typical user failure rate of 9%. Now, transdermal contraceptive patch, this patch also can be used. It again has a withdrawal rate and usually occurred, and it has a failure rate of 9%. Progesterone-only pills, POPs, are not typically recommended as a first choice contraceptive in healthy adults, as it causes the irregular bleeding PB. Now, TR3 is the least effective contraception, but very, very important for the prevention of STIs, especially when the dual methods are used. emergency contraception, the SAOG recommends that all the obstetrician and gynecologists should write an advanced prescription for oral emergency contraception for their patients to increase awareness and remove barriers, especially for adolescents. Now, orally administered, we have, like Dr. Basab told, the demonorgestrel 1.5 milligram. We have the USP method. We have the uriprestol acetate and insertion of copper IUD. Now, message what we should give to the adolescents is that emergency contraceptive pills are not abortion pills, not an abortifacient agent. Dose should be repeated if vomiting occurs within 1 hour and can be used at any time during menstrual cycle. It's not a regular method of family planning, and it does not prevent against the STDs. We know about the dual protection, and especially in adolescents, it is the method of choice. Now, recommendations of ACOG committee was that patient choice should be the principal factor driving the use of one method contraception over the another. New onset abnormal uterine bleeding unrelated to initial placement of long-acting reversible contraception should be evaluated, similar to the abnormal bleeding in non-LAG users. Because adolescents are a high risk of sexually transmitted disease, we should continue to follow standard STI screening. Adolescents who choose the long-acting method should be advised to use male or female condoms consistently to decrease the risk of STIs. Long-acting reversible contraceptives have higher efficacy. Now, maternal health remains a key cause of disease burden for adolescent girls. And in earlier data, maternal causes ranked as second amongst causes of death for girls aged 15 to 19. So adolescent contraception becomes a very, very important thing. Now, Foxy is doing a lot of role in this contraception. Like Dr. Alpesh sir, in his vision said that they are doing so many partnerships and so many things for improving the adolescent health contraception and contraception as such also. Just to add that existing services could be made more responsive to adolescents' needs and preferences. We have success stories of Chile and Ethiopia, so Foxy can integrate it with family planning centers like iCare, which Dr. Shobha Gudi will be talking about, and it's a very favorite for her. Combining service provision in static health facilities with community outreach can further extend the access. So training of ASHA workers in adolescent-friendly health services is very important. Going beyond public health facilities and systems, many adolescents seek contraceptives from pharmacies and shops. One study from Kenya showed that less than 5% adolescents take contraception from government sources. So we can put some IEC material or some information regarding over-the-counter medications like oral contraceptive pills or emergency contraceptive pills at the pharmacies endorsed by Foxy. Healthcare workers lack expertise, knowledge, and approach towards adolescent contraception. We can provide low-dose, high-frequency training to them to sensitize them about the adolescent-friendly health services. This was one study done at Gurgaon here in Haryana by us. And this was a CAP study, and the study revealed good knowledge and favorable attitudes of adolescent females towards contraception. The study also highlighted that awareness does not always lead to the utilization. A lot of educational and motivational activities and improvement in family planning services are needed at the grassroots and school level. Sex education in schools should not be limited to anatomical discussion of reproductive organs, but should include issues like infertility, contraception, and population control. Now, what does the WHO recommendation? It was recently, it's just the last slide. The WHO recommendation is the advocacy. We already know that we are doing a lot in advocate adolescent pregnancy prevention, capacity building. There is a widespread misconception that providing CSE will encourage adolescents to engage in early or risky sexual behavior. As a result, the content of CSE's curricula is often watered down or more limited than recommended by international guidance. For sustainable development, we do programs, but they need to sustain. Recently, Foxy has started SHOPS program as pilot in few districts with USAID, which can be taken forward with customized changes depending upon specific environment. So these are the references from which I have taken my slides. My very much thanks to WHO, Dr. Venkataraman Chandramouli sir for his slides, Dr. Sharda Jain madam for her beautiful slides on the slide share, and all others from whom I took my slides. Thank you very much for your kind attention.
Thank you very much, Dr. Chandan, for a very, very informative and illustrative talk. And you have really very nicely told about the approach of counseling and I will like to emphasize one thing, that in these adolescents, it should be like a cafeteria approach. It should never be provider biased. And really, all the things are very much required. It was really heartening to know that there has been certain decrease in the incidence of adolescent pregnancy. Thank you very much. It
Exactly.
was really a pleasure for me to be with you all on the occasion of 47th conference of AOGD. I am very grateful to my dear loving Dr. Shobha Gudi and
madam.
Dr. Milanli, who gave me this opportunity to be the part of such a prestigious session. Shobha, it is always a
Thank you,
pleasure
ma'am.
to be with
Madam,
you
your blessings are very important for me. Thank you
any
very much.
program you organize. Thank
Thank
you very much for giving me this opportunity.
Yeah, thank
Thank you, ma'am. Our pleasure, ma'am.
Thank you so much, ma'am. I request Dr. Ramani Devi, ma'am, to introduce.
Yeah, it's my pleasure to introduce Dr. Charmila, who's from my own city and my society and our society, that is Trichy OBGYN Society. She has been a student of Grant Medical College, Mumbai, and a chairperson of Clinical Research Committee of FOXI 2016 to 18, president of Menstrual Hygiene Management Consortium of our district, joint treasurer of Indian Fertility Society of Tamil Nadu chapter, director of Aditi Hospital and Parvati Ayavu Fertility Center, and consultant in Southern Railway Hospital, Trichy. She has been awarded the Mohanlal Desai Prize for standing first in DFP, past secretary of Trichy OBGYN Society and organizing secretary of Viva Foxy South Zone in 2013. And when we were the team as president, vice president and secretary of Trichy OBGYN Society, we won nearly 5 trophies from Foxy, and HMS champion for Foxy 2013, recipient of Shailaja and Pandit Prize for Women Empowerment, awarded Merudara Hansuti Award for the Best Committee, editor of handbook on RPL, ICOG campus, and she is one of the principal investigators in the mother study on ovarian reserve in 2019. ICOG, she is elected as ICOG Governing Council member for 2021 to 23. I welcome Dr. Charmila. The topic given to her is benefits of contraception and beyond. See, contraception, when we sometimes what happens is when we tell them that mainly for controlling the family size, they may not accept. Sometimes if you tell them the other benefits of non-contraception, for example, they can be relieved from their pain because of endometriosis, or AUB because of AUB, the patient may be having menorrhagia. We can correct her anemia and so many other things. We can counsel her indirectly so that we can motivate her to use. For example, LNG IUS has got so many non-contraceptive benefits, likewise COCs and Implanon, etc. So I think Dr. Charmina will be elaborating us on this important topic. And I request every speaker to confine themselves to the time that is being given for them, because already we are running behind schedule by almost by 1 hour. Over to Dr. Charmila.
Thank you, Ramani Madam, for that kind introduction. I would like to thank the organizing team of AOGD for the opportunity, and a special thanks to Dr. Shobha Gudi Ma'am, who gave me this opportunity. And it's a great pleasure to see Dr. Usha Sharma Ma'am in a webinar, because she makes it so happy and a cheerful place to be. Thank you so much, Usha Sharma Ma'am and Dr. Ramani Ma'am, for chairing this session. My topic is going to be on benefits beyond contraception for a contraceptive agent. And why do you think that a contraceptive agent needs to be explained about regarding the other benefits? Because when a lady is well informed about the non-contraceptive benefits, she's more likely to use that agent and will also consequently avoid unplanned pregnancies. And the additional benefits will influence a method choice also. Suppose it's going to reduce a dysmenorrhea, it's going to reduce a pain factor, a bleeding factor, then she's going to use it much better than compared to using it just as a contraceptive. The low dose hormonal contraceptives are being used. It's actually a very effective contraceptive agent. So there's a less need for an induced abortion, less need for sterilization. There's got a lesser chance of abortion as well as sterilization. There's a lesser chance of endometrial cancer, ovarian cancer, and overrectal cancer, colorectal cancer. All have been proved beyond doubt. There's a lesser chance of ectopic pregnancy when you use a contraceptive agent like a low-dose hormonal contraceptive. There's a lesser chance of having heavy flows, dysmenorrhea, and less anemia when they're using a contraceptive agent like an OCPL. There's a less chance of salpingitis, benign breast disease, endometriosis, lesser chance of rheumatoid arthritis, protection against ovarian cysts. There's an improvement in the bone mineral density, and also improvement in the premenstrual dysphoric syndrome, which happens with many women during their menstrual cycles. The other uses of the lower dose OCPLs is in Mittelschmerz, where it reduces the ovulation pain. Endometriosis prophylaxis, it can be used. It can be used definitely for acne and hirsutism. It can be used as a hormonal therapy for hypothalamic amenorrhea. It can prevent menstrual porphyria. It can control bleeding in dyscrasias like von Willebrand's disease and in anovulatory bleeding. And the other hormonal contraceptives, as Dr. Ramani ma'am was saying, was the levonorgestrel releasing intrauterine system definitely controls heavy menstrual bleeding, and subsequently anemia is reduced. There's a lesser chance of endometrial hyperplasia and cancer when you use an LNG device. There's a reduced rate of endometrial polyps in women who are used tamoxifen users for breast cancer, and definitely it alleviates the pain associated with endometriosis and adenomyosis. And we know that Depo-Provera will control the crisis in a person with a sickle cell anemia, and it will reduce the pain factor in endometriosis. The implant etonorgestrel releasing contraceptive implant has also shown to be a benefit in reducing the pain associated with endometriosis. Regarding the copper intrauterine device, it has been associated with a reduced rate of endometrial and cervical cancer. And we know that barrier methods are a great benefit in reducing the sexually transmitted infections, both in the male and female, when the male barriers, the condoms, and the female condoms when they are used. And regarding heavy menstrual bleeding, there was a study done where they used the treatment options, that is the continuous or the OCPLs, the danazol, ablation, the levonorgestrel system, a placebo. Then they gave the short-term progestins for this group of patients, and they gave another group a long-term dose of progestogens, and then tranexamic acid. These are the treatment options for heavy menstrual bleeding. And in this study by Hoegelin in 2013, he very clearly said that levonorgestrel intrauterine system and endometrial ablation have got the greatest reduction in blood loss among women with heavy menstrual bleeding. And the OCPLs were superior to short-term progesterone therapy, tranexamic acid, and placebo. So you can use these agents for these indications also. And regarding dysmenorrhea, when you use low-dose pills, it will reduce the prevalence and severity of dysmenorrhea. There's a lower incidence of endometriosis in current users of OCPLs. It's a good option to maintain pain suppression after surgery for endometriosis, but please remember, it will not cure or eliminate endometriosis, but it will cause a pain relief for the person who's undergone surgery. And women who continuously used OCPLs presented a reduction in the recurrence of dysmenorrhea. There's a reduction in the pelvic pain, as well as a lower recurrence of endometriomas. There's a reduction of endometrial and ovarian adenocarcinoma in women who have got endometriosis when they are on OCPLs. And regarding osteoporosis, it has been found that it can occur later in a user, and it's actually less frequent, and it's related to the duration of usage of the OCPLs, but it's very useful for lean women and may not have a much effect when the ladies are overweight. And regarding polycystic ovarian disease, it's very useful in anovulatory heavy menstrual bleeding, which happens in polycystic ovarian disease. It is a very good drug for treating of acne and hirsutism, because it will suppress the free testosterone levels, will increase the sex hormone binding globulin, and that will also decrease the testosterone production. So it's very useful for a lady who's got acne and hirsutism, and can be even used in hyperinsulinemic women, because we know that hyperinsulinemia is associated with a metabolic profile problem. But even though OCPLs can cause a little change, they have found out it actually improves the weight in the women with polycystic ovarian disease. It improves glucose tolerance, it improves insulin levels, as well as the cholesterol levels. So it's not a bad drug to be given when a lady is having polycystic ovarian disease and she needs contraception too. And there's a study which has said that there's a reduction in recurrent ovarian cysts, but it's not proved in all studies, but it can be given. And regarding endometrial cancer, it has got a very beneficial effect. It will persist even after discontinuation. And there's a very good effect on endometrial proliferation, as well as the development of endometrial cancer when OCPLs are used. And regarding ovarian cancer, there's a reduction almost of 50% of epithelial ovarian cancers in women who are using OCPLs for almost 10 years. The same effect is also seen with the use of Depo-Provera. It's associated with a 39% reduction in the risk of epithelial ovarian cancer. And the 83% had a good effect when they use it for more than 3 years. And the mechanism of action and how it prevents epithelial ovarian cancer is, the one theory is it reduces and eliminates ovulation, so that will reduce the risk of epithelial ovarian cancer. The next mechanism which has been put in place is actually there's an increase in apoptosis, which will potentially eliminate the cells that have sustained a genetic damage and may be predisposed to develop a malignancy. So the progestin component in the OC pulse will actually activate this critical pathway of apoptosis in the ovarian epithelium, and this will reduce the chance of ovarian cancer in a woman who's using OC pulse. And there's a 20% reduction in both colon and rectal cancers in users of OC pulse, but the association has not been defined well, and the mechanism of action is also not proved. But definitely it has caused a reduction in colorectal cancer. And regarding ectopic pregnancy, it works by an effective pregnancy prevention, and also the ability of the COC to reduce the risk of pelvic inflammatory disease may play a part in preventing ectopic pregnancy in women who use OC pulse. The symptoms of premenstrual dysphoric disorder, where actually the previous studies said that OC pulse do not benefit, but now the recent regimens, when they use 20 microgram of ethinyl estradiol with 3 milligram of drospirenone in an extended regime of 24/4, or the conventional regime of 21/7, where they use 30 mics of ethinyl estradiol, they had a significant improvement in systems. And when the lady used it for a longer period of time, she had a reduction in the symptoms of premenstrual dysphoric disorder when she used drospirenone as a OC pill. And regarding the levonorgestrel system, which Dr. Ramani ma'am has said clearly, is it is equivalent to hysterectomy in efficacy in preventing heavy menstrual bleeding. It can be used for even non-structural pelvic abnormalities like von Willebrand's disease, platelet disorders, coagulation deficiencies, and in the usage of anticoagulant drugs in persons who are on different transplants. It's a very beneficial agent for them. And it can be also used in structural abnormalities like fibroids. Even though it will not reduce the size of the fibroids, it will have a beneficial effect on the hyperplasia which can happen when it's associated with fibroids. And women who have used it have also shown a improved quality of life compared to the other agents. And regarding endometrial hyperplasia and the levonorgestrel intrauterine system, it is used mainly in young women who want to preserve their fertility. It is much better than oral progestogens for regression of simple hyperplasia as well as atypical hyperplasia. The regression was achieved in almost 90% of women by 2 years, and most of them achieved the regression within 1 year. And the regression occurred in 92 and 67% of the cases in Verma et al. Study with both simple and atypical hyperplasia. And the main variable which is associated with the failure of treatment with this system is the body mass index. Suppose the lady is more obese and she's more than 35 BMI, that is a predictor of relapse of hyperplasia, even if they use the levonorgestrel system. And regarding ovarian cancer, it has got a protective effect against ovarian cancer also. And they say that's because of the downregulation of the estrogen receptors, which will result in low endometrial cellular proliferation. That's basically for endometrial cancer. Because of the receptors are downregulated, she's going to have a beneficial effect that will prevent endometrial cancer. And regarding the tamoxifen uses of women who got breast cancers, when you put a levonorgestrel system, it reduces incidence of endometrial polyps with breast cancer and the uses of tamoxifen. And regarding the pain associated with endometriosis, like the low dose OC pills, there's a definite improvement of pain when you use levonorgestrel system in ladies with endometriosis. It's basically due to the high local levels of levonorgestrel and some systemic effects also. And there's an evidence of depletion of estrogen and progesterone receptors, and that's why there's a reduction in the endometrial cell proliferation after the insertion of this system. And the pain associated with adenomas also will be reduced with the usage of the levonorgestrel system. It will reduce the menstrual blood loss as well as the pain, and that's because of a reduction. There's a reduction in the thickness of the myometrial junctional zone and the total uterine volume, which will cause a beneficial effect for both blood loss as well as pain. But please remember, it may take 2 years after placement for the benefit to happen in certain women. There's a reduction in the blood loss because of the direct effect of levonorgestrel on the adenomyotic tissue, and it will cause deserialization and hypertrophy or atrophy of the endometrium along with that. And there's an improvement in pelvic pain also when the lady uses levonorgestrel system, and that they say it's because of the reduction in the vascular supply to the pelvis, and there's a relief from the pelvic congestion, which will help her to tolerate that pain of adenomyosis. And the other agent which can be used for the pain associated with endometriosis is DMPA. Several trials have said that can be used to treat pain associated with endometriosis. The similar efficacy can be seen with the etonogestrel releasing contraceptive implant, which will reduce the dysmenorrhea which is associated with endometriosis. And regarding copper IUCD, it has been said that it can reduce the risk of both endometrial and cervical cancer. And the mechanism postulated is, one was they said it will reduce the production of ovarian steroids, which will influence the hypothalamus pituitary ovarian axis. But actually there's no logic to it, because there are steroids levels do not cause a reduction just because you insert a copper T. But there's one more mechanism which can be attributed to the reduction in the endometrial cancer, and that they say there'll be an alteration of the endometrial response to the steroids. So that will provoke an endometrial chronic inflammation, and this endometritis may reduce the possibility of endometrial hyperplasia and subsequently endometrial cancer. And they have said that when you use copper IUCD, there's a reduction in both endometrial mitotic activity as well as the estrogen receptor concentrations, which can cause a reduction in the chance of endometrial cancers. And regarding cervical cancers, the postulated mechanism is that threads may provoke a chronic, non-infectious inflammatory response in the endocervix and cervix, which could modify the course of the human papilloma virus infection in the cervix. And the local inflammation could be provoked during the insertion of the IUD, which may prevent the HPV being aggressive in the cervix. And during the insertion, there's a chance that the inserted tube on the device may remove the cervical lesions which could have occurred because of the HPV virus. These are all postulated mechanisms in the way which copper IUCD reduces cervical cancer. And regarding sickle cell anemia, we know that DMP is a very good drug for these people, because in sickle cell anemia, they'll have a blockage of the small blood vessels, which will impair the transport of oxygen to the body tissues, which will provoke episodes of bone pain known as sickle pain crisis. The DMP will actually stabilize the red cell membrane, making these red blood cells less prone to sickling, and that will cause a reduction in the pain crisis. So a lady with sickle cell anemia, that this agent will be a much better contraceptive agent. And the last slide is, I'm finishing now. The last slide is on the usage of hormonal contraceptives for athletes, and this is the best drug for them because there's no adverse effect due to the progestogens on oxygen uptake or the respiratory rate in athletes. It will improve the aerobic power with the increase in time to exhaustion and total work performance in the users. There's a reporting of decreased soreness after exercise in users, and there's no effect on prevalence of back pain, which is a common complaint of athletes, and can be used on a daily basis with no breaks for them, useful for women in the military, and you can use any route of contraceptive and they'll all have the same benefit: oral, vaginal, and transdermal. Thank you so much for the opportunity. I will stop sharing mine. Thank you.
Dr. Ramani ma'am, kindly unmute yourself. You're muted, ma'am.
Yeah. Thank you, Dr. Charmila, for your exhaustive lecture on non-contraceptive benefits of contraceptive agents. I would like to add one more thing. LNG IUS, even early invasive, stage 1 malignancy, well-differentiated malignancies of endometrial thing can be prevented, or the progression of the lesion can be prevented by LNG IUS. So in women especially with PCODs, who are waiting for their fertility management, I think this can be used as a good option. And you have rightly pointed out the advantages starting from A to Z of all the modalities of contraceptive agents.
Thank you, ma'am. Thank you so much. Thank you.
Thank you so much, Ramani ma'am. I request Dr. Padmashri, Dr. Usha Sharma ma'am to give her expert comments, to give her valuable inputs, ma'am.
You know, the whole session was so nicely done and all the topics were so nice. I tell you that regards the safe abortion practices, the medical legal aspects, the adolescent contraception and benefits beyond contraception, all the topics are so important in today's scenario that all of us should have good knowledge of each and every subject. Actually, you cannot promote anything till you are absolutely clear in your mind about all these things. And so I said in every talk also that creating awareness is only possible if you really update your knowledge and you are really aware of the various things which are happening day to day regarding the various misconception of a thing and how you can clarify their misconception, because without which you cannot promote anything. And I think everything has been dealt with so nicely that you do not need many more expert comments. But if there are any questions from the audience, I think that we are going very late, but let us see if you want to entertain them, then we will take them afterwards. And thank you very much once again for making
so
me a part of such
Thank
a
you.
prestigious program.
Thank you. Charmila, if I may add, that was
Yes,
a
ma'am.
wonderful presentation, and I compliment all the 4 speakers of this session because they really brought about the most important aspects of these vital areas of practice. Thank you, Bharti. Lovely as ever. Your presentation was really, really crisp. Dr. Patel, sir, thanks very much. Charmila and dear Chandan, all of you did excellent. Charmila, if I may add,
Yes, ma'am.
brought it out excellently. A very important benefit which is often overlooked is the mental health and the emotional health and the sense of security that a woman has. I think this is one aspect which we always kind of overlook, and that is her comfort level with her day-to-day life. And when she is using a very good contraceptive method and the fear of pregnancy is not there, she has the utmost fulfilled marital life, and she is a better mother. I mean, she does function better in the microcosm of her family. That is what I feel. And it is important that she should feel good also. So most of the hormonal contraception makes them feel good, especially the estrogen containing ones. So with that, and Madam Usha ma'am, shall we move on to that panel discussion? And with your blessings, we will come to the end in another 45 to 50 minutes. We'll
Yes.
keep it extremely crisp. Riju and Kavita, do you want to say anything?
I would just like to invite Dr. Mirnalini ma'am to introduce our moderator, Dr. Shobha Gudi ma'am, for the next panel discussion.
Yeah,
That
please
is
be
the-
brief, Mrinalini.
Shobha ma'am, can I say a sentence?
Of
I really
course, Anita, of course.
I
Yeah.
really want to thank you, Dr. Usha Sharma ma'am. She's my mentor, and she's the one who has made me passionate about family planning services all over the country. So
Anita,
thank you,
God
ma'am.
bless
Thank you
you.
for
Anita, God
thank-
bless you. You are my
thank-
very favorite student.
It is obvious. Yeah.
Congratulations, Shobha Madam, for wonderful program whole day. And thank you all organizers, and really thank you Usha Sharma Madam and Ramani Devi Madam, our esteemed chairperson. So thank you very much.
Thanks, Bharti. Your support is very
Thank you so
valuable for
much.
me. Thank you so much.
It was a
Thank
lovely
you, dear.
session as well.
Yeah.
Kavita, can you move the slides forward? Now we move on to the next session of panel discussion. And I would like to invite Dr. Shobha Gudi here to conduct the panel. She needs no introduction. And she is the chairperson of our Family Welfare Committee, FOXY. And throughout the year, she has been working very tirelessly, and a lot of reach has been done, outreach, and a lot of programs have been done covering entire country, in fact, and we have had lovely panel discussions and webinars. She's the secretary of the Bangalore Menopausal Society also, and she's also an assessor for the Lakshya project run by the Government of India. And she has received so many awards, as you can see, and she has done a lot of original research and publications in Foxy Focus and other index journals also. Over to you, ma'am. Shobha, without
Thank you, thank you. And with that, the panel is on increasing the Met need. And Riju became confused. She said, always we talk about unmet need, madam. I said, no, here we are increasing the Met need. So it is working in a reverse way. So Dr. Neelam from Patna, welcome. Santati Fertility Clinic and ART Center, that is where you come from. You are the president of Patna OB-GYN Society now, and you're treasurer of the Menopause Society there. You have authored textbooks, and your interests are in HRP and rural obstetrics. So I salute your work in rural obstetrics, Neelam ji, and I hope you will take my committee work forward, and you are already doing that. Purnima Jayadeva is a very dear friend from the city of Mangalore, Karnataka. She is in government service, and she has been a clinical coordinator for the Medical College there as a master trainer, IUCD, PPIUCD, resource person for POXO and PCPNDT Act. So really a very hard-working person. And Dr. Alka Kuthe, consultant OBGYN, past chairperson amongst Medical Legal Committee. And human rights education. Wait a minute. Be on Alka Kuthe, please. Who is chairing? Yeah, sorry. Best Committee, Best Chairperson Award, Medical Legal Committee, National Adolescent Health Trainer. Welcome, Alka ji. Pleasure to have you here with us. Next, please. Yeah. Dr. Sushma Sinha has been an active worker in our committee. Thank you very much, Sushma, for always being there with me. IMA National President and Appreciation Award she has won. She has publications to her credit also. And I must say, she was awarded the Certificate of Appreciation by ABGH Hospital. She is District TOT Trainers, Contraceptive Care Around Birth, Lakshya, life member of these many organizations. Thank you for being here. Dr. Kalpana Apte, a very, very special entry for today's panel discussion, because she is where the action belongs within the NGO-GOI partnership. She is the Secretary General of FPA India, earlier used to be called Family Planning Association. It is fulfilling people's aspirations also. MPH Human Sexuality, Institute of Advanced Study of Human Sexuality is what is her another degree, Masters in Public Health, PG Diploma in Hospital Management as well. And her work involves managing large-scale SRH services, interventions in India, and mainly working with the GOI. So welcome, Kalpana. Thank you for being there. Next, please. This is a very special entry for us who will actually tell us how leveraging partnerships will help us to increase the met need. Leading telemedicine app is in his domain. He is the co-founder of doctors.com. Welcome, Dr. Saurabh Shavla. And he has featured, just a minute, please, just one more, amongst 20 most promising digital health startups in 2019. So I wanted to bring this innovative mind into our panel. Next, please. Of course, Anita needs no introduction to the delegates of Delhi. Very hard-working gynecologist. She's present affiliations are AOFOG as well as FIGO as well as the AOGD, and of course she is an ardent Foxian. Next, please. Yeah, do we have anybody else? Yeah, so there you are. That is my team of panelists. I will share my screen and a very, very simple presentation which will take us through some aspects of today's deliberations. 1 minute. Yeah, so I hope everybody is able to see my screen, and I would like to ask the panelists, anybody is open to comment. Why is providing family planning services information important in the COVID-19 pandemic? So in your understanding, there you go. Neelam ji, Sushma, please respond. Yeah.
Good afternoon, ma'am. Thank you so much for having me here.
Yeah.
Yes, COVID pandemic has thrown up many challenges because of the lockdown and because of restricted OBGY services and other services as well.
But providing the service is important, na? The family planning.
But in those times, we took up the challenge and we provided adequate services. As working in the public segment, we took up the challenge and we started putting up more and more of LARC methods. Mostly IUCDs and all women who were being discharged after delivery, they were being provided any one of the contraceptive measures. Nobody was sent without any contraception. Mostly it was IUCD. Chaya also did very well.
Yes, very good technical input there, the service provision. I want the audience to be reinforced with the idea of why is it important to be very, very, forceful about providing family planning service.
And moreover, during COVID pandemic, women have become more prone to unwanted pregnancies because of
correct. Yes, yes.
Yes,
And
it is because they were unable to reach the services of the doctors.
Yes.
That was also one of the reasons.
So we need to, because the pandemic is no way ending, no, Neelam. It is going to continue. Yeah.
Continue. So it is more important that they should be provided long-term contraceptives, and even on telemedicine, telemedicine front, they should also be given the suggestions.
And
or
eventually,
even on
the burden
contraception.
also should come down on the healthcare system, which is already battling with COVID-19.
Right.
So if we have more, emergencies with abortions, etc., it's going to be worse. Okay. Any factors to be considered before giving women choices in birth control methods? So Purnima and Anita, any of you could respond. What factors do you usually consider before giving the birth control method choice? Or yeah.
Can I start?
Yeah.
Ma'am, it is important. What is the timing of counseling? We have to check what is the woman's physical condition at that moment. What are the situations which are appropriate for whether the time is appropriate for counseling for contraception. And if the patient is coming for MTP, we have to counsel her before and after also. We have to assess her individual situation, her family circumstances,
correct,
and the potential barriers which are there.
Which are there.
And then,
Purnima, anything? Purnima has to speak up also. Purnima?
Yes. In government setup, where we work more, we have to consider other factors also, like what are the government policies and what the client needs. It varies, and what we are using now, PPI, CD, and post-abortal, this one contraceptions are now at the front. So we have to start telling at the adolescent level, when they come for adolescent clinic, when they come for antenatal, when they come in the labor. So all these things have to be considered, and their socio-economic status. We have to always keep that in background.
Yeah, so we all should become adept at constructing this trial, the Bidzer triangle, where we need to have the woman's profile, which is very important. The woman's profile, as all of you have discussed just now, her medical socio-economical
condition,
the context in which she is coming. You described the various life situations, the antenatal, postpartum, post-abortion, and then the method profile, the method itself. So this triangle, these three aspects quickly will give you the MEC choices for the woman, and you'll be able to offer it. Now, I just want to know that all of you have experienced that there are changing trends of contraception and abortion in these pandemic times. Have you experienced that there is more, misuse of abortion pills over the counter? How many of you have experienced that?
Yes, ma'am. As soon as the lockdown started, we started facing this problem. So many people were coming with incomplete abortion.
Abortion. So where is it falling? The contraception option is not given, or they don't know how to reach.
They didn't have access also. They didn't know what to use, and then over the counter availability of abortion pill made them rather use abortion.
What do you say, Kalpana, from the field? What feedback you got on this? Dr. Kalpana Apte.
Thank you. So from the field, there are many changing trends. That's true. We see that the methods which are provided at the doorstep, or whether women can access those methods easily around them, are being accepted more than the ones where they are supposed to be able to come to the clinic and get it done. It's fine, and I agree with the experts here who say that post-abortion, post-delivery, that is the time we can provide a long-term. But interval methods, long-term interval acceptance is going down because women are absolutely scared to come to the healthcare facility to accept a contraceptive method. And the second point is that the travel for women also in rural areas and others, because the restrictions on travel still exist in many areas. In many areas, they are not there, but in the mind, there you can say there is a little stop. So travel of women is becoming a little bit an issue. Overall, if you see the data in the health MIS, you will see that the access for even other healthcare services is going down, including contraceptives. So short term.
I would just like to say that since women were more confined to their houses, usually the husbands used to go to the pharmacy and pick up the MTP pills and give to their wives without thinking what is the duration and whatever it is. And so there were many more cases of incomplete abortion and bleeding PV and continuing since 1 month or 2 months, and they were coming for
Yes,
the
yes. So I think you have correctly answered that. Do women have better access and choice? And no, they do not have. And Kalpana, as you rightly said, many other health situations also have suffered a setback. But I have a personal feeling that this sector has suffered the worst.
Yes.
That is what is my feeling. So I think you agree with me, because it is not considered as a priority. It is not even considered as a health factor. So let us
Also,
not.
just to add, sorry, Dr. Shobha, that it is family planning, abortion, and all other sexual reproductive health services are declared as an essential service by the government of India.
Yes, correct.
Has not really made.
It has not been followed, because I get a feedback from the public sector as well that the services are impacted. I get from them as well. Yeah.
But it has not made the impact. They had been declared the essential services, but it has not made the impact on public itself.
Very correct, Neelam. So do Indian women in general also? Yeah.
Not only lack of knowledge, ma'am, transport was a big problem when lockdown was there. They were not allowed to move out of the containment.
That's what we have.
Even if they were aware, they were not able to attend.
Yes, Anita. Do Indian women receive adequate information about contraception? So NFHS 4 has already looked into it. Anybody, Purnima, would you like to say, those in the public sector? Yeah.
Yes, it's the information given to the people public is very less, madam, because whatever level it is, either ASHA workers, Anganwadi workers, our staff nurse, doctors, though we give information about it, it is not adequate. As you are showing, the permanent sterilization is more. We think we are concentrating on the permanent methods, but it is not the real factor. We have to have more of the long-term, long-term LARC. We have to concentrate on LARC also. But whatever, we will give information to ASHA workers, Anganwadi workers repeatedly. But reaching the women is very less. See that only 18%, 30%, 34%, very less. So we have to work on these things.
Correct. Health workers,
we have to work on this.
Female non-users about family planning is only 18%. It should be actually 80 to 90%.
Yes,
so talking more about contraception has become imperative, mandatory, necessary, and very, very important. So the pandemic effect is showing this in one of the surveys conducted by SRH, published in SRH Matters. So I am thinking that, if this is the countrywide scenario, 36% decrease in injectables, 21% decrease in IUD, has it really happened in your practice as well? You confirm this in your practice?
We have come across, because we are concentrating only on the COVID now. Even ASHA workers, Anganwadi workers, those who are doing more work about this contraception, they are concentrating only on the COVID now. So the distribution has come down drastically. So the pregnancy, abortion coming is more. And we also cannot do that work also because so many constraints. Even abortion, services have become reduced. So we are not.
So in discussing the problems, is it across India the same? Delhi also it is same, Patna also same?
Madam, I would like to just pitch in that I do agree that these have been less in these days, I mean in the days of pandemic, but I found that now women are more receptive to IUD insertion as well as LARC, injectable contraceptives.
Okay.
Because I find them that now they think that this is the opportunity when once they have come, they might not get it again. I mean, like that. So now they are readily accepting. More and more women are accepting after they have are undergoing an abortion, completion of abortion and all.
That's wonderful to know. So up to 26 million couples in India may face an unmet need of contraception and abortion services is what is the study is showing, and that I think repeatedly has been has been, informed to us today by all the speakers. Now, can I have some input on a more technical aspect? What is the best contraceptive method during COVID-19 pandemic? If anyone asks us, what should be our response? Anybody can take, Sushma or Anita or anybody.
Ma'am, again, the cafeteria approach is very much applicable here also. It can be customized as per her needs and as per her medical conditions. So the most useful has been PPICD and Chaya, where there are hardly any contraindications.
Yeah,
and
all modern methods are okay,
all
right?
modern.
All modern
Yes.
methods are okay.
And even
And
we
if
have
she is COVID
continued
positive,
to do
then
NSVs and ligations. We have been doing each and every method we have been adopting as per the requirement of the clients.
Yeah, we'll come to. So what we wanted to highlight here is most methods of contraception can be actually prescribed digitally also, unless they have got some medical problems, in which case they will have to visit the consultant face to face. If they turn COVID positive, they will be in quarantine, then the need for contraception may come down. Nevertheless, it is important to educate that mild symptomatic or asymptomatic COVID positive may need contraception, and in which case almost all contraceptives are okay, except for the estrogen containing pills, which we may have to carefully assess before prescribing. We'll go on to this case scenario. Mrs. RD and Mr. SD, busy IT professionals, living apart, meeting infrequently before, but now there is a lockdown and they have to work from home, and they are wanting to access contraception advice from you, and they call you up. They don't want to come to you, but they call you up. So have you been doing contraception practice and advising a new couple over the digital media? Have you been practicing telemedicine? Anybody can answer. Yeah.
Yes.
Anybody take it up, please.
Telemedicine has really become much more relevant in pandemic time. We are working in government setup. Despite that, on social platform also, we have to give them advice about contraception. So many couples, they seek advice regarding contraception. So telemedicine is now allowed even by all the medical.
Yeah.
Can I add, Shobha?
Yes.
Can I add, Shobha?
Mm.
Yeah. Telemedicine is now there are guidelines by the NITI Aayog, and it is a very well recognized way of providing services. We provided 50,000 and odd contraceptive services during the lockdown time through telemedicine. And through telemedicine, there are guidelines what you can do and what you can't do.
Correct.
Simply what you can provide, of course, for that couple is study. Condoms are absolutely very easy to use and easily accessible. Also, oral pills, if she is screened well, and then you can prescribe on telemedicine. There is a little bit discussion, but we have prescribed and it has been okay taken.
It has been okay.
Point up. Yeah, oral
Correct.
pill is fit for providing.
Yes.
Otherwise, other stuff, we need provider initiated stuff.
Yeah. There is often a doubt in the mind of providers: is a certification needed? So I think all registered medical practitioners can practice telemedicine, and they will come up.
Legal.
Yes. Yeah.
Now it has become legal since March 28.
Yes, correct. So the MCI has already put an amendment saying that it is legal to practice, but the same norms should be maintained. And I think soon they will come out with an accreditation, certification course. So I invite Dr. Saurabh now to interact on the next few slides, and I'll ask him about how has been his approach to this sector of service provision. And Dr. Saurabh.
Thank you very much.
Dr. Saurabh Chawla.
Yeah. Good afternoon to everyone. Thank you, Dr. Shobha, for the kind opportunity that you have bestowed. So not taking much of the time, it is, as you can see, that's accessibility, affordability, ignorance, and lack of focused knowledge. These are the, you can say, key problems that we have figured as a telemedicine provider in last 2 years. Accessibility, it is not only that you can say that people living in impossible locations are who are having such kind of trouble. Young adults, unmarried couples, every sort of person who has some sort of, you can say, taboo in their minds to visit a gynecologist for having, you can say, consultation on sexual problems or contraceptive methods. We consider it under this acceptability issue. Another aspect was the affordability. See, you can say, we have figured out that there are the people who can spend generally end up, they are, you can say, more aware about the entire contraceptive process. They end up going to the gynac and getting the consultation done. It is only a majority the people who are not, you can say, well educated, who are ignorant about it, and plus do have some sort of low socioeconomic background, who are the, you can say, the people who are more who require this telemedicine, or we can say who require this contraceptive counseling and other counseling about your other methods more. So these are the things, and lack of focus knowledge. Since we have social media, we have Facebook, Instagram, we see a lot of doctors putting up educational content on them on YouTube, but the problem is that it is accessible to everyone. We need to have a very focused approach, that who is the real person who needs this, rather than circulating it, just throwing information for public. So this is what I want to briefly talk about. So we had a collaboration, social collaboration with PSA India from last 6 months, and we were giving a free platform to PSI. They were getting some sort of queries on their website, and they used to get routed to the doctors that were enlisted by PSI on that. So we found that there were clicks, but those clicks were not converting to a consultation, to a teleconsultation. So we have people who want to know what needs to be done. They are aware of the fact that there are contraceptive methods, but they are not going ahead with they are not completing the cycle.
Correct.
They are not doing the consultation, and then they are not.
They're not completing the loop. The loop is still open.
Yes, the technical word, the loop. So we came up with the this concept of pro bono clinic. It's an American slang word which says free clinic. So we are, it is in a beta phase. We did it with 3 gynecologists. So what we are doing is that gynecologist, we have requested her to give around 2 slots per week, 15-minute slot for telemedicine, for teleconsultation, and the patients from the PSI are, you can say, forwarded to that doctor's profile, and they do a consultation.
So there is a link between the client request and the consultant, which you are able to connect. That's what you are saying?
Yes, ma'am. All the doctors who are doing telemedicine, link means that there has to be some platform.
There has to be an encrypted platform, actually.
Yes, when we are having a HIPAA compliant encrypted platform, the video consultation is encrypted and HIPAA compliant. So that is another technical part of things. So I was not taking that thing due to the shortage of time. So talking about this, we were considering going for a task force kind of thing for doctors who can give 1 slot minimum for 15 weeks, and they can give 1 educational video in language of their choice. So language barrier can be taken care of, and a consult can be done, a free of cost consult. We as a company are ready to take care of all the costs involved in this, so that under our CSR project, so that more and more people can take advantage of this.
Yeah, I think that is a very beautiful way forward for an organization like Foxy. Also, we must put serious thought into this offer that you have made, and I think you will absorb the cost of medicine delivery under its CSR initiative, is what you have told.
Yes.
So the actual cost of medicine is not getting covered, but the cost of medicine delivery is covered, or the medicine also.
See, I had we are in talks with government of Punjab right now, and for this project, we are in talks with they are ready to give 1 medical college a pilot project kind of thing. So currently, the government will take care of the medicine provision, but we have to deliver it. So we will absorb the cost.
All right. And now it is clearer.
Yeah, maybe NGOs can come up.
Saurabh, what you are going to do with the patients who are not techno-savvy? Like majority of our target.
I was coming to that. Yes. Anita has a point. So, Saurav, in the beginning, you said, a lot of difficulty you had in explaining that there are few couples who are in need, but they are belonging to low socioeconomic strata. They are not able to access. That is the population also that you wish to cover. Yeah, tell me.
Yes, ma'am, we have two-tier approach in that. So the first thing we figured out was that people don't know, they are more than 50% of Indian population doesn't know English, leave aside using a smartphone which has apps in English language. So the first thing we did was that we have translated our app into, currently it is in Hindi and English, but we are coming up in 10 vernacular languages. So we'll be covering majority of the population which speaks non-English language. Second thing was people don't have email IDs. So once you download the app, if it asks you enter your email, patient was like, I don't have an email, how to go ahead with it. So we chucked out the entire process. Now they just have to give a phone number. They even need not go ahead and you can say pick up an OTP and do anything. It will itself pick up the OTP from your system. Nothing to be done. Just enter your phone number and you can log in. So rest, your language is there. So that much of leverage we are taking, that you have to fill up the details. We have partnered with an AI company where you give your symptoms and within 60 seconds, it will tell you what kind of specialist do you need to see. So you need to go for a gynecologist, you need to go for an endocrinologist, depending upon the problem, that assistance is provided.
That's great. And your project is called? What you proposed for me?
Yeah, it was
Sampark se Samadhan.
Sampark se Samadhan tak.
Yeah. Sampark se Samadhan tak. So it was very attractive actually, the way you had coined it.
I like
and
to add
here you have in brief, you have mentioned
Yes,
your action points. That patient orders medicine. The NGO who acts as medicine provider receives the request. So there is an NGO here, and delivery partner picks the medicine from NGO location, and delivery partner I think is doctors.com, right? That's what you promised. You said you would deliver. And patient receives the medicine. So all the patient has to do is to open the app, speak to the gynecologist, get the medicine prescription from the gynecologist on the phone, and then order the medicine from an online pharmacy. Something like that, isn't it?
Yes, ma'am.
That will close the loop. So thank you so much for that input. It is it's worth exploring because it removes the element of a physical visit to the clinic. We will get back to you from time to time, and please feel free to give your input, Saurabh, in any of the further discussions. I also want Kalpana to butt in whenever she feels that she has a solid point, as she always has. This is Mrs. AB, who had a copperty inserted 5 years back. Probably this has been extended LARC concept has already been discussed. I just want to know your own experience, that if you are asked from a patient that what to do about a copperty which is getting expired, she doesn't want to come, how are you handling the situation? This is for Neelam, Purnima, Anita, Sushma.
Yeah, we have so many queries, ma'am, regarding property devices, and even regarding these LNG 380A also. The patients were, counseled on telephone itself that they can continue for extra 1 or 2 years with that, and the patients who had IUDs which were for 3 to 5 years, they were advised they can come for removal later on when the wave has COVID wave comes down, and meanwhile they can cover it up with some other
contraception. Yeah, so correct. So you have to give them the bridging contraception till they can come. And that can be any of the hormonal methods, and you can also open the basket of choice for her over the teleconsultation. Anything else in your experience, Neelam, or because copperty is one of the common methods and this situation may come to anybody?
Yes, I would also like to do the same, have done the same, that added some hormonal method to it. And apart from giving her assurance that it is not that at 5 years dot, it becomes non-effective.
Yeah, we can.
Is effective,
we can
but still,
offer
still
her
if you
the
want,
pills,
if you want,
injections also. Injections
Yes.
also prescription can be given.
Yes.
She can take. So
Right.
we come to that popular question as what family planning services can be provided on virtual platform. So Purnima or anybody wants to answer this, Sushma. What can you dictate?
So when we cannot approach the patient or patient cannot approach us, only thing we can just on the telephone or telemedicine we can give. The things are condoms, oral contraceptive pills, and emergency pills. That's it. Only on the through the phone we have to. And for that copperty, I want to inform we have to tell the patient which copperty we have put. Otherwise, we'll be in a dilemma. Whether it is 385, we don't know. So just for 380A, it is another 2 years. 12 years is okay.
Yes.
And for 250, 370, but patient many a times will not be knowing what exactly the IUD they are having. That is
so
very
the
bad.
primary care provider has to be very specific.
Yeah, yes.
They should give them a card on which it is mentioned.
And mention
that
properly.
Is very important. As
Yes.
you rightly said that 380 will take to 12 years, implant 4 years and LNG for 6 years. So they are the extended LARCs. But
Yes.
copper-bearing IUDs of lesser strength are not extended LARCs.
Extended, no.
So we wanted
Yes.
to give that message. Okay.
You
So
have to tell them the
yes.
exact time of expiry, like 2020 August. Please be careful. You have to come either for reinsertion or something.
Yeah.
Because they don't remember 3 year, 4 year, 5 year.
That is what I feel. Yeah.
बदला जाएगा. So that is the way we tell them.
And we can add on telemedicine, we can add Chaya and POP as well.
We can add.
Apart
So
from the
when I was
COPs,
speaking
POPs.
about, when we were talking about bridging methods, then these are all excellent bridging methods, beginning from barriers, both male and female, Sushma ji, as you said, condoms, male and female, and then the POPs are excellent bridging methods till the woman can come back and take maybe in a month or 2, she can take proper advice from you. And the other one is Centrum and Chaya. So you rightly said that they can also be included. So these are the scope of telemedicine services wherein we can counsel them to initiate, continue, also assess the risk of pregnancy in women who are very kind of worried about pregnancy, and the OTC preparations, A are refill prescriptions for contraception, and B is add-on for any troubleshooting. Let us go ahead to this. A woman who is recently delivered 10 months back but has fallen pregnant again, and she wants an MTP. So this is often the case now, unwanted, unintended, and she is in a containment zone. She cannot come. What to tell this girl?
It depends on the biology.
Yeah.
Period of gestation.
Early pregnancy. Let us think that it is early pregnancy.
If she's less than six weeks, then we can offer her empty pills. But if she's beyond that,
over teleconsultation? No.
No. Yeah, she'll need a bit of screening as well.
Yeah. So she has to come for at least one visit. So we can make it a single visit service delivery for abortion, right? Yeah. So once she comes, she fills up the form. She gets all the screening done. Yes, Sushma ji, what you wanted to say? Yeah.
Yeah.
But many a times tablets will be prescribed over the phone.
No.
Nobody will come. That is the problem. They should not do that.
No.
Yes, they should not do that.
Consent is necessary. The consent is mandatory.
Consent is mandatory. Consent is mandatory. Just like Dr. Patel said.
As we do for surgical abortion.
Yes. Yes.
So C, filling up the form C is paramount importance.
Form C.
Yeah.
Yes.
And at the same time, we can also counsel her for conception. So these are the situations.
Ma'am, please unmute yourself. Shobha, ma'am, you.
Minute. I don't know.
You are audible now. Yeah.
Okay. So all 3 vaginal deliveries and requests for a sterilization. She's not ready to accept any temporary method. And she says she'll wait till she can come to the hospital, but she won't use any other contraception. Dr. Kalpana, has this happened?
Yes.
Has this happened? Yeah.
Yes, it happens just so that the data tells us that women are aware of contraception, but about 90% of them are aware of only one contraception, and that's sterilization. It's a huge accepted method, and women do accept it. And we have started providing. Government of India has given the approvals. You can do up to 10 tubectomies in a clinic in one session with adequate testing. You have to do the pre-test. That is, you must also test her for a COVID-19 infection and provide it safely with the PPE kits and taking due care. It's a simple procedure, but we have to be very careful so that we don't spread infection. Otherwise, it can easily be provided. There's no problem if she is healthy and fit.
Correct. So it need not be postponed.
No, it need not be postponed. In fact, I would say that if it is possible to provide, let us provide, because otherwise she'll go back and she may become pregnant immediately next month, knowing the way our women have that kind of right to say no to sex and unwanted pregnancy.
Correct.
Let us provide. I think we must provide.
She can also be counseled for male sterilization, NSV as well.
Yeah, that's it. Thank you for reminding me that. We have been able to successfully convert about 10% cases into male sterilization.
Oh, wow.
So
That's great.
So we tell them that it's, abdominal surgery. For him, it's not so much. It's more superficial. It's easier for him. And then there have been changes, not drastic, but about 10 to 12% men have accepted.
At least that much is there.
It is really heartening to know.
Very heartening. That is why I brought Kalpana in, because she will give very authentic information.
Yes, it's a fact. With proper counseling, they do agree.
They do agree. Yes, Sushma, good that you brought it up. Now the women who are absolutely, we are not able to do sterilization. We cannot leave them. We have to give them a LARC method. This lady was given DMPA because she could not come to the hospital. The situation of pandemic did not improve after 3 months. The next injection, again, she asked for sterilization. So what I needed to know is, we do eventually provide this woman. I want to know the method which is being used. Is it okay to do a lab sterilization?
And we are offering mini lab to patients, but still there is concern about lab sterilization in a majority of government hospitals, because anesthetists are also not ready to help in cases.
So I think it is safer to do the mini lab, right? It is a good, method. What is happening, Kalpana, in your clinics?
Thank you for that. Actually, for us, it depends on the surgeon. If the surgeon is comfortable in mini lab or laparoscopy, we provide that. It is led by the surgeon, and of course the woman. Women normally don't have so much big choice on these two methods. Now the laparoscopy, there is just one thing. What we understand from the discussion, and Dr. Nozer Sheriar and other experts also have said that, and more than anybody, Dr. Atul Ganatra, we sorted out that problem, that when you are done with the surgery and when you are trying to kind of remove the trocar cannula and the air comes out of peritoneal cavity, that is the time which is the most dangerous for the anesthetist. And so we apply a classical filter at that time. If you keep a filter on that and allow the air to pass through that, then there seems to be a little less risk. We have been providing sterilization for last 6-7 months now. No, say June, we started in a big way. So about 3 months or so, we've done about 15,000 or so. We haven't had a single case across the country. We haven't had a single case of any surgeon or anesthetist turning positive, because we do the test before taking it. So you take pre-operative, you test her, and that seems to have helped us in avoiding the infection.
Okay, so pre-operative testing and using a filter at the time of removing the trocar. That has been
testing is mandatory. Pre-op testing is solves quite a lot of problems.
Yeah, so that is where it stands.
Surgeons and anesthetists feel comfortable, and women also feel comfortable. Government of India guidelines, it's not mandatory, but I think it's important. It's a safety mechanism for everybody.
So the Government of India guideline on lab sterilization is there now? Is it there? No.
It's not updated with these.
It's not updated for pandemic. That is what I found. And I felt really that, we could give a feedback that please update this, because a lot of people are having
because in Karnataka, we have not started the camps what we are doing. We have almost stopped, madam. For the past 6 months, we are unable to do any camps. and we don't need their anesthetist, only the gynecs are doing, but still we are not able to do because COVID is taking all our time.
Correct. We
Very bad
understand that
actually.
situation in Karnataka for sterilization has taken a back
It's
step.
going
We
to be the
understand
same.
that. That is why, yeah, that is why we must use more LARC. That's what we are, the message we are trying to give. That's what Sushma also said in the beginning. Kalpana, Neelam, all of them are saying, please push towards LARC. If no sterilization, convert them into LARC. But don't, let us not sit idle, because these are not women who can pick up from the basket of choice. These are women whose family is complete. So they will be looking towards us for a very, very, safe solution. So this is continuing to offer LARC to new users where possible with adequate safety preparation for the procedure, if any. And so I come to Mr. X and Mrs. Y. The reversal of alphabet is no pun intended there. A couple has had unprotected intercourse and want to avoid a pregnancy in the pandemic. So the options right now are also a basket, isn't it? There is the LNG pill, there is a ulipristal acetate now for us, there is a copper IUCD insertion. So what is in general, the experience of my panelists today? Let me begin with Kalpana, because this is one area where I find that the demand is very, very low. So has FPI experienced any demand from the field for EC?
So these days, after the lockdown, because we have foot on the ground, we have had these kind of demands where there was more demand for the EC pill. There was a rather demand, meaning people really, at this point of time, if you see on the ground, there is a lot of misunderstanding. People don't understand women. They get mixed up in abortion pill, emergency.
Yeah, they get mixed up. That is the problem. Yeah,
so all the pills, even oral pills, they get completely mixed up. So it is our people who have to, our field workers, ashas, who have to inform them. And access to emergency contraception is supposed to be very easy, but it's not. It's not easily available also in many areas and many shops as well. But yes, we did get, if you can get them into that window period where the EC pills are effective, then that is the
Yeah, I think there has to be a lot of advocacy for the pharmacies, because they also do not realize that these are not abortion pills. They also don't know the difference between the two. So there is a lot of scientific barrier here as to understanding what is an EC. Yeah, somebody else was talking.
Can I intervene?
Yeah, Neelam.
I think that emergency contraceptive pills needs a very big boosting. That means the advertisement as well as education and awareness, like MTP pills. These people are, so these people can giving pharmacy people giving MTP pills to their husbands, they can always tell them that, look, instead of this, you can use this, and they will be too happy to use it.
Yeah, one time solution, but come back for the next. Yes. What I just wanted to bring in here is prescribing an EC may on its surface look simple, but the problem is that EC also requires a lot of work to be done along with it. It's not just prescription of one drug. We have to combine it possibly with another quick start contraception, because otherwise the woman will go on having unprotected intercourse if we don't tell her about ongoing contraception. If she wants to wait for that method, you have to do a bridging method with a quick start. You pre-arrange the collection of EC pills. Sometimes, as Dr. Saurav has brought out, maybe we must have the drugs ready for them to pick up. Arrange for an IUCD insertion if receptive. Provide in advance other prescriptions of bridging method, of ongoing method, or further EC, and ongoing contraception has to be emphasized upon. So I just wanted to ask whether all this can be done on the virtual platform except for the IUCD insertion. So is it possible to expand our services on the virtual platform like this? If there is a query for EC, we need to give in this much of more input into the client. Anybody?
Yes, we can do that, ma'am. Definitely, if the patient is asking us on telephone, we must tell her कि भाई ठीक है, इस बार तो तुमको लेना है, लेकिन इसके बाद तुम्हें परमानेंट इसका इंतजाम करना है, इसके बाद इसको बार बार नहीं लेना है, और you have to be surely using some contraception as a definitive
Correct.
method.
And follow up of the next period, etc. They have to understand that this will not take care of a pregnancy. Yes, please.
All these
Anybody?
days,
Yeah.
all these days we were talking more about IUCD and permanent methods. Now we can take this platform to tell about EC, which is very much neglected. Easy pill available in the government, but nobody takes that. I hardly get any patient asking for easy pill.
Correct.
So now we can take that opportunity to educate the public more about these easy pills.
Correct.
I have found that when some woman knows about EC pills, they keep on, especially adolescent group, they keep on repeating it. They don't take up regular contraceptive.
Correct.
And that is the worst part of it.
So
Correct.
that is what
to
we
add
have
to
to.
what Dr. Neelam said, actually the GOI advertisement was very confusing. It showed that whenever you have any coitus, you can just pop in a tablet. So
Yes.
the IC material and the advertisement need to be, properly. It should be designed by some doctor or somebody.
Yes, yes.
Because
It is the onus is on us, Sushma. We have to do all that work now.
Yes.
Along with all of you, I'll have to do that. So
Yes.
help me with all of that. Now this one, the contraception which can be started after an EC has been outlined in this chart, not within the purview of this panel discussion, but there are directions as to when you can start a particular method after a particular EC which has been used. And as you can see, the copper T, if it is inserted within 5 days of unprotected intercourse, will actually cover the subsequent acts and also will be an ongoing method. But then it requires a physical interface between the provider and the client. So that becomes difficult. So we need to become adept in prescribing hormonal contraceptives. We shall go ahead to this 18-year-old. The hot topic of today is adolescent contraception. And these are the people who are tech savvy, and these are the people to whom we can source our digital platform. So this girl is also having acne with a high BMI. Anybody wants to comment on the management, and we'll go on to the digital platform with Kalpana and
She
with
needs lots of counseling related to her diet and exercise pattern.
Yeah.
And her activity is also required. And the method of choice is exercise to bring down this BMI. Correct. But if she needs medication because she is sexually active, so COC is the drug of choice for PCOS.
Anything else? Anybody else?
Cyproterran acetate should be given together with her condoms. I mean, she should be
dual methods. So you brought out the dual methods. You brought out the dual methods, but please be informed. Cyproterran acetate is not an kind of approved medication.
Yeah, that's true. But she's her acne and BMI made me.
Yeah. So drospirenone containing or desogestrel containing. Sure, she needs some kind of COC prescriptions for long duration lifestyle modification, as you have brought out. I want to know from Kalpana, the adolescent, they have a very rich history for adolescent and youth friendly services. Kalpana ji, aapka experience for the young.
Yeah, I completely agree with the expert advice given. The experts have spoken, and that is how we normally do that also. Only thing is nowadays we do have fourth generation oral pills, and in case a woman would want to use that for this condition, then there could be some oral pills which we may be able to prescribe. It may help her, in fact. Yeah. But otherwise, yes, there have been a lot of, particularly urban girls. It's not only the rural girls, urban girls, more PCOS and obesity, which is again nutritional related issues. They are not well nourished, but they are very obese, and then we all know that. So this is what we are beginning to see.
It is also a malnutrition, the extra weight.
Another important thing is, ma'am, to screen this adolescent for STIs and HIV, because this gives us an opportunity. Because she has come to us, we must screen her, and we must counsel her regarding safe sex and responsible sexual activity.
Dr. Saurav, can you come in and tell us about the approach to youth with your platforms? Has there been any experience? Dr. Saurav is there, or has he left? Yeah. Okay, can we see Dr. Saurav Riju? Can you help us? It seems to have left.
Yes, ma'am. I think he has left.
Sure. Okay, so we will also be concluding in another few minutes. One thing which I wanted to highlight about adolescent contraception is by research it is possible now to promote abstinence as a method, and it is surprising and rather actually in retrospect it is understandable that couples or girls who start an early sexual debut are more kind of receptive to the idea of abstinence as a method of contraception. So periodic abstinence in their relationships is actually good for their self-esteem and their health, and they understand it very well. So that is another way, and it is also a part of the lifestyle modification. So this is a
Madam,
woman
can
who
it
has
be, is it sorry, is it abstinence, or is it that they should be told about I mean fertility period, or abstinence during the fertile period?
It's a safe period. No, Dr.
Safe period.
Neelam
No,
ji, it is no.
Total abstinence.
It is periodic abstinence.
Periodic abstinence.
That has been
Okay.
researched and found to be
Okay.
very, very successful and
Okay.
very healthy for long-term outcome of the adolescents who have had an early sexual debut.
Okay.
So this is a very straightforward 39-year-old with AUB. I think Charmila covered this, but I just put it there for a matter of completion that 39-year-olds still requiring contraception. So we should not fall out in giving. Yeah. Anybody wants to say, or we shall?
ऐसी ड्रेस में रहते हैं.
Yeah. So all of you want to respond with LNG IUS for her?
DMPA can also be given, ma'am.
DMPA can also be given. Yeah.
Yes.
Anybody?
Yes.
And we must remember that that if she's on lipid lowering agents along with, then we must consider the efficacy of OCs has to be told to her.
Yeah. So I first hand is she should come in for a detailed investigation of that HMB.
Yeah.
You all agree with that? It could be imaging, it could be histopathology, it could be other things. So let her first get investigated. When we have ruled out any serious problem, then of course LNG IUS will help. The other drug which helps also is low dose oral contraceptive pills. It might seem paradoxical, but when the estrogen doses are low, even NICE recommends it as a first line treatment, especially for ovulatory DUBs, ovulatory where there is no anovulation. In those conditions, it is possible to prescribe.
Yeah, it is category 2.
Yeah.
It is category 2 even beyond 40 years.
Yes. COCs can be given. And in context of the AUB also, NICE recommends as the first line treatment, COCs can be given, low dose COCs can be given. Okay, so I have a couple of questions on program implementation and policy making. So whoever has had administrators experience, administrative level experience, like Kalpana, maybe Sushma, can you please tell me what kind of programming will help in these times for family planning? The last two questions, we have passed 2 o'clock, so we'll wind up in another 5 minutes. Yeah,
so much.
program implementation. Kalpana, anything you wish to say about programming?
I think it's very important at this point of time. We have now understood that the public sector is completely full and flooded with managing COVID cases in many cities and towns. Therefore, the focus on family planning and planned services as well as on preventive work has been on a side. The nature of the infection being such as I think Dr. Purnima has just said very rightly that in Karnataka, no camps are going to be happening. And that is going to be the truth of the matter, that the family planning services, which have been very seasonal in India for the winter months of sterilization, is not going to happen this year. The complete focus on what we used to have on sterilization is not going to happen. And therefore, we have to see that you empower ASHA. You have to see that the long-term methods, reversible methods need to be completely pushed more than anything else. And our push on the sterilization will have to be altered and somehow balanced by other methods. At this moment, the whole machinery actually is looking at COVID. This year, we will have very, very poor performance of family planning and an accelerated, you can say, unwanted birth numbers.
More births and more abortions.
Availability of contraceptive methods has to be ensured.
Correct.
In Delhi,
that is in the policy. Correct.
Yeah.
That is in the
But
policy
our
making.
program officer made it very, very sure. Delhi government program officer made it very, very sure that at no point of time any of the contraceptive is not available in hospital setup.
Correct. You brought out very well the next question, which I was trying to pose, that policies also should be in place, women-friendly policies, so that they need not go back from the hospital without the service. So that is important. Now, this is a concept for private clinics, which I have in in my perspective, that this will help. This is what Dr. Poonam Shivkumar also was mentioning. And this is about having a dedicated cubicle or a clinic on the OPD floor of every private hospital, wherein, because the government already has it, I believe, in most of the places, where only contraception can be spoken with the help of trained counselors. And the clinic should be equipped with as much material as possible about the different methods, so that the patient can get a feel of it. We can even generate nodal training centers for such counselors. And of course, we can bring down the cost related to such clinics. So that is the improvisation which I had tried to propagate. I am still doing that. And this can also be digitized. This kind of family planning special service can also be digitized, so that once the consultant has generated the MEC criteria, the basket of choice, then the matter can be taken up for further counseling with the couple in the eye care clinic setup. And every phase of a woman's life can be tackled, as we have already spoken. It can be clubbed with adolescent preconceptional, antenatal, postpartum, and abortion care, premenopausal interval agents, along with immunization, with PPT, CT, RTI, STI clinics, everything. So this will help if we have a skilled counselor who uses a gather approach, because the gather approach may take some time for the consultant to put in place. Nevertheless, the client will also have an opportunity to look at all the methods herself and get a feel, and the fear element may remove. So as a final input here, what are the barriers in providing choice is what I wanted to ask the panelists. What do you think?
I just wanted to add to your vision.
Yes,
I think
Sushma.
both in private as well as in public sector, each strata of healthcare worker is a champion for providing quality family welfare services. Like everybody should be sensitized, right from the guard to nursing orderly to A&M to nursing officers to doctors, because the patients has the last interaction with the doctors, and they hardly listen to us. I mean, they are more receptive to the guards. The client that we have, they are more receptive to the guards, and therefore we should be, sensitizing the
trust
guards.
element is there. Trust element with other
trust element is
paramedical health.
So we do give frequent talks to the guards in small groups, and the nursing orderlies. Everybody is sensitized. Even the dietitian, even the who provide immunization in wards, in labor room, everywhere.
Everywhere they talk contraception. That
everybody
is a good
should
thing.
be. It is not only related to OBGY. Even in the medicine OPD, even ING OPD, people should be talking about.
When pediatricians help us, when the children are brought for immunization, pediatricians are sending mothers.
Yeah. So the barriers can be there at the policy level. We have just spoken about friendly policies. The national program level, the focus which we have been discussing about COVID. The client level, of course, the myths and the huge influence of the family. Most of you have been telling about the family influence, and at our level. And as Dr. Usha Sharma rightly said, we have to do that work. What she was trying to tell is, unless we have a conviction within ourselves that this is going to be good for this woman, the exact body language and the verbal language will not come out. So we have to make away with that, do away with those misconceptions. We have to give time. for this service. Let us just as a salutation to so many mothers who are dying due to this lack of service, let us just discuss this Mrs. Unfortunate 22-year-old dies from abortion complications 5 months after childbirth. Just 5 months back she has given birth and now she is dead because she had an abortion and complication. She was given an option of insertion of PPI-UCD at the time of delivery in the healthcare where she delivered. She had a hospital delivery, but the husband has refused. Now, who is responsible for her death? Can we just blame the husband?
Unfortunately, we are responsible for her death because we did not provide her timely information and counseling.
Yeah.
And the repeated time she visited hospital, but we should have been sensitized enough to tell her about the modalities of
choice. She was not given a choice. When the husband is prejudiced against IUD, she should have been given a choice.
So gatekeeper concept is there, ma'am. Shobha ma'am, gatekeeper concept has to be dealt with.
Correct.
Mother-in-laws, husbands, whoever is coming, we call them gatekeepers. So
They
we
are the
have to do
gatekeepers.
counseling of gatekeepers.
Correct. So
Yes,
healthcare
I also agree that not only doctors and the healthcare providers are, the woman's family is also responsible for her death.
Yes,
it is. She might not have been. I mean, she was given the consent of choosing anything. That may be because women are not usually decision maker. These young women, their mother-in-laws are decision makers.
But all of you agree.
Mother-in-laws.
All of you agree that such deaths are happening in the pandemic time. All of us agree.
Yes.
We agree that such mothers are being lost. We all agree.
We
and
all
these are the
agree.
ones responsible. The healthcare facility as well as the healthcare system, the husband and the society. Everybody is responsible. Okay, so this could have been done for her. This entire table could have been done for her. And also these methods been repeatedly telling these are the methods we can put in place before she gets discharged. She could have had a PPI-UCD, she doesn't want. LNG-IUS, she doesn't want. She doesn't want intrauterine method. What about implant? Can be placed before discharge? What about progesterone-only pills? Can be given to her before discharge. She can start taking them as early as 1 month after delivery. So then where do you, that brings us to the human rights issues, which is the most neglected in family planning services, and where do human rights issues fit in? I will just allow one comment from Kalpana so that I can end this. Because I already have put no coercion, offer unbiased, do not deny information, and offer services or refer appropriately. So these are the 4 key things to ensure human rights. Kalpana, your feeling about human rights in family planning.
It was a superb panel, and kudos to you for ending it with human rights issue. Contraception is a reproductive right, which is basically embedded from a very human rights perspective. So a denial or an inability to use a method, I completely accept, and I salute you to say that it is primarily the healthcare system which is responsible. And you have a wonderful panel, Shobha. Really, it was excellent.
Thank you, Kalpana. Thanks for joining. Your presence made it more so.
One thing I want to say, Shobha, your eye care program, which you have unveiled just now, I would be very happy to provide training to the nurses or whoever private provider if they want their paramedical trained in counseling. We will be very, very happy to do that as your partner. And let us know. We also have guidelines on counseling for family planning. We'll be very happy to share that along with the
Wonderful. Wonderful, Kalpana. That's what I was looking for. You know, we were talking about this yesterday and I was looking for.
So we are there for you. Anytime, let us know, and all our resources are yours.
Yeah. So from our perspective, we need to ponder on our clinical practice, how much time we give for this, for giving them choice in contraception, how much time we give in discussing, how correct are we in assuming that patient cannot make family planning decisions themselves, because sometimes they do have something in mind. We should not oversee that. We should always talk with them long enough to find out what is their wish. Maybe that will improve the uptake. Do not forget to discuss at every opportunity. Neelam has told that, Sushma has told that, Purnima has told that so many times. Every opportunity should be utilized, every interface. That is also the underlying core of Foxy Eye Care service, that no opportunity is lost. Contraception, after all, is an individual choice. So we cannot really force her, but we can create an enabling environment, and we must dispel the myths, misconceptions. And while offering choice, we must individualize. We should have the Bitzer triangle in place. Okay, we must push past the pandemic by ensuring accessibility, as Dr. Saurav also said, changing the conversation. All of you, we as agree, we have to make more noise. Somehow we have to make more noise. We have to use everything, information services, training and referral. Thank you so much for agreeing for my concept. I need the help of each and every one of you to make some change in our outcome. And this community mobilization, television, social media, radio, community, TV talk, any of you who have access to these media, please tell me. We will start doing that and strengthening the infrastructure. That is what iCare is about, and relaxing restrictions on the quantities. This is what was discussed earlier. Anita said, I think that we must have more availability, supply chain. So if you meet the unmet need, we can prevent more than 1 lakh maternal deaths each year. And that is no mean feat, ladies and gentlemen. That is what we are here for, to save lives. Well, it is difficult to make an impact, but not impossible. We should have short-term and long-term goals. Long-term, of course, is population stabilization by subsequent governments. It has to be taken. We need to see if partnerships are possible, because just now, as Kalpana has said, she very rightly brought it out into the open that alone Foxy cannot achieve. We need to have skilled partnerships on a scale of difficulty 1 to 10. Population control is a full 10. Don't you agree?
Yes, 100%. Of course.
Everybody agrees.
Everybody
it's a full
agrees.
10. It's easier to do a TLH. It's easier to do an oncosurgery. It's easier to do something complex, a difficult instrument.
Even ligation is easier to do rather than
to do. But otherwise, it's a full 10. So that is the reason. We have to be ready and we have to be willing. We have to be willing. So closing remarks, a supply side constraint to be removed. We need to have an electronic medical register. And that is how somebody said that they need to be sent reminders. I think Purnima and Anita said that they should be told when it is getting over. Knowledge gap to be filled, ways of digitization. Create an agency for women. Women need to be convinced. Change the conversation, cross linkages, elementary concerns will still persist, and demand generation is crucial. Educate them so much that they start asking for it. Partnerships are essential. Thank you very much, all of you.
And thank you, Dr. Shobha, for giving me this opportunity to being in this such a good and excellent panel. Really enjoyable.
Thank you.
You are also part of the panel.
Thank you for sticking on till the end, and wonderful people. I think we are all like-minded. We should stand to achieve something. We must. Yes, Kalpana, lovely to have you, and you are becoming a fast favorite in Foxy. Thanks, Bharti, for being there.
Thank you so much. Bye.
Yes, Sumit there.
Bye, everyone. And Dr. Shobha, very nice panel. I have heard all panel and all panelists. They done really very well and very interesting question and very interesting way. So Dr. Shobha madam is whole passionate for family planning, family welfare in very varieties of way, horizons, like master of family welfare.
अरे तुमको मालूम है ना भारती, कमिटी ले लिया, काम नहीं करा तो बहुत मार पड़ेगी. खुद किसी से नहीं पड़ी तो we ourselves will keep feeling that we got a chance and we didn't make any difference. So it's not about trying to achieve something great, but trying to do whatever is possible, because a lot needs to be done. So Bharti has always been there with me, and we have done programs together so much. We are going to continue to work more and more.
Yes.
And I think that is important.
Actually, it is more important to how to address these people who have less educated and are unreachable. Because the people who are savvy, tech savvy, and all this, they don't need so much of persuasion. They ask themselves. But these people who are, and they produce more children also. Sorry for extra commenting.
No, you are right. Just yesterday, I think who was Dr. Amrita was sharing from me from Mangalore, same place where Purnima comes from. And she was telling she is really fed up because 3-4 children, they are not even 3-4 cesarean, but they are not ready for sterilization.
Yes.
So it is. I think
I
Bharti will
also.
have very good experience on that,
Yeah.
and you, Neelam from Bihar, will have very good experience.
Yes,
How
I do have.
resistant they are.
Yes,
to
how
the idea
resistant
of
they are.
stopping procreation. Yeah,
I
And
really get
contraception
irritated.
is contraception is one aspect in which we really need to build up our counseling skills.
Yes, we
So
need
that
to
is
do
also
that.
very important.
So
That's what I say, for a successful program, it is all about counseling and counseling. And
Your talk was very good, Mridalini.
Each one, doctor, it should be a part of our curriculum, and it should be emphasized when interns, they should be emphasized, and everyone should be involved in that. Without counseling, whatever we do, we will never reach our goals.
We'll never. So a couple of things I just wanted to announce as a committee. So are the audience still linked in, or is it over?
Some of them, yeah, they are still
Okay, no
linked in.
problem. No problem. There are a couple of things. Anyway, my young soldiers are there, Kavita and Riju, and I have come to depend so much on them. And they are involved in some other things, you know, they are in infertility care and all, but I drag them to this platform ever so often.
Fertility care.
Everybody is doing infertility. Everybody wants to give more children.
We are trying to
They are in fertility care now.
Fertility care. So now they are in fertility care. So actually, when we check with our postgraduates also, when they finish and they say, what do you want to do? So till very late, they were all telling, no, I will go for training for ART, or I will go for training for endoscopy.
Yes.
But you know, 1 out of 20 might say, madam, I want to join medical college. I want to teach. I want to save high-risk pregnant women. All that only very few will say. But so far, nobody has told that they want to give quality family planning services.
Family planning services.
And that is because, you know, we have not emphasized on that most important part. Yes. So the committee has started Sankalp traveling family planning workshops to be conducted in medical colleges. We have started from Dharwad in Karnataka. And Amrita Chaurasia has been very graceful in giving me time in Allahabad. And there is some talk about Delhi also. And whoever is in medical college, please come forward and take this.
medical college also. Take my medical college also.
कौन बोल रहे आप ना जरूर
Yeah,
आपसे
Muzaffarnagar
तो
and
पूछना ही
Meerut
था
Medical
मुझे.
College together we
Yes,
in your
we will
Sankalp
do.
program.
We will do.
We can. You
मैं
can
आपको भेजती
come
हूँ,
to
mail
Patna
भेजती हूँ, आप
also.
मुझे dates दे दीजिए. Patna also.
Patna also. I will talk to the people who are there in medical college to
Please,
give time.
Neelamji, please.
Sure.
So it will be done in 2 parts. I have divided the condensed and divided the part into 2, and we'll get 2 ICOG credit points. We'll give a certificate. It will be for PGs. It will be for staff. It is related to college. College digital platform if possible from the college, so that we don't have to spend more amount, because we want to do more number, because their curriculum is lacking today. Postgraduate education has taken a back seat. Let us at least reinforce this part for them, and let them carry it forward in their hearts. Whether they practice or not, it is their fate and the country's fate, because they are the gynecologists of tomorrow. So we thought from the committee that we'll do this. I will require all of you to be faculty in turn, and I'll build up a faculty base. We'll share presentations. We'll make it simple and understandable. So please be with me for that. The other thing was, of course, Foxy Eye Care clinics. If private hospitals can come forward and start this, like Poonam has started in her medical college, maybe it will kind of make enough noise to bring about a change. So I will keep in touch with all of you and share my work, and I will appeal all of you to give some time for this committee. Let us work together. And
Madam, I don't know why, but really I sometimes feel, I just want to share that if government, we have been so much motivated on institutional deliveries, that if government gives disincentive, I don't know however, on third pregnancy, third delivery onwards, something which is actually government's policy decision, we can't do much about it. But perhaps then people will be I mean, they may be distracted from third pregnancy or going for third pregnancy. I don't know, just I was thinking.
Means they don't give them. incentive for the third
Yes,
one. It's there
yes,
for the third
yes.
one. It is there. It's not
Yes,
there. No,
yes.
JS5 we are giving to all now.
Only
JS5 we are giving to all actually now.
Acha, acha.
That 2 births have been removed and we are giving to all institutions.
To all. That is to bring down, because
We want to have
bring up
institutional
the
deliveries.
more
to not
institutional
have
delivery
deliveries.
rate.
Yes,
Because if
yes.
they feel that if they make it 100%, because see, Neelam, once she is pregnant,
Each
it's a
pregnancy
foregone
counts,
conclusion she has
actually.
to deliver.
Yes.
Yeah,
yes.
each
So,
pregnancy
and
counts.
she herself is not the only one at fault,
One.
or family
Yes,
only
right,
is
right,
not at
right,
fault. So it's
right.
like punishing them for
Yes.
something which is not. And then if they are in institution, at least we have some opportunity to put a break
Yeah,
there.
that's a good part of it.
If they go and deliver at home, then kya, wo bhi nahi
Yes,
kar
yes,
sakte.
yes.
So,
Right.
I don't think that it is an easy task for the government also. And as I can see, the government machinery has really been very active in the past 2 decades. All of you are from public sector, you know much better than me. Bharti has such volume of work. I really admire her volume of
Can
work.
really vouch for it.
तो ये लोग तो सब बहुत कर चुके हैं. So then
I can understand.
They are also doing so much, no? But still, there is a leaking bucket phenomenon.
Oh yes.
So, congratulations, Dr. Mrinalini and Dr. Shobha Goody, madam.
Oh,
Wonderful.
thank
have
you.
done good
Okay
workshop.
then.
And Dr. Kavita and Dr. Riju, they have conducted very well in
Very
coordinating
well.
I must
group
thank
and
them.
all communication. And thanks to all AOGD.
Yeah, I think Mrinalini has to say the vote of thanks before.
Yeah, as
I
all
should
good
stop
things have
talking.
to come to an end in life. So this is so as this workshop. And good take-home messages have been that we should not lose any single opportunity and give counseling and provide services wherever possible. And important message, it has not only to be a ladies counseling, but couple counseling, and more importantly, a family counseling session should be there. And we should take in the pandemic means of telecommunication and other methods should be advocated. And only that way we will be able to overcome this pandemic situation and work towards achieving our Millennium Development Goals. First of all, I would like to thank our chief guest, Dr. Alpesh Gandhi sir, President Foxy, Dr. Ragini Agrawal madam, and Dr. Atul Gatra, vice president, to accept our invitation and take time out of their busy schedules. And I also AOGD for providing us this opportunity to host this workshop. My sincere thanks to her. And also thank Dr. Shobha Goody ma'am for her guidance at every step and being moral support. And my special thanks to our senior members of the faculty, Dr. Basab, Dr. Sikdar was unfortunately not able to attend, and Dr. Atul also. And our committee chairperson, Dr. Ramni Devi, Dr. Bharti Maheshwari, Dr. MC Patel, our stalwarts, Padam Shri Madam Chandravati and Padam Shri Dr. Usha Sharma ma'am, and all senior colleagues like Dr. Meera, who were on this occasion, Dr. Poonam Shivkumar, Dr. Radhika, and all my panelists. It was a great treat to hear such a lovely panel discussion from Dr. Sushma, Dr. Anita Rajoria for their participation. Dr. Neelam, Dr. Purnima, Dr. Alka could not join us, and Dr. Kalpana and Dr. Saurav, particularly giving us a word about telecommunications. Here, I would also like to thank both my compares, Dr. Kavita and Dr. Riju, for doing a wonderful job and for their unflinching support and coordination. And not to forget the IT team behind the scenes, and whose flawless support made this workshop a grand success. And I also thank all my delegates for the active participation and stake in the end. We had 300 plus delegation logged in. We started in the morning early, and this was a working day. Still, we had 300 plus delegates. And once again, I thank you all for your cordial cooperation. And I think we move to the end of today's seminar. Thank you all very much.
Meera ma'am is here. Meera ma'am will like to say something at the end. Yeah.
Meera ma'am, Bharti ma'am,
special thanks. Special thanks to Meera ma'am for staying till the end and boosting our morale. Ma'am, that shows your dedication to women's healthcare and to Foxy.
And AOGD ko or whole of the organizing team and lovely faces seen over here. मैं 1 घंटे के लिए जल्दी से सीधर करने गई थी और जल्दी से मैं आ भी गई and I find that this program went off so well. बेबी निकालने के बाद मैं 1 भी मिनट नहीं रुकी and I am back again. I think
PPICD डाला कि नहीं?
Thank you so much, ma'am.
I must come back on time.
Ma'am will give Centroman or
मुझे बहुत अच्छा लगा, मुझे बहुत अच्छा लगा, और आगे भी बड़ी बड़ी जो एक्टिविटीज कर रहे हैं उनमें आप लोगों को, सब लोगों को, एओजीडी को खास करके, आई कैन सी भारती सिटिंग ओवर हियर एंड होल ऑफ द एओजीडी, लवली फेसेस, एंड कविता, डॉक्टर गुडी, please, please, Poonam, please join us when we are conducting this women empowerment session, and it will be addressed most likely by senior faculty members and senior ministers of the country. तो आप लोगों को, सब लोगों को बहुत तेजी से उसमें पार्ट करना है, and I will write it down on the Foxy forum कि आप लोगों को put 2 lines only. What do you feel about women empowerment? And 2 lines you have to add. So I want to make a big कविता को और मृणाली को इनका पूरा भार दे दे. एओजीडी की प्रेसिडेंट हमारे सामने बैठी हुई हैं, आप लोग दोनों मिलकर के just be part of it. And thank you once again for a wonderful session. I really loved it. 90% मैंने सुना है, 10% नहीं सुना होगा. So भारती, डॉक्टर गुडी, देन कविता को तो हम बहुत कस के भी ट्राई कर चुके हैं, जहां जहां इसको लगा देते हैं, बेचारी बहुत तेजी से करती है.
All my pleasure. It's all your blessing.
So just do it, because you have to go a long way. Our president has done a lot, and lot big has to be done in the coming years also. हम लोग को ये नहीं कि हमारी एक्टिविटी बंद हो जाएगी.
नमस्ते मीरा मैम, नमस्ते.
I think the service is
inspiring. आप जहाँ भी आती हैं बहुत अच्छा लगता है, and we all again more and more motivated to work better. Thank you, madam.
Thank you, ma'am, for your very inspiring words, ma'am.
Yeah.
Thank you. Thank
So
you all.
I just wanted to thank Meera ma'am for all those blessings.
Thank
you, ma'am.
Thank you
Means
very
a great deal. Means a great deal, because Bharti has been, has been with all of you since her childhood, let me say, as a doctor there. But I am from the South, and I was not exposed to all of you. But now I feel as if, I'm so blessed to have you as seniors.
डॉक्टर गुडी, you are very much exposed. अभी लखनऊ में हम लोगों ने बहुत कुछ किया है ना.
बहुत कुछ किया है, साथ में पैनल किया है, कितना जम के किया है.
सारे साथ तुम्हारे साथ रात भर बैठे हैं, ऐसे कैसे नहीं एक्सपोज है? और क्या
नहीं, मतलब अभी है ना मैम, पिछले 5-6 साल से छुट्टन से तो नहीं था. थैंक यू Riju, and thank you Kavita.
Have lovely lunch.
Thank you. Thank you, ma'am.
Thank you.
Bye.
Bye everyone.